Morning, friends. Gives me a great pleasure to welcome all of you for this meeting on cardiology beyond guidelines. It gives me an immense pleasure to invite everyone for this meeting. I think we are flooded by guidelines, but all of us know that common sense medicine trumps all the guidelines. So we have a mix of young and old, very seasoned clinicians and very bright and aggressive interventionalists. We try to bring them together to kind of find a pathway where the patient benefits the most from this. As cardiologists, we all share a common goal that patients with cardiovascular disease, we should provide the best for our patients. And I hope and pray that this meeting will help us to kind of further our knowledge so that we can take care of our patients better with not only the latest that is available, but also the good old traditional system of medicine which has fostered better patient care over generations. And while it's a very important day, it's also a very tragic day today because one of our beloved cardiology colleagues has succumbed to a sudden cardiac arrest yesterday. And Dr. Mohan Nair, I think all of you are aware, he's very enthusiastic and intelligent, hardworking cardiologist, interventional cardiologist and an electrophysiologist who had kind of distinguished himself in these fields and has won the love and affection of several generations of the students whom he has mentored, and he has treated several patients. As a mark of respect, I would like to just stay 1 minute in silence before we start the meeting. Please be seated. Thank you. May I request the chairpersons for the first session, Dr. Ashok Kumar Dash, Dr. Johan Christopher and Dr. Bhairavi, to come over and occupy the stage, please. Can start with the proceeding.
Morning, everybody, and it's a great morning. And respected faculty, a lot of my teachers are there in this room, my colleagues. It's a great way to start this morning, and we'll be starting this session as a session of imaging, advances in imaging. And it's a great honor for me to introduce a very close friend, Dr. Madhavi Kadyala, who is a director of cardiac MRI and CT at the Tufts Medical Center in Boston, Massachusetts, United States. She has a keen interest in atherosclerosis with CT and also myocardial perfusion imaging with MRI. She's also an assistant professor at the same hospital, and she's been nominated as a fast-track cardiologist for leadership by the ACC. Over to you, Madhavi. Incidentally, Madhavi has just completed a session at the ACC, and she'll be joining us live, I think, from New Orleans, if I'm not mistaken.
That's correct, Jaran, thank you. Can you hear me well?
Yeah, you're audible.
And you can see my screen.
Yeah, slides are perfectly visible.
Okay, great. Good morning, everyone. It's a great honor to be here with you all in Hyderabad. I am presenting from New Orleans. We just finished a leadership conference in Women's Mid-Career Leadership Program. So the topic that I was given to discuss was recent advances in cardiac imaging. I'm going to try to wrap it up, all of it up in the next 20 minutes or 15 minutes. As Johan said, my research interest is in quantitative myocardial perfusion. And let me go back a little bit in the past before I go forward. So my interest in cardiology actually spurred in Hyderabad after my medical school in Siddhartha Medical College. I did a month of work in the CCU and back then in Medicity, and this is a book that I carried it from back 25 years ago. So it's an inspiration that I found. I think I hope some of the teachers that I learned from are also probably in the audience. I can't tell, but this is my interest actually stemmed right here in Hyderabad. And 25 years later, I'm now a multimodality cardiac imager. And if you ask me what that is, and and like Dr. Johan Christopher, I do cardiac CT, cardiac MRI, echocardiography, and I used to also do nuclear imaging, which because it's just difficult to maintain certifications in all of them, I recently gave up nuclear imaging. But this is the field of imaging that we are practicing here in the U.S. And I don't know if there is a major turf war going on, but there are some bar brawls that happen between the different imaging modalities when we ask a clinical question, which imaging modality would you perform? And there's a kind of a turf war also within the landscape of imaging. And I won't go into details, which is not relevant for this topic. But what I wanted to remind was, instead of picking which imaging modality, we do want to pick the right tool for the right job. So in order to do that, we'd have to know the strengths and limitations of each of these modalities. And cardiac MRI has multiple different sequences that one can acquire. And here in this slide, you're seeing various different imaging sequences, including not just function, but also where images, what we refer to as dark blood images. We can do myocardial stress perfusion imaging. We can also measure velocities akin to the Doppler imaging in echo, and parametric mapping, and late gadolinium enhancement imaging, which most of you must be familiar with. It's the idea with the cardiac MRI, the greatest strength of it is for tissue characterization. That is, when the tissue is the issue, then cardiac MRI is really your test of choice. And I won't go into details of how to do in each of this due to the time constraints, but many of you probably use it for viability testing in ischemic heart disease. But there are also implications in non-ischemic heart disease, valvular heart disease, and other rare cardiac diseases as well. One of the more recent developments that many centers are using is called the parametric mapping, which is something that you may hear about. And the techniques that are used in parametric mapping involve T1 and T2 mapping. The T1 mapping sequences allow us to assess the interstitial fibrosis or sometimes replacement fibrosis, the amount of fibrosis. The T2 mapping allows us to look at the myocardial edema, and another technique called T2 star mapping, which allows us to evaluate the iron deposition. And this sequence, the T1 mapping, bears, I think, something that people should be very familiar with. If we have that available, it does help us in identifying the tissue process as to what is happening in the myocardium. T1 numbers, that mapping is only increased in a few conditions where we talked about fibrosis, amyloid deposition, or edema, and it is decreased in these conditions where there is more fat, iron, or hemorrhage. So it allows us to distinguish what exact tissue process that is happening. And so we're going now, when we're talking about with cardiac MR evaluation, we're going beyond disease diagnosis. We're not just saying, is it infarcted, is it amyloid? We're actually talking about the tissue process involving inflammation and iron content, as well as presence of edema. Now, I thought, because this is a case-based presentation, a picture is worth 1,000 words. So I'm going to try to illustrate a couple of concepts in the next minutes, how we use multimodality imaging in current contemporary clinical practice. And I'll start with this case about a leaky valve. This is a 55-year-old patient with unexplained dyspnea on exertion. And he was a patient that I saw a couple of years ago. He's a very active construction worker with relatively sudden onset of unexplained dyspnea on exertion and volume overload that was intermittent over a year. He had extensive workup, including cardiac and pulmonary workup, which was unremarkable. The only remarkable finding was moderate mitral regurgitation on a transthoracic echocardiogram. He had a few hospitalization for flash pulmonary edema, and there was no evidence of significant obstructive coronary artery disease on the catheterization. However, his left ventricular end diastolic pressure was 17 millimeters. And this is his transthoracic echocardiogram. The mitral regurgitation on the left side is, you see there is some MR. It goes, flashes in and out. On the spectral Doppler, the Doppler density is actually pretty high. So there was some concern that this patient might be having more significant mitral regurgitation. And here are more images. Again, you see the moderate mitral regurgitation, which quite did not explain his symptoms. So he did undergo a cardiac MRI at that point, as the consultant physician was concerned if this patient also might have infiltrative cardiomyopathy. The patient's left ventricle, this was the report. I'll show the images later. It was mildly dilated, and his ejection fraction was 54%. He did have moderate mitral regurgitation visually, but the regurgitant volume was 57 milliliters, and the regurgitant fraction that was calculated was 37%. So this was a little bit more than what one would expect. So a TEE was recommended for this patient, and also an exercise echocardiogram was done. So this exercise echocardiogram was done to bring out any potential latent mitral regurgitation. He did have, as you can see, this is his baseline, this is a stress, and this is recovery echocardiogram. He did not actually demonstrate any significant increase in the mitral regurgitation. However, his TEE did actually show that he had mitral valve prolapse. This is his posterior leaflet prolapsing, and you do see this mitral regurgitation jet. And this is a very interesting jet in the sense that it doesn't stay eccentric. It has this garden hose effect, and that can be sometimes seen in the early mitral valve prolapse, where the jet is actually swishing around within the left atrium like a garden hose, with a garden hose effect. And as you can imagine, this was a difficult jet to characterize on transthoracic echo, because you don't see it in one plane, it just moves around quite a bit. Since he was having symptoms, and he ended up having the, let me show you. A robotic assisted mitral valve repair, and you can see the reduction of regurgitation after the surgery. And a year later, the patient is feeling fantastic and reports resolution of symptoms. I just wanted to take you back and look at the MRI. And if you look at the MRI again, you'll see that there is this mitral regurgitant jet, which compared to the echo Doppler is not as prominent. And a quick illustration on how mitral regurgitation is assessed in the setting of in cardiac MRI. So essentially, this is the strength of MRI, in addition to characterizing tissue, is accurate estimation of volumes. So you get the left ventricular end diastolic volume using a summation of discs method. So you get multiple slices, and you take the area times thickness, which gives you the volume, and then you add those discs, and you do that in diastole and systole, and that gives, and you take you get the stroke volume after you deduct the end systolic volume from the EDV. So that's how you calculate your stroke volume. And for example, in this case, you have an end diastolic volume of 250 and an end systolic volume of 100, and then you calculate what goes into the aorta. So this is the phase velocity images that gives you the aortic forward volume. In this case, it's 80 ml. So a stroke volume of 150 and an aortic stroke volume of 80 ml. So the mitral regurgitant volume can only go into either the aorta or into the mitral valve in systole. So you have this number, and then you have what goes into the aorta. So what remains is the mitral regurgitant volume. So that's how you calculate the regurgitant volume of any ventricle, and it's true both for left side and for right side with MRI. So in this patient, we had a regurgitant fraction of 37% and a regurgitant volume of 58 ml. Now, before we go and use this application for all cases, I do want to mention that in studies, what has been shown is there's a significant discrepancy between what an echo would assess as significant mitral regurgitation versus CMR. Although our early studies are showing that CMR-based regurgitant volumes are probably more accurate, as they seem to predict the left ventricular recovery after surgery. This is yet to become a practice, but something that is an emerging application that one can use in the situation where there's discrepancy between echocardiographic findings and clinical presentation. And I'll take you to another case. This is a very interesting patient case, and a very atypical chest pain patient. And this is a woman who also was my patient several years ago. She came complaining of severe cramping chest pain that would knock her out. It was severely limiting her lifestyle. She was a 65-year-old, otherwise very active person. And her biggest complaint was that she was not able to golf. Her history was significant for hypertension, paroxysmal atrial fibrillation, and recent cessation of hormone replacement therapy. She was on a DOAC, anticoagulant, and antihypertensive medication and beta blockers. Because of this cramping, severe chest pain, she did undergo a nuclear stress test, which was normal, and a normal echocardiogram. When she came to me, we decided to get a coronary CT angiogram that showed very minimal disease, mild non-obstructive disease in the left anterior descending artery, and a little bit of minor calcific plaque, but nothing obstructive. So she actually ended up getting enrolled for a research stress perfusion study where we were looking at the quantitative parameters in patients with minor non-obstructive coronary atherosclerosis. So this was her baseline echocardiogram, baseline cardiac MRI with normal function. And she underwent the stress perfusion study, which is a first pass gadolinium perfusion study, and we look for any perfusion defects. And in her case, she got long axis imaging and really did not have any perfusion defects. So interestingly, what happened was while she was in the scanner waiting for the gadolinium to pass away before we get the late gadolinium images, she started complaining of the similar cramping chest pain that she was debilitating her from participating in her golfing activity. And we had already ruled out significant coronary artery disease. So I was at the scanner, asked the technologist to put the patient in the scanner and look at what's happening. And this is what we found. Again, reminding you that this patient did not have any obstructive coronary artery disease. And these are the symptoms that were debilitating her. And you can see that her entire left ventricle is completely thinned and blowing out. It was and a few minutes prior to this test, her LV function was completely normal, and she had a normal myocardial perfusion. It was very alarming as to what was happening. And we immediately pulled her out, gave her nitroglycerin, and sent her to the emergency department. and within an hour, actually, her left ventricular function completely recovered back to normal. So she did not have any enzymes leaking. She just had the transient apical wall motion abnormality where her ejection fraction almost dropped from 55-60% to 20%. So this, in retrospect, was severe coronary artery spasm, but it's the first time where I saw such significant myocardial stunning and apical ballooning, which fortunately for her was quite reversible. So this brings us to the condition called ischemia with non-obstructive coronary artery disease. This is a term that more and more is coming into vogue and people are using it. And we realize that the ischemia can happen in the absence of obstructive coronary artery disease. This has been recognized way back in way back when in 1967. This is an article from New England Journal of Medicine where this issue of normal coronary arteriograms with patients with unmistakable coronary heart disease was brought up. And just to remind that non-obstructive coronaries are coronary arteries with less than 50% diameter stenosis. What I want to point out here is that you have coronary plaque developing from fatty streak all the way to obstructive coronary plaque, and exertional angina happens here, but the vessels are not necessarily normal. We do call them non-obstructive disease. And in this picture, which is important physiologically to remember, is that here's the pressure can drop, and this is what causes ischemia. Intracoronary pressure can drop, whether it is focal stenosis or if it is diffuse atherosclerosis. In both cases, pressure can drop and result in ischemia. And we do know for a long time that many people, particularly women, can have non-obstructive coronary artery disease but with chest pain. And back in 2004, the reports were reporting as high as 62% of cardiac catheterizations showed non-obstructive coronary artery disease. And this is true even in the setting of myocardial infarction or unstable angina, where 10% of women more than men would have non-obstructive disease, and this is in the case of unstable angina, where up to 30% had non-obstructive coronaries, and this data is from 2012. And this has been termed as a syndrome called as Yentl syndrome, where Dr. Healy has mentioned that this condition where women tend to have ischemia without the presence of obstructive coronary artery disease, it still causes significant morbidity and mortality, but is not recognized, resulting in gender discrepancies in care. And this term is known as Yentl syndrome. And more and more the emphasis, we're realizing that we are overtly focused on obstructive coronary artery disease as an explanation for ischemia, whereas that only represents 5% of coronary circulation. 95% of coronary circulation is in the microcirculation. So there's it is a reminder to think beyond epicardial disease, and inability to increase coronary blood flow at microvascular level can also result in ischemia. And looking at flow reserve may be something that is an increasing target. So it's important that we look at physiology and not just anatomy. And here's an example of coronary CT angiogram patients with two different kinds of stenosis. And only one of these patients has hemodynamically significant coronary artery disease. Both of them look, this one looks significant, this one looks significant, but of these two, only one of them has hemodynamically significant coronary artery disease. And so that brings us to the question that is there a way to look at physiology and anatomy in the same study? And FFRCT is something that is more recently being available in the United States. I think it's still not available in India, but this may be a solution for giving both anatomy and physiology on the same test. And basically, FFRCT is an artificial intelligence-enabled technology that combines algorithms trained by deep learning as well as and then corrected by highly trained analysts in a core lab to provide a 3D map of the heart predicting lesions and vessel-specific FFR. And for example, this is a patient patient with a coronary CTA in a 64-year-old with chest pain and risk factors. And you see this, there's some disease here, and this is the left anterior descending artery. There's some disease here. You can see some narrowing here, but not exactly clear how significant this is. And then there's minor disease in the circumflex, and then the right coronary artery looks clean. And this patient's analysis was sent for FFR CT evaluation. This is basically nothing else needs to be done. These images are sent to a post-processing analysis program, and they give you the physiology based on that. And in this case, it was predicted that the LAD was going to be significantly stenotic with a FFR value of 0.57, and the cardiac catheterization was consistent with a significant stenosis. So the availability of CT-FFR is very rapidly changing the landscape of how we're doing testing for patients, and this is most recently presented in American Heart Association, the PRECISE trial, where they looked at CT-FFR guided decision making versus traditional stress testing. And if you look at the primary endpoints, the primary endpoints were there were no changes, but however the obstructive coronary artery disease was 2.6%. So if you imagine, we were looking at 60% of diagnostic catheterizations, which were a non-obstructive coronary artery disease. Compared to that, this has come down significantly. So I think I'll just
Dr. Madhavi, can we just conclude so that we can have time for discussion?
Okay. So the last thing I'll talk about is about plaque characteristics, and we do get detailed information about plaque characteristics. And this is I won't go into the details of that, but this is also an emerging application that is coming up, and we can actually look at how the plaque is modulated, and this is something that is coming up as a new method to evaluate the progression of atherosclerotic plaque. So I'll conclude with this slide. If you can see the images, this is a case where this plaque has been regressing over a period of time. This is another case where the plaque is transforming, meaning from non-calcific to a plaque which is becoming more and more calcific. This is often seen with the effects of statins. And this is a case where this plaque has been progressing. So the beyond guidelines, when we talk about it, we're looking at a phase where we might be looking at temporal changes of plaque burden and intensification of medical therapy. So unlike in the past where we were only targeting the obstructive coronary artery disease, I think it's time we can look at the non-obstructive coronary artery disease, because unless we see it, we won't be able to treat it. And once we have this information, both the physicians and patients can make aggressive changes that can either slow down or speed up the atherosclerotic process. So in summary, I'll conclude that multimodality cardiac imaging here is to stay, and I think we all work as a team to figure out the problems here. I'm happy to take any questions.
Thank you, Madhavi, for that very excellent lecture and a little bit of how you use multiple images to reach a conclusion, and that the tool is very important. I'll open the house for discussion. We'll just have 2 questions so that we stay on time. Madhavi, just one question. Patient with HCM, T1 map shows increased numbers on the septum, and there is no gadolinium enhancement. Your take on what to do next?
That is that's a very good question. What do you do next? The data so far has been only with late gadolinium enhancement, and that too, in terms of doing something, we typically want to at least see 15% of enhancement before we would do anything more concrete, like giving an ICD placement. Now, if you're just seeing that there's only T1 elevation but no LGE whatsoever, and there is septal hypertrophy, it could, as you know, it could also be a technical issue. And if you're very sure it's not a technical issue and it's a truly increased T1, that could indicate early fibrosis, and it hasn't just gone to a stage of replacement fibrosis. And that's a really tough question. There are no guidelines to answer, but if there is enough clinical suspicion, I probably would repeat another cardiac MRI within a couple of years.
Hello, Madhvi. I just want to continue the same question. Whenever there is a hypertrophy in the septum or some other segment of the myocardium, but there is a T1 increase value in hypertrophied segment. So how do you conclude it, or what is the next step you do in these cases, or do you just do a follow-up in these cases?
I think it's worth to calculate the ECV. So you have a global information if there's increased interstitial volume, or having that global number. In general, the reproducibility has just based on just the T1 values is not, I don't think is adequate enough to like make management decisions. But I think in general, I would follow up the patient with another repeat cardiac MRI.
Thank you, Madhavi. And I think that was a very excellent erudition of multimodality imaging. Madhavi, thanks once again for sparing time from your ACC schedule. And hopefully we'll be in touch for future projects. Thank you very much.
Thank you for the invitation.
Hello. After an interesting session from Dr. Madhavi, now we'll have a very interesting case discussion. I request Dr. Tariq Iqbal to come to the dais and present the case.
Good morning, everyone. Today I'm going to discuss about one tough case and a patient which we dealt with in the past 6 months. So this is about a patient of pyrexia of unknown origin and a patient with recent TAVI. So we start with the background of the patient, who was a 62-year-old male patient, a known bronchial asthma, which was a stable disease which rarely required any treatment. Also with a history of symptomatic gallbladder calculi and a history of pancreatitis, and for which cholecystectomy was done in March 2022. The oral story began in June 2022 when he was diagnosed with severe aortic valve stenosis in the other hospital, not over here in our hospital, and for which he underwent transcatheter aortic valve implantation in June 24, 2022, after which he had an asymptomatic course for 20 days, but later he developed fever with dysuria, for which he received apparently meropenem for 21 days, and not much of evaluation was done by his treating clinician over there. We're just wondering why such long duration of antibiotics, and we just presumed that probably he was febrile for a longer duration, for which he might have received 3 weeks of antibiotic. Then later again he started having fevers, and this was the time his clinician back where he underwent TAVI, he did a blood culture for the first time, which showed Pseudomonas aeruginosa, for which again he received anti-pseudomonal antibiotics of 15 days, with not much of evaluation done for the etiology of fever. After stopping of antibiotics again, he developed fever, and this was the time when he changed his clinician and he approached some other doctor, where persistent bacteremia with Pseudomonas aeruginosa was seen. And this time the doctor did a PET CT, which showed multiple splenic infarcts with multiple uptake areas in T6 vertebra, mediastinal lymph nodes, as well as in the right ankle joint. Later, after the PET CT, he underwent TE, which showed a vegetation. And this was the first time when the etiology of fever was attained by the clinicians, and for which he was prescribed ceftazidime and amikacin for 6 weeks. And then this was the first time when he came to AIG because he was still having persistent fevers despite antibiotics, with a new symptom this time, that was dyspnea from 3 days. So this time what we did was we stopped all the antibiotics for 48 hours. We repeated the blood cultures, and to our surprise, a new growth is occurring in the patient, which is Burkholderia cepacia. And as you see, only he was sensitive to only 3 antibiotics, that is levofloxacin, ceftazidime, and meropenem. And meropenem, ceftazidime been having very high MIC values, and intermediate susceptibility to only trimethoprim and sulfamethoxazole. Then, meanwhile, what we did when we did a transesophageal echocardiography. So, if you see over here at the aorta, we can see a mobile mass which was a TAVI vegetation. Along with that, a cardiologist could diagnose that patient is also having aortic root abscess along with moderate effusion and an impending risk of tamponade. So patient was immediately taken to the lab, and pericardiocentesis was done and fluid was sent for analysis. Meanwhile, we also did a PET CT again, and if you see, we are able to see the bright area in the heart, which is the aortic valve vegetation, along with the mild enhancement in the pericardium, the bright structure surrounding this heart, which showed the uptake, which is the uptake in the increased uptake in the pericardium. Along with the right side image, if you see the dark area, the arc-shaped dark area is an aortic root abscess. So as you know, PET CT is a very good imaging modality for paravalvular involvement in the infective endocarditis, be it prosthetic or native, especially in the prosthetic valve endocarditis. Later, we see the still persisting splenic infarcts in the patient, but of course, one good thing was there is no abscess formation. Meanwhile, we got the pericardiocentesis reports, which also showed Burkholderia cepacia. And this was the time we had a challenge. We tried to convince the patient for the surgery, but he wasn't willing. He was pretty much exhausted by all his sufferings. So we had to discharge him with meropenem and levofloxacin. But this time we tried a different strategy of meropenem. We tried a continuous infusion of meropenem. As we know, beta-lactams are time-dependent antibiotics. So we gave continuous infusions over 24 hours along with levofloxacin dual drug therapy because it was a difficult infection to treat. Patient remained afebrile for 2-week follow-up. Then again, unfortunately, a month back after his previous admission, he started having fevers again. But of course, afebrile for 1 month. Again, we repeated cultures. We still had persistent bacteremia with Burkholderia. This time again, we tried to repeat a PET CT which showed new enhancing lesions, which means that still new ectopic septic emboli were still in the patient has been suffering with, and we stressed the patient this time for he definitely needs a surgical AVR, otherwise this infection is not going to heal at all. So finally the patient agreed for the surgery, and our surgeons tried doing the surgery and they were quite successful. If you see in the right side of your image, the TAVI valve which was extracted with great efforts, because it is a very tough surgery even for a skillful surgeon, and our department in the CTVS could successfully implant the valve. And if you see over here on the left side, which I have highlighted, a big huge vegetation sitting on the cusps of the aortic valves, and the right image is the new prosthetic valve. So patient after surgery remained afebrile, and he was discharged later on. But unfortunately, after 2 weeks of discharge, he developed some dyspnea, and while on the way to the hospital, he passed away. So that's the sad part, but thank you.
So that was really a very challenging case, and the surgery, whatever done, aortic valve surgery, would the patient would have been saved if it could have been done early?
So actually, post-TAVI endocarditis is a very tough thing to deal with. Despite surgery is also a very high mortality. In first 6 months of their illness, almost 60% of the patients, we lose almost 2/3 of the patient. So I think all over the world, not more than 50 to 60 cases have been diagnosed, but not much of them could survive after surgery, even after surgery.
Anybody from the audience have any queries? Sir's opinion, expert opinions.
It's not, I'm not an expert here, but it's just a comment. There are dozens of patients with stent endocarditis, endarteritis. I think Dr. Rajesh Nair is putting together a series of patients where the main thing you should realize is when the patient develops a stent endocarditis, he never goes back to the primary cardiologist. He goes back with fever or abdominal pain to a physician, and they get treated in ICU. And the fortunate few where they connect the dots and send them back to the cardiologist, only they are diagnosed. So when they have rupture, it's a hemopericardium, sudden death, they don't make it to the hospital, and several of them are getting treated as PUO. So be aware of this. I think Rajesh, you have close to a dozen patients or so he has collected as a series. Probably we'll ask him to present later on, because that's more common than TAVR that we do.
Thank you, sir.
Just a comment is regarding TAVR. One of the important aspects is to make sure you have surgery type of aseptic precautions. So when a TAVR is being implanted, that's the reason why the initial TAVRs were done more in a hybrid lab. So all the surgical precautions need to be taken, and as TAVR is spreading and almost every center is doing TAVR nowadays, it's important that this should be kept in mind. As was mentioned, once TAVR valve gets endocarditis, they almost have a near 100% mortality. And retrieval of the TAVR valve is extremely difficult. Most of the series which have been there for TAVR explantation, it is in patients with infective endocarditis. And most of the experts feel the reason why TAVR explantation has such a high mortality is because it starts with infective endocarditis, and that's the reason why many of them don't make it. Very important to maintain aseptic precautions.
Thank you, sir. So we have our next speaker online.
Thank you.
Dr. Bharat Raj Palraj, MD. He is an eminent physician, now is Assistant Professor of Medicine at Mayo Clinic College of Medicine, Infectious Diseases Physician, and Chief Infection Prevention Officer at Armor Health. He has been associated with Mayo Clinic since more than 12 years and had been consultant before that, had been consultant in the Division of Infectious Diseases, and before that also he had been working as a consultant physician of infectious disease and had fellow of instructor of medicine in Armor Health, where he was chief infection prevention officer, has been long association with Mayo Clinic and JFK Medical Center in Florida. So I would request Dr. Raj. Dr. Raj, are you there?
Hi
Hello,
everyone.
Dr. Raj.
I'm
Yes.
Dr. Raj Palraj.
Yes. We
I'm
welcome
from Mayo
you.
Clinic College of Medicine and Science in Rochester, Minnesota. I would like to thank the organizers for giving me this opportunity. I do not have any financial conflict of interest regarding the topic. Let's go on to case number 1. Patient is a 81-year-old male with a past medical history of diabetes, hypertension, coronary artery disease. He also has a prosthetic aortic valve with aortic root replacement done several years ago. He presents to the emergency department with fever, chills, and rigors of 2 days duration. Blood cultures are positive for Staph aureus and no peripheral signs of endocarditis noted. The question is, what is the next step in the management? So let's look at the diagnosis of endocarditis. It is based on the modified Duke criteria, but we should note that the typical Ostlerian manifestations, including Ostlers nodes or Janeway lesions, are present in only a small minority of patients. We should remember that these were described when subacute infective endocarditis caused by low virulent pathogen like strep viridans were the predominant form of infective endocarditis. But things have changed. In the contemporary database, Staph aureus, which is a highly virulent pathogen, is the most predominant cause of infective endocarditis, and patients present to us within a matter of few days before these signs can typically manifest in the patients. So absence of these signs does not rule out infective endocarditis. So when clinical signs are not sensitive enough, our main go-to modality is echocardiogram. And when you compare TEE versus transthoracic, it is very clear that transesophageal echocardiogram is far superior in terms of sensitivity to detect infective endocarditis, especially in the sense of prostate aortic valve, and also to detect perivalvular complications like abscesses, fistula, and leaks. So the go-to diagnostic modality is transesophageal echocardiogram. We discussed briefly that the patient population have changed with aging population. They also undergo a lot of diagnostic and therapeutic invasive procedures which put them at risk for highly virulent bacteremia such as Staph aureus or fungal pathogens. So Staph aureus has become the most common cause of prostate valve endocarditis. And if you look at Staph aureus bacteremia patients, if they have an underlying prostate valve, they are at very high risk for endocarditis. And these patients also have a higher degree of perivalvular complications, which put them at high risk for mortality. So it is very important to kind of diagnose endocarditis in the setting of Staph aureus bacteremia. This is one of the few scoring systems available to kind of understand the risk of underlying infective endocarditis in the setting of Staph aureus bacteremia. This was developed during my fellowship almost a decade ago, and we have day 1 and day 5 scores which you can use to kind of categorize patients into low risk, moderate risk, and high risk. In a simplistic term, if a patient has ICD, pacemaker, or prostate valve in place and they develop Staph aureus bacteremia, they have a very high risk for endocarditis. If they have prolonged bacteremia, they have a longer time to see the valve. So they are also at high risk for developing endocarditis. So you do perform a transesophageal echocardiogram, but it comes back as negative. You monitor the patient daily. He continues to have fever for more than 5 days. Blood cultures on day 4 and day 5 remain positive as well. Then the next question is, you can either do a repeat TEE, maybe the first TEE was done too early, or you could go ahead and do a PET CT. In a PET CT, you would find heterogeneous uptake around the prostate valve ring. Here, this patient also had uptake around the aortic valve, clearly showing that this entire aortic root and the prostate valve is involved. So what is the role of PET CT in endocarditis? Among those patients who are categorized as possible infective endocarditis, if you do a PET CT, you can recategorize them into either definitive infective endocarditis, or you can definitively rule out infective endocarditis. So it's very helpful in those possible infective endocarditis category. This has been added as a criteria in the European Society of Cardiology guidelines. It is not yet in the American guidelines. It can also show occult pacemaker pocket infection and can be useful in diagnosing ICD and pacemaker infections as well. Sometimes it can also show up clinically occult infections. Here you can see that it shows a vertebral osteomyelitis as well as splenic abscess, which we did not suspect clinically based on symptoms of sinus. Case number 2. 65-year-old gentleman with an ICD in place, and he comes in with Staph aureus bacteremia, presumably from a skin cellulitis. The pocket is without any infection, and the question is whether this patient is at high risk for developing secondary seeding. And the answer is yes. In the setting of Staph aureus bacteremia, if patient has ICD or pacemaker, up to a third can have underlying infection. And only a small minority, 30%, have pocket infection. So if you press on the pocket and it doesn't show any signs of infection, doesn't mean that they cannot have a lead infection. We also have a predict SAB scoring system based on our Mayo Clinic database to kind of tell you what is the risk of underlying CID infection in the setting of Staph aureus bacteremia. Okay, so TE is performed and it shows the leads have vegetation and the valves are clear. The question is, would you remove the ICD? Would you give antibiotics for 6 weeks and followed by chronic suppression? And the data is very clear. If the ICD is not removed and we try to manage with antibiotics alone, both the 30-day mortality as well as 1-year mortality is very high. Conservative management in one study was 7-fold higher mortality compared with the removal of the device. So it's very important that patients with CID infection get their leads as well as the generator removed. And why is that? If you think about it, the bacteria form a biofilm around these leads. Biofilm is just a slimy extracellular matrix inside which colonies of bacteria are in a protected state. So the antibiotics alone will not be able to cure the infection. A very similar patient, 65-year-old with a pacemaker device in place, but this time the bacteremia is due to an gram-negative organism, E. coli, and it was thought to be from a recent urological procedure. The question is whether the risk is different compared to the Staph aureus bacteremia which we saw earlier case. The answer is yes. And many studies have shown that the risk is completely different compared between gram-positive bacteremia seeding a lead or a valve versus a gram-negative bacteremia. The risk of gram-negative bacteremia from a urosepsis going on to see the leads is extremely low. In our database, the study did not show any cases of hematogenous seeding from a gram-negative bacteremia. So we can keep the device in place. We don't need to remove the device in the setting of gram-negative bacteremia. Case number 4. Patient is a 55-year-old resident from Bhutan. He has spent several years as refugee in Nepal. He comes with 3-4 months of fever, weight loss, and chronic diarrhea. Blood cultures are negative, but TE shows a big vegetation in the aortic valve. The question is, what is the etiology and how will you diagnose it? Patient was eventually diagnosed with Whipple disease. He has a classic triad: fever, weight loss, chronic diarrhea, and his biopsy of the small bowel was showing PS positive foamy macrophages, and the tissue from the valve when he went for valve replacement was also sent for pathology, and it showed foamy macrophages. The tissue was also sent for broad range PCR, which came back positive for Whipple, Proferima Whipple. So culture negative endocarditis, if you think about it, previous antibiotic exposure is the most likely scenario where the blood cultures are negative, but in the right setting, we have to think about other organisms. Bartonella can cause endocarditis in homeless patients. brucella in patients who drink unpasteurized dairy products, Q fever if a patient is from Southern Europe, Mediterranean setting. Whipple disease is very common. It was mainly described in France, but it is prevalent worldwide. So in a patient even from Bhutan and Nepal, we should think about Whipple disease. We have valve tissue PCR, which is organism specific, but also broad range PCR as well as next generation sequencing tests, which we can do on the tissue that can help identifying the pathogenic organism. Going on to our last case, patient is a 55-year-old male with rheumatic heart disease. He presents with mitral valve endocarditis secondary to strep mitis. Patient was diagnosed in a different institution, and he was noted to have a huge vegetation, 1.5 centimeter in the anterior mitral leaflet. They do an MRI of the brain, which doesn't show any evidence of stroke, and they are sending to your institution to kind of see if patient qualifies for early valvular surgery. If you think about the role of surgery in infective endocarditis, there are certain indications which have a very strong evidence. If patient is in heart failure, if patient has a valve dehiscence, fistula, perivalvular abscess, or the organism is highly resistant where we don't have bactericidal drugs, the surgery is very beneficial. But certain indications have a low level of evidence. If the vegetation is big, especially on the anterior mitral leaflet, studies have shown that they have a higher risk of emboli. Can valve surgery reduce that risk? The evidence is not clear-cut. But a very small study, a small randomized control study from Korea, noted that early surgery decreased risk of embolization, especially among patients with streptococcal mitral valve infective endocarditis. In two meta-analyses also noted early surgery can reduce the risk of death. So in this patient, there might be a role for early valve surgery. In summary, Staph aureus is the most common pathogen in the healthcare setting. Modified Duke criteria with TE as a preferred echocardiograph modality is a diagnostic method of choice. PET-CT can be helpful in selected setting, and role of surgery is individualized based on case-by-case risk assessment. Thank you.
Thank you, Dr. Bharatraj. I think since this is a recorded lecture, there will be no questions to the speaker. If there is any thoughts from the audience, we will entertain one question. Please there. Bharat, are you there?
Yes, I'm here.
Sure. Okay.
Yeah, thanks
any
thanks for the
questions can be
organization
addressed.
for inviting me. So I'm happy to answer any questions.
Yeah, thanks, Dr. Raj, for that excellent talk. Recently, with these PCR-based techniques, we've been having some patients with infective endocarditis with some of the viruses being grown. So EBV, CMV, how much importance do we give to that? Do we treat it or we just ignore it? And what's your experience about it?
That's a good question. I think we haven't seen a lot of PCR detecting viruses from the valve. I would say I would not treat it. CMV, EBV, we all have it. Majority of adult population have CMV or EBV past infection, and they're all belong to the herpes virus family. And once we get the infection, they stay in the dormant fashion throughout the life. So it's not uncommon for us to detect small low-grade viremia during a phase of acute illness for something else. So I would not treat. We do not have enough data to kind of know whether they are pathogenic, but typically they are not considered to be pathogenic in the setting of infective endocarditis.
Raj, this is Narsimhan here. Thank you so much for joining us. I know it's quite late. Thank you so much for this excellent lecture. On a slightly different note, when we do procedures, it's very common, we're all practicing cardiologists. When a patient comes for a replacement for a pacemaker or an ICD, we take it very lightly. The junior most person does it and does it at the end of the day when all the list is over. And that is the worst thing to do, because once the leads have been there for 18, 20 years, if the leads get infected, it's impossible to pull it out unless the risk increases. So please remember, device implantation is a surgical procedure. And I don't know how often to say the carelessness with which we treat the device replacement is the main reason for device related infections. And I don't know whether you've seen, because the moment you have long standing leads and you try to pull them, the morbidity increases of the procedure itself. So if there's one thing that I would like to say, replacement of devices appears simple, but if they get infected, that's a real disaster in making.
Thanks, Dr. Narasimhan, for that comment. I completely agree. I think we have seen in several data sets, like a device change, generator change is a risk factor for CID infection. So absolute sterile precaution, infection prevention measures are absolutely indicated.
Thank you, Dr. Bharat. So with this, we come to end of this first session. So after that, session 2 will start after this session. Thank you very much. Thank you for the audience.
Thank you. The next session, we have two interesting interventional cases. So I'd like to invite the chairpersons for that session, Dr. Srinivas Kumar, Dr. Ajay Swami, and Dr. Gokhale. They can join us on stage. And they will introduce the presenters for the next case.
Yeah, morning to all. Thank you, Raju, for the opportunity. And then in this session 2, we will have, as told earlier, we'll have interesting cases. As is a case-based discussion, and you are sitting in AIG, it's very apt that we have a post-liver transplant patient with severe liver dysfunction and left main calcification and significant disease at the bifurcation. As we all know, it is easy to say left main bifurcation, so it's sent for surgery. But even with surgical colleagues, I think Dr. Gokhale will agree, they would hate to operate on patients who are high risk for bleeding, we have multiple complications. So I think with the advances in interventional cardiology with supportive devices like Impella and other things, and better antiplatelet drugs and better techniques of imaging, we are able to tackle some of these patients and help our surgical colleagues by interventions. So I think let us hear one such case and we can have some discussions, and later Rajiv will present about tips and tricks and chip, and Anuj will have his expert comments. I think I request Rajiv, Anuj are already there. Right, thank you. So over to you, Dr. Pragati, for your presentation.
So, good morning, the dignitaries on the dais, the chairpersons, delegates, and my dear colleagues. Sorry for the voice; it's slightly harsh. So. So we'll deal with the case which was done with Impella support and DK crash with rotational atherectomy. So CHIP procedure, what is CHIP procedure? So it is complex, high risk indicated percutaneous coronary intervention. So this subset of patients, they have complex coronary lesions targeted for revascularization. And these are the patients with major comorbidities and significant hemodynamic instability and univentricular or biventricular dysfunction. And these are surgically turned down patients. So we go with the case scenario. Here are the patient's details. Here is a 69-year-old gentleman, known hypertensive diabetic for 15 years with peripheral arterial disease and chronic kidney disease with baseline creatinine of 1.2 when we started the procedure. And this is a post-liver transplant patient that he underwent liver transplantation 9 years ago. So he presented to us with dyspnea that was rapidly progressing. To start with, it was dyspnea NYHA functional class 3, progressed over 2 days to functional class 4, and he was in frank pulmonary edema and cardiogenic shock when he presented to us. So the initial diagnosis made was acute coronary syndrome, NSTEMI, with left bundle branch block and severe LV dysfunction. And this patient was in acute decompensated heart failure and cardiogenic shock. So initially the patient is stabilized with heart failure management, inotropic support, diuretics and NIV support. And once he recovered, we have taken him for coronary angiogram. So this is his baseline coronary angiogram. Here we see there is significant ostial left main and distal left main lesion with diffuse disease of left main, and the lesions extending both into LCX and LAD. So we see diffuse severe calcification with significant ram tract calcification of both LCX and LAD. So we as well see distal LCX diffuse disease with the disease extending into the major OM. That's also Medina 111, and the left main lesion extending into LCX LAD Medina 111, and LAD is diffusely diseased thinned out vessel with significant narrowing. So the right system injection shows again dominant vessel severely calcified with tram tract calcification, with the distal RCA showing discrete lesion close to 90% stenosis. The PLVB has tubular lesion with close to 80 to 90% stenosis, and distal small vessel disease. So we had a heart team discussion considering the patient profile. So this patient had syntax 1 score of over 33. So and syntax score 2020 taking into the physiological consideration. So so we had a detailed heart team approach, and CABG was categorically denied by the surgeon in view of the patient's profile, underlying biventricular dysfunction, and his previous comorbidities. Hence, percutaneous coronary intervention is planned with the aim of complete revascularization. The calculated syntax 2020 score is at the end of 5 years with PCI, the mortality is close to 32%. And with the CABG, the mortality is 21% approximately. And 10-year MACE rate is, with the CABG, it is 33%, and with the percutaneous coronary intervention, it is 45%. Yet we have gone for percutaneous coronary intervention because the surgery is declined by the surgeons. And this is the CHIP scoring, considering requirement for dual access, mechanical support, involvement of left main and a complex bifurcation lesion, and underlying comorbidities and biventricular dysfunction. The overall CHIP score is 12 with the predictable in-hospital MACE rate of 17.4%. So this is the planning. So this patient required hemodynamic support considering the underlying biventricular dysfunction. So impella from left femoral axis is planned, and the right femoral axis for 7 French primary axis for PCI. And we have planned to revascularize the RCA first to decrease the overall cumulative ischemic burden. And it is upfront rota that is planned to left main to LAD and LCX in view of severe tram tract calcification. So we have gone for upfront 2-stent strategy, that is DK crush, because it was sufficing the major and minor criteria. This patient had significant distal left main disease extending into both the branches, both the main branches, LAD and LCX, As well, there was significant tram tract calcification with the multiple lesions and the bifurcation on, angle extending over 70%. So all put together, it is prudent to do an upfront 2-stent strategy with the DK crush with a surgical backup ready. So left femoral axis for mechanical circulatory support, impeller CP was chosen, and post axis check shot shows ideal puncture site, and impeller CP is placed into left ventricle across the aortic valve. And then RCA is revascularized first as planned with the guideliner support. So we were conservative in revascularizing RCA. Only a focal stent dealing with the discrete RCA lesion was put. And we see the result is good, RCA result is good. And then and left main engaged with 7 French XP3 guide. So we cross the L6 lesion and exchange with floppy rotawire, and thoroughly rota ablation of L6 is done, and followed by that rota ablation to left main to LAD is done. And then wired both the vessels with workhorse wires, and left main to LCX predilation is done. We see there is adequate plaque modification and good balloon expansion. And as well, LAD is predilated thoroughly from starting from left main to mid LAD. And then mid LAD stent is done first. It's a short stent we put. And then we went with bifurcation angioplasty DK crush of left main to L6 and LAD. So with the balloon in place from left main to LAD, LCX stent is done. Left main to L6 stent is done with the stent struts protruding to at least 3 to 4 millimeter into the left main. Following that, crush is done with the balloon that is secured in left main to LAD. And this is the first kissing balloon inflation with the 3 into 12 mm balloon in left main to LCX, and 3.5 into 12 mm balloon from left main to LAD. So this is the first kissing balloon inflation. So followed by that, left main to LAD stunt is put with the 3.5 to 28 mm regulating stunt inflated at nominal pressures. Then first parts with 4 into 8 non-compliant balloon. And then the LCX is recrossed and it is post-dilated. And this is the final kissing balloon inflation, and final report with the 4.5 into 8 mm NC balloon to the left main. And this is the final result we achieved. So angiographically there is good stent expansion, and there are no complications, no edge dissection or geographical miss. So imaging was done in the patient. So initially we couldn't pass the imaging catheter, so I'm not included those images. This is the final result. We achieved good angiographic result. So to summarize, so complete revascularization in high risk patients is the aim of CHIP PCI. So it's not at all a substitute to CABG, but an alternative strategy. So hemodynamic status of the patient, complexity of the procedure, and LV function or the cardiac reserve are important in choosing the mechanical circulatory support. And frailty index is always taken into consideration to decide between a CHIP PCI and medical management. So anatomical, clinical, and procedural factors govern the decision making in an individual patient that scores baseline surgical risk assessment. Thank you.
We have Dr. Gokhale, sir. Your comments?
Is Sukesh here? I was just thinking that, you see, we know in cases like this, cardiologists have become very aggressive and new techniques have come, and they really look very good at the end of the procedure. But we know in the long-term results, for sure, so far, surgery does much better than the angioplasty. I was just wondering whether in this case, we could have used a ECMO and done the surgery. It would have been much cheaper and probably have given a better long-term results. Just want to hear the comments from cardiology colleagues. And the second thing is, I think you have to delete a sentence from one of your presentations. You had a surgical standby ready. You know, we have not accepted the surgery, and when things get worse, what can we do except for run away from the place? So these are the two sessions, and I would like to hear the comments.
We want to call our surgeons, make them comfortable in a console room and drink coffee. So we may not give you case, but we want to be you to be around so as to comfort. That is the idea of saying that. But as you said, long-term results are okay, sir. First, the patient has to survive, no? So he's in shock, pulmonary edema.
No. He is better. Only after stabilization you have done that. I'm just saying I'm not doing. I want to put a ECMO and do the surgery.
Okay, if say surgeon.
Okay, instead of impella and angioplasty, all these stents. I was just thinking whether it could be an option. I understand definitely perioperative risk is much more with surgery than with procedures like this.
Yeah.
But ECMO I can keep for about 3 weeks. Impella I cannot keep that long. I'm just saying. And it is much cheaper than the impella. And probably it will cover all the costs with the impella cost. I'm just saying one proposal, one possibility I'm saying.
Discussion.
So I wanted to see if Sukesh is here because it's only the surgeons who can talk about this side.
This patient, I was actively involved in counseling, and it was a lot of people who actually were involved. He categorically declined surgery because he had gone through liver transplant. He knows the pain that he went through, and he was very sure he didn't want surgery at all.
So patient refused.
Yeah, he refused.
That closes because that comment was not mentioned. It was mentioned that surgeon refused, in the presentation. That's why I raised this topic.
Ajay, any comments?
The patient who refused.
I think this debate is long and hard, and it's been fought over the last 3 decades. And the very fact that we are still debating it means that we don't yet have an answer. And definitely in selected patients, surgery is better. In selected patients, percutaneous intervention is equivalent, if not better. And in selected patients, percutaneous intervention is better. Having said that, the perioperative risk of surgery sometimes is so high. If we leave the economics out of it, the perioperative risk of surgery is so high that we are looking at palliation in any case, and relief of symptoms and palliation, sometimes PCI has an advantage. So I think that's all that can be said for this. As far as large size randomized double-blind controlled trials are there, the evidence is out there for us to make what we want to, both for surgeons and for percutaneous intervention. As long as we're able to put our hand on our hearts and say this is the best treatment option for this patient in this given situation, I think we've done our duty. The debate is much larger, and I think we needn't go in there. I was interested in 2 things. We put in the impella. So did we look at the hemodynamics before and after, and what did you look at when you pulled it out? Because I presume that you've taken it out immediately after the procedure, although that wasn't mentioned. It's just for discussion. But excellent case, very nicely done. Probably we would have looked at how much benefit we're going to give this patient with the left main bifurcation prior to doing the whole thing. Because I felt the ostial circumflex was almost subtotally occluded, definitely. With the LED, we would have looked at maybe reversibility. I mean, patient already has LV dysfunction. Is there viability in the LED before doing it? It's just
non-ST elevation.
We did a cardiac MR before we did.
Right.
It was completely viable. That's when we actually took
That's
this
great.
decision. Otherwise,
That's
we would
great.
Other thing which
One comment I want to ask you. This question always haunts me. When someone has such a tight block in the right as well as the left, and patient is alive, has been walking so far, do we need to do viability study in these patients before doing any procedure? I don't know the answer. I just want to know. And in my practice, if someone comes like this, I don't do viability.
That's correct, sir. Actually, if it is non-ST elevation MI, where the dynamic changes, no QS at all, LV function echo, reasonably preserved thickness, we don't need to do viability. Suppose if you find a scar territory, thin LED territory, something there you might think of, but otherwise in this case, he has the dynamic changes. They said non-ST elevation MI, you don't need to do viability. Yeah, other aspect.
Exactly.
Anuj, other aspect, what is also important in this antiplatelet therapy business and bleeding is, what is liver function? Post-transplant, if liver function normal, then he stands a reasonably good chance even with percutaneous. Suppose sometimes he is already bleeding, then we can't give antiplatelets and then do stenting. Then
he was
surgery,
completely compensated. Liver's normal.
in
normal.
one of the management points I'm saying, suppose the liver function is managed, is maintained well with no worsening of PT and bleeding is okay, then probably we can manage with PCIs. Gokhale sir, what I would like to say from interventional point of view is all these patients, when surgeons were refusing, would die before. Now at least they have there's an option for them to, obviously they will be expensive initially, but those patients are surviving. The proof of pudding is eating it, then the patient survived and went home.
I
That's
fully
a-
agree with you. You are doing wonderful work, especially
thank
the
you.
recent advances. So beautiful to see such clean coronaries after the procedure. Unfortunately, we are not yet able to prove that after surgery.
Rajiv is going to present some tips and tricks, I think. Afterwards we can, Acha, sorry.
Yeah, just one comment about this particular patient. This patient did come back with the osteal LCX restenosis, which was expected, and considering the index procedure, it was not that difficult to treat the osteal LCX restenosis, which we managed with the drug-eluting balloon, 2 kissing drug-eluting balloon, one in LAD and one in LCX, and we didn't offer him additional metal. And down the line, I think now around 18 months, he's doing well. LV function has improved. And again, just to re-emphasize the same point, idea of chip is not, it's a substitute to the CABGs. It is a complete or near complete revascularization in a patients where surgery is not possible or it is declined categorically. And if that is going to change the prognosis of the patient. If the same group of patients, they are too frail, no point offering all these complex procedures to them. So it has to be a holistic, multidisciplinary heart team approach. Thank you.
I think after Rajiv's presentation on tips and tricks,
Small
we can
question
discuss.
about the LAD proximal is not that much disease to do LMCA stenting. LAD lesion doesn't appear to be significant in this patient. Here the LCX is the culprit and the RCA. By doing left main stenting for LCX, is it correct in this patient or not? LAD mid lesion is okay.
They felt LAD had dynamic changes, anterior and non-ST elevation MI. That's why they did it. As your point is well taken, if LAD left main is not important, only LCX ostium is a problem, we have different methods to approach it. We can discuss it
NST-MI
later.
can occur even with a non-obstructive lesion.
We
Because
can
here
do-
it looks, to me, it doesn't look significant.
If it is only isolated LCX osteal stenosis, then a different mechanism to deal with it. We'll talk about it. We can present that.
Yeah, thank you. Good morning to everyone, and thank you, Dr. Narasimhan. Thank you, chairpersons, for having me here. I think Dr. Pragati has made my job a bit easier. She's already presented certain tips and tricks. What we'll do over a period of next 10 minutes is just trying to see how we can make this overall procedure safe and make sure that the patient goes home without any hiccups after a complex procedure. So first, we start off with a very basic question of what is a chip procedure and why do we need to know this? Basically to prevent overuse, but please remember that we should prevent underuse also. There are many times where patient is just left to die because the surgeon has refused surgery and the interventionist is not adept at managing a chip procedure. So he just leaves the patient and over a period of time there is a progressive deterioration. Overuse again is extremely important because there are a lot of MCS devices which are present nowadays, and which one to use in which patient becomes extremely important. Trying to use an impeller for a person with a good LV function may not be appropriate. At the same time, trying to use IABP for a patient with severe LV dysfunction may not be appropriate. So it goes both ways. So this was already mentioned, a complex, high risk, but indicated procedure is what a chip is. And this was again elegantly shown by the previous speaker, where it's not just one component which determines whether it is a chip procedure. It is a combination of factors. So you have a complex anatomy. At the same time, patient has a severe LV dysfunction. Patient has hemodynamic abnormality, some arrhythmias which are going on. Patient is ACS, as was shown in the previous case. These are the patients which require proper hemodynamic support before a complex procedure is done. Just summarizing the same things, you look at the clinical factors, you look at the comorbidities, you look at the anatomical as well as procedural factors, and it's a combination which is important in these cases. The previous case which was mentioned, the score was somewhere around 12. So just imagine that this patient is going to have a MACE anywhere around 20%. And it is almost impossible that you will be able to do this type of cases without a proper hemodynamic support. The second issue is to make sure you have a chip capable center. So if you are doing probably a PCI a week or 2 PCIs a week and then suddenly decide that such a complex left main angioplasty we want to do, it's extremely important that you have proper training of the lab personnel. So this will make sure that you are able to finish the procedure safely and also give excellent outcomes. So you don't compromise the outcomes just because you want to get in fast and get out fast and in the process come out with a suboptimal result. These are all the aspects which you need to look into when you are trying to develop a chip program. And I'll just again re-emphasize the issue about cath lab staff. If you are trying to develop a program, it is not just you having great hands and ability to do an excellent angioplasty, but it is the nurse who is scrubbing up with you, the technician who is moving and keeping a watch on the hemodynamics. You have finished a complex procedure, patient is shifted to ICU and a fantastic critical care team which makes sure that lactates are in control. The urine output has not been dropping for 12 hours before it's identified. All these aspects are extremely important, inclusive of the teaching and the training program which has to be part of that particular program. Know your patient. Having known how to do a chip procedure, you have a good capable center, but it starts with knowing the patient. I think again the last case illustrated that, where there was so much of discussion about what all the patient went through and what are the important things we should know about the patient. Because the appropriateness of MCS and what MCS you use again depends upon what your patient is having. All the clinical variables are again extremely important, whether the patient is in shock, not in shock, compensated, not compensated, the arrhythmia risk, what is his LV function, what are his hemodynamics. There are many times when you start off with an idea, but once you do the hemodynamics, probably you change your plan. What were the opening pressures of these patients? What are the left-sided filling pressures? What is the cardiac output? And very important to look into what is the cardiac power output now, what is the PAPI. Make sure that you spend a couple of minutes. Everything is algorithmic now. It's available on the click of a button on the smartphone. Make sure you get all the hemodynamic parameters before you decide what is the type of MCS which you are using. And again, I think the chairpersons were emphasizing this point. Kindly do not try to do these procedures in a futile patient. Patient is in end stage shock, extremis, almost probably has a couple of minutes or hours. That's not the time when you want to take up for a chip procedure. It's only going to dishearten everyone and probably stop the further chip procedures. Know your devices, again extremely important, because the choice of your device will depend on what you are targeting. As we know, we have IABP, we have Impella, we have tandem heart and ECMO, and I think most of you know that tandem heart is basically between the LA and aorta versus ECMO between the RA and aorta. Now this is again an elegant slide just to summarize all the hemodynamic supports which we can give and the extent of support. IABP is the best for all of us. The unfortunate aspect is its support is very minimal, so hardly 0.5 to 1 liter compared to the other support devices which can give close to 4 to 4.5 liters. Of course, you need a large bore access. You should know how to do a large bore access when you are trying to use any of these. The cardiac power increases, but it's very important to know what happens to the hemodynamics. Now, we know that tandem heart and ECMO actually increases the afterload. So this is a situation where you might stress the heart in a patient who already has a severe LV dysfunction, and you might have to top it up with some other device, something like a IABP or a Impella, to actually reduce that afterload. And in effect, what it means is to understand what happens to the oxygen demand. And any situation where the afterload is increasing, this is going to increase the oxygen demand. Learn the nuances of the procedure, why to execute it successfully and prevent complications. What do they entail? These are just few things which we have put up here, but it starts with something as fundamental as a large bore access, and I think we would encourage all the participants to be part of the workshops which are being conducted tomorrow, because you will be taught how to gain a large bore access and also how to close a large bore access. And you don't learn for the first time on a chip procedure on a TAVR, but your regular femoral PCIs, start doing it. That's how we learned. So start doing it, because we are not used to the ultrasound guidance. get used to the ultrasound guidance. It adds significant amount of safety. Be adept with what are type of vascular closure devices. Usually angioseal and ProGlide are the ones which we use. The fluoro positions you should understand. So like when you're doing fluoroscopy and you're doing a percutaneous ECMO, you should know where exactly the cannulae have to be. Otherwise, you are not going to come out with an effective positioning of the ECMO. At the same time, you should know how you use echo and TE. If you use Impella, it's not the fluoroscopy, but it's the echo where you try to find out what is the exact position, what is the distance where the teardrop has to be. So these are certain things which you should learn beforehand before you actually go in and put. This is just to give you a picture of dual lumen ECMO catheter, the Veno Venus, which is an excellent catheter, just single access, and everything is done TE guided on the bedside. Many of these patients are not fit to be shifted to the cath lab also. Now let's go to some case examples. One already Dr. Pragati has told, but I'll just emphasize some of the other cases. So this was a 60-year-old gentleman, diabetic, hypertensive, hyperlipidemic, functional class 3 angina with crescendo symptoms in 10 days, morbid obesity. He had a BMI of 40, OSA, prior colonic surgery, Phillips class 1. Troponin was mildly positive. ECG showed some Q waves, and this patient had a good LV function. And these are some pictures. I will show you some more detailed pictures in the further slides, but you can see that patient has a very critical left main disease with good LAD and circumflex, and RCA, which is a subtotal occlusion. So this patient came to us and categorically refused CABG. These are the syntax score of 27. A detailed heart team approach was taken. And I should mention, now that Dr. Sukesh came, I think I can mention this, that our heart team is actually heart team in its sense. So we sit together in the console room, lot of discussion, and then talk to the patient. And probably Dr. Sukesh is one of our major referral base, and the other way around also. So he says, Rajiv, I don't think you should touch this LAD, please go and put a stent to the RCA. So that's the spirit in which we work, and that's what happened in this patient also. CABG was offered to the patient, but he categorically declined. His family was quite worried with his morbid obesity, and the plan was to do PCI with full revascularization. So here the idea was to use IABP as a bailout, mainly because of the good LV function here. So though a complex procedure, but good LV function, so went ahead and opened up the RCA, and then it was a Medina 111. So a DK crush was done, and I won't go into too much of procedural details, but the patient did well. It ended with IVUS, which confirmed a good mean stent area, and the patient has been doing quite well. This was the second case of a 50-year-old person, prior MI.
Rajiv.
Yeah.
I think we are running short of time.
Yeah.
See if we can do it faster.
Sure. So this was the second patient who again had a prior MI with LV dysfunction, significant ISR. I'll just show you the angio pictures. Now here there was upfront IABP which was put because the hemodynamics showed that the wedge pressures were high. Probably we can consider Impella in this case, but we need to look at in our country how many of them actually can afford Impella. So again, a TAP procedure was done here with a good result. The third case already I think Dr. Pragati has mentioned, so I won't go into details. She has already shown the pictures. And so this case, because the patient has severe LV dysfunction and a complex procedure, we went ahead with Impella upfront. So again, the take-home message was again mentioned by Pragati, which I'll just re-emphasize that here the idea is complete revascularization in high-risk patient. We should realize that most of the CHIP patients are high risk for CABG. So that's the catch here. They are refused CABGs, and that's how they land up with CHIP procedures. MCS should be decided beforehand, but we need to take a call depending upon hemodynamics. Frailty index again is important, and just don't go by scores. It's the patient which you need to see, individualize the patient and then take a call. Thank you so much.
Thank you, Raju, for highlighting that aspect. Dr. Somraj always said take care of patients and deal with them first rather than technique. Another important aspect is if patient is elective, probably preparation of the patient with proper diuresing the patient, stabilizing prior to the procedure also goes a long way. I think for the sake of time, that's also important because if it's an emergency, it is different. But elective case, probably you should consider it equivalent to surgery, and probably our anesthesia colleagues being around and all that also helps a lot, helps us in concentrating on the procedure and doing a good job to the patient. And regarding Sir's question, Murthy Sir's question of LCX osteum alone, if you are confident about that on imaging, where only LCX osteum is involved and LAD left main is free from disease. Incidentally, yesterday we did one 82-year-old female relative of Gokhale sir, where the orbital atherectomy is another new addition which has come, which actually rotates and then probably makes a good lumen there. Once you image there, then we just avoided stent also, because if you're stenting, then again there could be some compromise onto the LAD where bifurcation procedures required. So after doing orbital atherectomy, we did regulating balloon and did imaging. The final result was very good. So we are all learning with new techniques, but we should be very sure that there is no disease. Generally, disease extends into the left main and also into the LAD by imaging. Then it is always better to what they did. If you are sure about it, only LCX osteum, that is there. As he told, Antonio Colombo's statement, if you did a bifurcation stenting of left main, if patient comes back with restenosis, it will be invariably LCX osteal stenosis. Interventional cardiologists, we conquered left main, other things, but LCX osteum is still a difficult thing to conquer. I think orbital atherectomy, some of the newer things could help further. I think we are running short of time. Narasimhan has sent a message. Expert comments by Anuj, anything, or we'll close?
Major. I think the only thing other than this is we need to be, in addition to seeing the nuances of a procedure, vascular access, I think we have to be extremely cautious, because we end up doing a great procedure and then we end up with vascular issues. I think that actually takes a... We're actually now retrogradely evolving back into femorals now.
Yeah. So what Raghuram sir used to teach before, the same things, positioning it properly, doing it in the main artery is what is required.
Needs more time to be spent on than I think the procedure.
Our procedures nowadays to getting the axis and putting the that thing is taking more time than deploying the valve. Agreed. I think we'll go to next thing. Gokhale sir, you can introduce. Yeah.
So, next case speakers are Dr. Uday Kiran, Dr. Swaroop, and Dr. Rajiv can join us on stage. This is a 70-year-old male with severe paravalvular leak after TAVI deployment.
I think this is another area where cardiologists and cardiac surgeons should work very closely together. Unless you have a very good support from our cardiac surgical colleagues, the TAVR program can never pick up. We have great help with Dr. Gokhale in our place, but all surgeons are not like Gokhale. So what I am saying is combinedly we should think what is good for the patient and try to do good things to patient, be it surgery or TAVR, that is not the issue. But finally, we should work together. Real heart team should go and do good to the patient. Sometimes it could be patient choice, but by and large, patients oblige what surgeons and cardiologists say, I feel. For your presentation, please.
Good morning, everyone. So I'll start with a simple case where we did a TAVI in this patient. So
I think it's simple in TAVI, okay.
So it's basically a run-of-the-mill case, but we'll see what got wrong and how we managed. The age is 80 years, not 70. 80 years old male, non-hypertensive, non-diabetic. So patient is basically dyspnea on exertion functional class 2 since a year, which progressed to class 3 in a month. And in the last 15 days, he had a heart failure admission, which he was treated with diuretics. So ECG was normal. Angiogram was done, which showed only mild non-obstructive coronary artery disease. So I'll go to the echocardiogram. So it's a calcific aortic valve disease, severe aortic stenosis with a mean gradient of 85, mean of 45 and peak of 85. Continuity equation, valve area was around 0.9 centimeter square with mild aortic regurgitation, concentric LVH and good biventricular function. So with this, we evaluated him with a CT TAVR. So CT, before proceeding with the TAVI procedure, understanding the anatomy and anticipating the complications and planning a procedure is of utmost importance. So most of the information for us is given by CT TAVR. So here you can see the dimensions of the annulus, dimensions of the LVOT. So roughly the annular diameter is around 24 and the LVOT diameter is around 22. So this is a funnel kind of anatomy. And look at the peripheral axes. Good peripherals, everything is more than 6 millimeters in diameter. So peripheral axis is not a problem in this case. And we also have the information about the ascending aorta, sinotubular junction, the sinus of Valsalva diameters as well as height. So sinus of Valsalva diameter more than 25 and height more than 15 is very generous, and coronary ostia height also it is very good in this case. So we expected this to be a very simple case to proceed with, and here this funnel anatomy actually protects against development of AR. In cases where the annulus is smaller and the LVOT is bigger, we tend to expect a little bit of aortic regurgitation post procedure. So with this, this is the view which shows calcification. So here this is the non-coronary cusp, this is the right and this is the left. Here you can see most of the calcium is accumulated along the non-coronary and some along the right coronary, and you can, this is at the tip of the leaflets, and at the base of the left cusp also you can see some calcium. This is a slightly horizontal aorta with the angle around 60 degrees. So the only thing we were a little concerned was it was a horizontal anatomy. So we expected a little difficulty in delivering the valve. Other than this, it's a tricuspid anatomy, but functionally bicuspid because the left and right cusps are fused. So as already discussed, we have good diameters, and you can see practically no calcification at all, both on the left as well as on the right. So with this, so this is the sizing chart, extremely important. In this case, we chose a self-expandable valve. Here based on our patient's parameters, and normally balloon expandable we tend to oversize by around 6 to 8% and self-expandable around 15%. So we chose a 29 mm valve. So with a comfortable oversizing of around 20%, because the sinus of Valsalva diameters as well as the height are very roomy. So we thought it would be an ideal to choose a 29 mm valve. So with this background information, we went ahead with the procedure. So this is the secondary access. We always take the secondary access first, but secondary access also needs to be taken meticulously like a primary access, because we never know when we might convert it into a primary access. So ultrasound, fluoro and micropuncture assisted, and this is the primary access. Then baseline angiogram, aortogram, sorry. So here you can see the large non-coronary cusp and a smaller left which is fused with the right. So this is a RAO caudal view. Here you can see the opening of the leaflets as well. Then we did a conservative predilatation with a 16 mm balloon, but I would call it conservative because you are not able to appreciate the waist also. So it's a undersized balloon. The only idea of doing this is we just wanted to make sure that we don't have any issues with the valve tracking in a horizontal anatomy. So in case we went ahead with a safari wire here, in case we had difficulty, we thought we'll take a Lunderquist and go proceed. So we didn't have any difficulty, valve tracked well, and we aimed for a 3 to 4 millimeter depth position. So here you can see the slow release of the valve. So once valve is released and we are comfortable, we initially took an injection with a wire in the LV, safari wire. It showed moderate aortic regurgitation. So then we replaced the safari wire with a pigtail, because the stiff wire prevents your leaflets from opposing, and that can exacerbate the AR. So here initial images had both transvalvular as well as paravalvular AR. So once it is replaced with a pigtail, the transvalvular AR has disappeared. But here you can see there is a constraint on the stent frame near the left coronary cusp, and you can see most of the AR is coming through it. The same was confirmed in a RAO caudal view, and cine in the last you can see there is a constraint on the stent frame here. So the calcium has prevented the stent frame from getting opposed properly. So this we confirmed with the echo. we generally tend to do transthoracic only unless we don't get clear images, as we do it in conscious sedation nowadays. So here you can see from 1 o'clock to 4 o'clock position. So this is a short axis view showing the nicely expanded, nice round TAVI valve with a paravalvular leak. So how do you proceed? This is a 4-chamber view. Here also you can see the nicely expanded valve with a paravalvular leak. So this case, we know the etiology because of calcium, it has not expanded well, and the radial strength of these self-expandable valves are a little low. So we thought we'll go ahead with a post-dilatation, sorry. So here we choose a 24 mm balloon because we cannot exceed the diameter of the annulus. So once post-dilatation was done, this is the final result. Still, you have a mild aortic regurgitation, but hemodynamics were good, and the AI index before post-dilatation was around 20, and now it has increased to 35. So you can see good diastolic pressures in the aorta and a good diastolic separation between the curves. So this was the echo that was done just pre-discharge 2 days after. Patient has an uneventful course then. So here there is almost no paravalvular leak. So self-expandable valves, they continue to expand even after procedures. So post-dilatation plus that component has helped us in disappearing the paravalvular leak. Thank you.
Thank you, Dr. Uday, for presenting that interesting case. And obviously, you'll decide how to tackle the AR depending upon what is the cause for AR. As you said, there's a gap between that and you expanded with post-dilated the bigger side that could seal. Sometimes the calcium, which is nodule-like, which prevents expansion further, and whatever high pressures you use, apposition may not happen there. We might take help of some devices to close. I think we'll hear more about it by Dr. Swaroop. Management of paravalvular leak after TAVI. Over to you, Swaroop.
Thank you.
Good morning, everyone. Dear friends, colleagues, and my teachers, mentors, a lot of alumni around. I thank Dr. Narsivan, Dr. Sachin, Dr. Muthaya for this opportunity. With Dr. Srinivas Kumar was my first cath lab director, and I was trained under him. With the permission of chairperson, we'll start the dates proceeding in the course of next 15 minutes. I'll be talking about PVL after TAVR, its incidence, diagnosis, clinical implications, preventions, management, and future perspective. Feel free to stop me if I am exceeding the time. So moderate to severe PVL incidence was considered somewhere around 7 to 40%, mainly because of the heterogeneity of the methodology. This TAVR started in a patients where they were surgically inoperable or were considered having a prohibitive risk. So right from understanding its importance to the different methodologies used to quantify the paravalvular leak, to the timing of the calculation, whether during the procedure, during discharge or 1 month, and the type of the wall used, whether it's a self-expandable wall or the balloon expandable wall. So there was a lot of variability in the incidence, but the recent meta-analysis has shown that moderate to severe PVL has come down with a better understanding, and it is now around 11.7%, and now it is further coming down, and the most recent it shows around 7%. So clearly moderate to severe PVL is associated with the mortality. The most important to understand, it is associated with mortality in a dose-dependent fashion. And even mild PVL is suggested to have increased mortality, but this point remains controversial. With PVL, often there is a less regression of LV mass, in decreased LV compliance, repeat hospitalizations, and increased mortality. So clearly there is a temporal association between the moderate to severe PVL, and as the number of years pass on, the mortality clearly increases. There are different methods to quantify the PVL, mainly quantitative and the qualitative. So predominantly diastolic flow reversal, or the circumferential PVL across the prosthetic wall, which is the commonest use method. Less than 10 is mild, anywhere between 10 to 30% of the circumference is moderate, and more than 30% is severe. Clearly, you can quantify by the quantitative parameters like regurgitation, volume, fraction, or the effective orifice area. But the most validated for the TAVR is this
where you can see this is clearly less than 10% and it's mild. Here it is 10 to 20%, which is moderate, and this is here is all over, and definitely it's a severe and something needs to be done here. So this method is more validated for TAVR. So let us understand what are the predictors of the PVL and how does it happen and how can we prevent it. So basically it's an incomplete prosthesis apposition. It could be because of the calcium, or it could be because of annular eccentricity. It could be because of the undersizing of the device itself, or depth of the implantation. If it's a malpositioning of the TAVR wall, either too shallow or the too deep also would lead to the PVL because of incomplete sealing. So calcification, its severity, whether it's asymmetrical or asymmetrical, whether it's confined to leaflet tip or the base of the leaflets, and it's in the LVOT, asymmetrical or symmetrical, you can predict the PVL. And by your baseline CT, literally you can predict in which area your PVL is going to happen, and accordingly you can choose a proper device or your strategy to minimize it. So this was a classic slide from Dr. Leferway presented in London wall. Too much of undersizing will lead to a paravalvular leak. Too much of oversizing would lead to the mechanical complication, and annular rupture would be dreaded, and we all know how you may lose the patient on table. So somewhere in between 10 to 15% is considered ideal. You tend to or slightly more than higher side in the self-expandable wall. Balloon expandable wall, you don't exceed more than 15%. And again, in a bicuspid anatomy, nowadays it is advisable not to exceed more than 10%. So these are the four mechanisms by which PVL happens. It is a heavily calcified cup cusp. So no matter what you do, there is an incomplete apposition, and then you have to, this is a trade-off, how much aggressively you want to post-dilate versus you accept some PVL and close later with the device. This is a too shallow implantation, and obviously there is an incomplete sealing, and definitely here, how much ever you post-dilate, it's not going to solve the matter. In fact, it may worsen and it can cause embolization of the wall. So wall-in-wall is the solution here. Again, too deep implantation, again, so-called leads to the in and out phenomenon because the wall is somewhere here and this annulus is unguarded. So again, either you can, with the self-expandable wall, you can snare it to the proper position, or you might have to use wall-in-wall. And this is the most difficult situation where you are undersized, you post-dilate, but still it doesn't oppose and it leads to a severe AR, and later on it might lead to the surgery. So balloon post-dilatation, wall-in-wall, snaring, PVL closure, and the surgery are few of the treatment options, and you have to adapt them in an algorithmic fashion, understanding the mechanism of AR. So couple of cases we'll discuss. So first case Uday has already discussed but this particular patient, because of his 80, right from the beginning, though it might sound controversial, we thought we'll accept the mild AVL because patient was 82. So end result we saw here. Again, I want to emphasize this view. Many times in LAO, everything appears smooth, rosy. But if you see in RAO caudal, because this view corresponds to the short axis of the aorta, short axis of the annulus, and whatever constraint, impingement, especially in the self-expandable wall, you are going to see in this plane. And clearly it was underexpanded or constrained here. And then no wonder it responded to the properly sized balloon. And then it was confirmed both by angiography, hemodynamics, and as Uday mentioned, the post-op echo didn't show any PVL and patient is doing well. So case 2, it's a 76-year-old gentleman post-SAVR 2005. At that time only he required permanent pacemaker. It's a Mosaic 23 bioprosthetic wall. So just brief word about Mosaic. It's an internally porcine leaflet mounted wall with the supraannular design, and the length of the prosthesis is 16. That means it protrudes 13 millimeter into the aorta and 3 below the annular plane. And patient presented with degenerated surgical aortic wall with this severe symptomatic aortic stenosis, normal LV function, no CAD. So we all know wall-in-wall is better than the redo SAVR. So planned for that. And the coronary height here was not an issue because the height of the bioprosthesis was 13 millimeter into the aorta, and the coronary origin was above 15 millimeters. So risk of coronary occlusion is practically less, and the true diameter of 23 Mosaic is around 18.5, and the further degenerated wall, it can be further less. So it was planned for the planning of the procedure is extremely important here. So planned for 23 millimeter evolute R in view of small anatomy and the supraannular design. Plan was to implant TAVR wall directly with 3 to 4 millimeter implantation depth, post dilatation or the remodeling as per the hemodynamics and the PVL. And last option is a prosthetic wall fracture. So these are the basic measurements. I won't go through it. All of us know that. So we chose 23, but emphasis here is coronary height. It was 17 and the 15. So risk of coronary occlusion was less because that can be a dreaded complication in VIV procedure leading to significant mortality. And one point here is the markers here of the bioprosthetic wall are on the top of the frame, not at the bottom of the frame. So we had an experienced team doing this procedure, and usually those who are familiar with self-expandable wall, it's the fourth node you match to these markers. But taking all the precautions also, we ended up in the situation where we had a significant gradient post-TAVR and a significant paravalvular leak. So we decided to post dilate, and if you see that picture clearly, you know the mechanism of PVL here. Clearly it has a shallow implantation and the waist is seen somewhere below. The anchoring should have happened there. We deployed this wall too shallow, and this further post dilatation is not going to solve the issue. In fact, it may embolize the wall and can cause further complications. So only issue here was wall in wall TAVR. So we started with VIV wall, ended up with VIV TAVR and TAVR in TAVR. But ultimately the patient ended up with a good result. There is no paravalvular leak, no coronary occlusion, and there were no significant gradients across the TAVR wall. Now we discharged this patient on oral anticoagulation because of the complexity of the procedure. 6 months down the line, yesterday only he came for the follow-up. 6 months down the line, he is doing well, no paravalvular leak, and mean gradient is around 6 to 8. So this was immediately after discharge. So last case example in self-expandable wall factors associated with significant PVL. It's a greater mean annular or the LVAT area, and the most important what Uday was mentioning was annular eccentricity and the LVOT area more than the annular area, kind of funnel-shaped landing zone where you can have more AI because sealing doesn't happen here if your LVOT is wider than the annulus. So 76-year gentleman, again severe aortic stenosis. He was planned for PCI with TAVR. After the family discussion, RCA PCI was done transradially, and after 48 hours, he was planned for TAVR. Again, it's a large annulus, bicuspid wall, type 0. We know the challenges which are there, but good for us was LVAT area was lesser than the annular area here. So large anatomy. Our plan was because of the bicuspid wall, pre-dilate with 20 millimeter balloon. LVOT area is less than annular area, so we consider this a low risk of PVL. Choice of the wall, we thought 29 mm sapien with nominal recommended volumes. Walled implantment in an implanter's view, relatively higher implantation because of the bicuspid wall. And if there is a significant PVL, we would have post-dilated with 1 to 3 millimeter of overfill because up to 5 to 7 ml it is considered safe. So pre-dilatation was done. We understood where the anchor is going to happen. Wall was positioned relatively shallow. There is a foreshortening from the ventricular side, and we ended up with 90 to 10 deployment. Post-wall hemodynamics okay, no gradients, no PVL. So you can identify PVL by angiographic, echocardiographic, or hemodynamics, but idea is there should be concordance between all three before you label that as a mild, moderate, or severe paravalvular leak. Key to success, last couple of slides, proper sizing, thorough CT analysis and understanding of the anatomy, understanding of the sealing zone and the landing zone. The interplay of the sealing zone and landing zone is extremely important, and stepwise education of the procedure and approach to the PVL. So understand the mechanism of PVL and then execute it. To conclude, ladies and gentlemen, moderate to severe PVR post-TAVR is associated with increased mortality in a dose-dependent fashion. Procedural planning, proper sizing of the wall, and implantation technique. Trivial to mild PVL can be achieved in majority of the patients. Newer generation devices with improved sealing mechanisms do play important role to reduce the incidence of PVL to a single digit. Understanding the mechanism of PVL is most important to treat it successfully. Technical innovations like non-invasive debulking of the calcium might play a role in future.
pressure overload condition should not be converted into volume overload condition so that patient gets long-term or the lifelong benefit of the therapy. Thank you.
Thank you, Sarith. I think we have benefit of having Gokhale with here. Before we go on to Dr. Raju's comments, what in your mind in today is big no for surgical AVR and you prefer TAVR? In today's era, what do you think is the most problematic for surgeon to offer surgical AVR and you prefer TAVR? Apart from patient's preference, obviously. Big no for surgical, where you are worried more to do a surgical aortic valve replacement and you prefer TAVR? Obviously, you are a patient messiah, a patient wants TAVR, you send for TAVR, that's different. But where the surgeon doesn't want to operate, that's what you want.
Yeah. See, for example, you get a redo post-coronary with a patent lima and patent grafts, and patient is, say, past 75 years of age, and as aortic stenosis suitable for TAVR, certainly I will advise him TAVR as a first option.
Redo surgery, right?
Instead of redo surgery.
Yes.
And second thing is, of course, if you think the lifespan is not very good, patient has got multiple problems, maybe 5-6 years, even if it is a little younger, I would give them the option of a TAVR. And naturally, if I have a problem in doing a redo for some other reason, like the patient is 80 years, has come for a redo operation or even for primary operation, I think anyone past 70 years, I have a low tendency to talk about TAVR for these patients. But certainly less than 70 years, where it is a primary or redo, I think I would opt for
LV function, does it matter?
Yes, of course. You see, LV, as he said, porcine aorta and LV function in younger patients with severe aortic stenosis, still I would keep surgery as a first option and TAVR as a second option. But the age advances, as the redo issues like that, then TAVR takes preference over TAVR for me.
Very nice to say that redo is a problem. Gokhale agreed, but there are some surgeons who operated on a 75-year-old valve degeneration, surgical valve degeneration, again repeat surgery they want to do it. And that's a different choice, but again, as I said, redo surgery definitely, patients once they experience surgery, they have terrific feelings also. They don't want to go through pain of surgery again. They don't want it. I think that is where an area we can easily. Your expert comments, otherwise, Ajay, you want to say anything?
Yeah, just...
I think we're running behind time.
Yeah. Let him talk to you.
Rajiv will.
Yes, please.
Gopishan. Oh, very good to have Dr. Gopishan
I'm
also
really
here.
sorry to say that you people picture as a redo surgery as something which is worse than TAVR, and so Dr. Swarup also mentioned, we all know TAVR is better than redo surgery. But we have some data to support that, sir. Yeah, we have some randomized study that I would like to see. Okay, so I don't believe that you can make these kind of decisions as a generality. You have to go with the patient's parameters. He's a 75-year-old patient. If he has at least 10, maybe 15 years of expectation of life, redo should be considered, especially with a milder coronary artery disease. I don't believe you can just sit and say that TAVR is better, go ahead. You have to have a clear-cut parameters defined, both surgeon and the physician, to sit with them and then discuss about the possibilities of one thing or other. We can't just say that redo. Dr. Srinivas Kumar commented that why do you want to do redo surgery? Why not?
Right. Actually, there is, for your information, this data, not to upset you, sir, this data, leave about redo. Even
I'm not going to get upset.
No,
This is an
even for the
academic meeting, we should-
even for the let me tell you, even not redo, even 75-year-old plus, even first time surgery, TAVR has some advantages over TAVR. Let us not get into it. Your expert comments.
Just a couple of them. One is, I think, the important point which Swarup mentioned is how much PVL are we ready to accept, depending upon the age, and not run behind him, behind the PVL and then land up with a valve embolization. The second aspect is there are times when, in spite of all the things which were mentioned, you might not be able to quantify the PVL properly. Do not have hesitation to put in a TE probe and make sure that you have confirmed before you come out of the cath lab. That simple decision can make a huge difference to the patient. So you should have a low threshold to put in a TE probe if there is no clarity, there is no definitive clarity on the extent of PV.
Yeah, when he presented, we generally do transthoracic. That's what I was thinking, Rajiv. I think another important aspect is analyzing the CT ourselves. Like though companies come with the various reports, sometimes they tend to underestimate, overestimate the valve size. So you have softwares. If you don't have 3 Menso with you, for people who are interested, EndoVs or various other free softwares are also available. And try and calculate the valve size yourself. And also analyze where is the calcium chunk sitting. If the calcium chunk sitting on one side, then if you include that also, sometimes you end up with ruptures. So you have to balance it out and say how much it should be planned, and if at all you want to get a good result. I think paravalvular leak is not much of a problem now, but still where surgical colleagues fare better is conduction disturbances. That's where we need to improve further upon compared to surgical AVRs. I think if you're running any...
Yes,
Bhupesh?
sir. Just one comment. See, I agree with what Dr. Gopichandra said. I think we should not deny the patient a redo operation just because of, because 75 years or 80 years or something. Look at the literature, the redo aortic valve replacement carries a risk of less than 3% in good hands, in good centers. I think we should not deny them the chance of, redo operation. That is number one. See, if you look at the guidelines, as Gopal has rightly pointed out, if the patient is above 80 years and if the life expectancy is less than 10 years, then TAVR is recommended. Right? If more than 10 years, I think probably surgery will be best. And now we've got valves like Inspiris valve, which they claim they work for 25 years. Like the Inspiris Regalia valve, which has come out recently, they claim that it works for 25 years. So if a patient is 70 or is 75 years of age, if you do redo surgery with these valves, I'm sure in the lifetime they'll not have any structural valve degeneration.
So may I say so?
Yeah.
Regarding the valve, excellent cases. Regarding the valve-in-valve TAVR, in Sinai we have a protocol. If it is valve-in-valve TAVR, TE probe will definitely be going for sure, especially for mosaic valves where you cannot see the annulus. So my suggestion is to put a TE probe, especially when you are utilizing a self-expanding valve, because you can't know where you want to leave the leaflets. If it is a valve-in-valve, please have a low threshold put to go for TE. That will save the day actually. And regarding the valve-in-valve redo, the US FDA, not FDA, US Medicare, Medicaid do not reimburse if the TAV in SAV is a low risk. So the surgical assessment of risk is mandatory there. They don't consider age also. If the ST is going to be less than 3, they will not reimburse. So that is still an evolving concept. Different schools of thought, we can talk about it later.
Thank you. I think if there's no further thing, we're running behind schedule. Thank you.
Thank you.
Good morning, friends. A brief change in program. Dr. Nagesh Reddy has to leave a little early, so we're just having a brief inauguration right now. May I request Professor Krishnam Raju, Dr. Somraju to come over to the stage, please. As was said, I think there is no better place than medicine to realize that we are standing on the shoulders of giants to see what we have achieved, whether it's Gibson in surgery or whether it's Osler in medicine. There are several people, the shoulders of which has helped us to practice the medicine the way we practice. I would like to invite Dr. D. Nagesh Reddy, Dr. Somraju and Dr. Krishnam Raju to take over and occupy the dais, please. Dr. Kumar, sir. Dr. Kumar, sir, this side, sir. Rajiv, come this side. Would like to have a brief comment from each one of you before we get started with the inauguration.
Good morning to all of you. Am I audible?
Yes, sir.
Okay. It's very exciting and very pleasant experience to see some of our colleagues who have been with us for many, many decades, and some of you have been with us as students. So it indeed is a great honor for us to inaugurate this session, which is going. Sorry, it wasn't working all right. So I am particularly excited to be here to inaugurate this program because I see happy faces of so many of our older colleagues from medical cardiology and surgical cardiology, like Gokhale, Dr. Gopichand, and etc. Some of our students who worked with us for many years. So Dr. Narasimhan and we first did this cardiology update program for DNB students in 2004. If you remember, that was the very first in the country. It was a 1 week long program from 7 a.m. to hold your breath, 12 in the midnight, including a boat trip in the Hussain Sagar and program on the boat in the lake. Okay, so I have very happy memories of that, Narasimhan. Yeah, that was clinical cardiology, but also every day in the morning, 7 to 9, we used to have how to do a procedure like dobutamine echo, transesophageal echo, and nuclear imaging and cardiac CT, cardiac MRI. All these things were demonstrated step by step, and also IABP insertion, temporary pacemaker insertion. So I have happy memories of that. So thank you, Dr. Narasimhan, for putting out this very nice program. But
Right.
we woke up to the bad news of Dr. Mohan Nair's passing away.
Right.
So that,
It was a very sad
put me
news that
moved
happened.
a little bit because I had known him to some extent.
May I request Dr. Nagesh Reddy to come out to the dais, please?
Welcome, nice ready. Welcome, nice ready.
Thank you, sir.
Morning to all of you, and it's a wonderful time to be together and seeing all of you. I think some of us didn't see each other for a long time, not only because of the way we are located, but also because of COVID. I think this conference brought some of us together. But having said that, I just wanted to say a few things. The title is Cardiology Beyond Guidelines. We are already practicing a lot of things outside guidelines. The way medicine is practiced today, guidelines are not followed for a variety of reasons. We call it business of medicine or ignorance or whatever you may call it. But having said that, I heard some of the surgeons talking, Dr. Gokhale, Dr. Gopichand and all. Certain things I tend to agree with them. The reason why we need to question the guidelines, I agree. It's like, we are all the same, but we are all different. Each one of us are different. But having said that, there is a nice saying by Goethe. What is general? It is individual case. What is specific? It is millions of cases. So that that gives us the clue as to the importance of individual experiences, individual clinicians, individualization versus so-called guidelines and clinical trials or randomized trials. But having said that, I just wanted to also bring up one relatively political issue. Namely, it is often said the patient comes to me as a triple vessel disease, left main, and whatnot. And I just say as a cardiologist, patient refuse surgery. And then I offer angioplasty today. The word patient refuse surgery is political. The patient never saw the surgeon adequately. The cardiologist, only the patient knows. And then there is a lot of behavioral economics involved in it, in these decisions. When you say behavioral economics, it is something like, the nature of the cardiologist, the attitudes of cardiologists, the business of medicine today. That's one. The second issue is the other side, the surgeon. Whenever you are a surgeon too busy, and surgeon is also rich, they also refuse a lot of surgeries. So be aware of it, and thank you.
Thank you. I would like to welcome Dr. Nagesh Reddy, who has been the chairman of this wonderful institution and has fostered a culture of education, research, and excellent clinical practices. If there is some time during lunch, we have arranged a thing to the research wing, which is exceptional, that he has conceived and built over decades, right from animal lab to genomics lab to PCR. Everything, our sarcomeric mutations are identified here itself, and downstream metabolomics are possible thanks to the visionary ideas that Dr. Nagesh Reddy had, and meekly performances of reviews, and very close interaction between the clinician and the nurses, which has been made possible to offer the best of medical care to most of the patients who come to this door. And he has been a tremendous support in terms of fostering the education and research activities within the institutions and beyond. I would like to invite him to say a few words and then inaugurate the meeting.
Thank you, Dr. Narasimham. For me, it's a pleasure to be a part of this inaugural ceremony. In fact, my personal icons were Dr. Somaraju and Dr. Narasimham. When I came back from PGI, everybody used to tell us that you should at least try to be a little like Dr. Somaraju and then, of course, Dr. Narasimham, and to be a part of this community. For me, it's a pleasure.
Thank you, Nagesh Reddy. But he used to believe it. Now that now I'm here, he's seeing me directly, he's disappointed.
I think this topic, cardiology beyond guidelines, I think is a very interesting concept. It is very important because all of us blindly follow guidelines. I am a part of guidelines of many international guidelines of gastroenterology, and I have observed that there's so much of subjectivity involved in this. In fact, if you look at major guidelines in gastroenterology, I don't know what is happening in cardiology, but major guidelines in gastroenterology will give a guideline, and below they will say strong recommendations, low level of evidence. So most of the guidelines that we have, because we don't have a lot of science, RCTs behind so many things, it will be all very strong. So the committee says strong recommendation to do this thing in a patient, but the evidence is low. Unfortunately, that's what happens. So I think very often we have to go beyond guidelines. Last week we had a major international workshop where we called all the leading women actually to do procedures. And the person who was the chair of all the guidelines in Europe was doing a procedure and doing something against the guidelines. So people asked her, "You are the guidelines chair and you're doing opposite." She said, "That's what the guidelines are for rest of the people to follow." So that is something that happens, and I think I'm sure in cardiology also these dilemmas are there. Very often there are other issues which have to be followed rather than guidelines. So I'm extremely glad that the conference of this nature is going on. I wished I could stay behind and hear all these things, but I have to rush off for another meeting in Bombay, so I won't be there. But nevertheless, congratulations. I think our team, cardiology, are very proud. I think they're doing a fantastic job. I am biased, but I think it's best in the country. Thank you.
Thank you so much, Natin. Would like to, Dr. Kumar, Dr. D.M. Kumar, sir.
I can only say it's an honor to be speaking a few words in the company of giants like Krishnamuraju, Dr. Somaraju, and now Dr. Nagesh Reddy. I can proudly say we always carried education as a part of our life throughout. The education was not only at medical professional levels, but at every level. That's what the care hospitals implemented. I'm very happy to see that the same tradition of education is going on probably at a higher level, and a research component, a great research component, has been developed by Dr. Nagesh Reddy. Congratulations, Dr. Nagesh Reddy. I wish that you continue like this for many, many years to come. I wish the gathering all the success. It's a great going. Congratulations.
May I request all the dignitaries to come over and light the lamp and declare the program open. Get the
आरोग्यं धनसम्पदा शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय श्रीपज्योतिर्नमोऽस्तु ते श्रीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय श्रीपज्योतिर्नमोऽस्तु ते श्रीपज्योतिर्नमोऽस्तु ते
Thank you all, and I think Dr. Gopichand also is to catch a flight, so we will finish the next topic, which is on recent advances in cardio. Mutaya?
The next talk is delivered by Dr. N. Bhupati from Sri Ramchandra University. It's on recent advances in interventional cardiology. And Dr. Ramesh Kudapati, Dr. T. Shashikant, and Dr. Gopichand will be chairing the session.
Type C.
Good morning, everyone. Thank you, Dr. Narasimhan, for having us here for this session here. The rate at which research is going on, the advances are going on, it's just as big as the universe, what we are seeing in with the big telescopes nowadays. I think Dr. Bhupati is ready with his slides.
Yes, sir.
Go ahead, please.
Yeah. Slide changing. Pointer. Okay. Thank you for this opportunity, AIG Care Foundation and Professor Narasimhan, sir. It's an honor to be here in front of all my teachers, mentors who taught me how to auscultate. So I have segregated the topic that has been given to me as TAP advancements that has happened in the field of interventional cardiology. That is from my perspective into chronic coronary syndrome category, ACS category, structurals, heart failure, revascularization category, and pulmonary embolism. Chronic coronary syndrome, since it's a kind of case-based program, I would like to present this particular patient, a 70-80-year-old male. The presentation may not be completely true. It has been modified according for this particular scenario. 78-year-old male admitted with exertional symptoms, hypertensive. She had CMT muscular dystrophy, AEF of 55%, and stress MPA revealed severe ischemia in the LAD-RCA territory. Lab-based parameters were reasonably okay. Should we do angiogram in this patient who has got a moderate to severe stress test? We all know, most of us would have done it, but what is the evidence for the same? So we all know about the ischemia study published in NEGM 2019, which clearly randomized patients into two category, invasive and conservative category. And it concluded that at the end of median of 3.6 years, there's no difference in 4 years, there's no difference in the primary outcome, which is CV death, MI, heart failure, and resuscitated cardiac arrest or hospitalization for unstable angina. So there was a significant amount of sounds heard across the world regarding the need of angiography in this particular patient. What we actually learned from ischemia is an initial conservative approach and the invasive approach are equal. The initial invasive approach does not decrease the mortality. However, we often forget that the initial invasive approach decreases the spontaneous myocardial infarction. It's a hypothesis generating subgroup analysis data. And if the patient has got significant angina, it definitely decreases. Limitations. This is the point that I would like to emphasize. We often forget that the particular study excluded patient with left main disease. They had a mandatory CT angiography or a conventional angiography to disprove that patient does not have any significant left main. ACS within 2 months were excluded. Severe LV dysfunction was excluded. Cardiogenic shock was excluded. Patients who are highly symptomatic with symptoms with angina were also excluded. So our patient had a significant angina. Ischemia was moderate to severe. And this is the latest publication from the ischemia study, which showed that can we identify patients without doing angiography from the non-invasive data that is available by utilizing whatever the significant findings in the stress test. There's significant ST depression, transient ischemic dilatation, or significant more than 4 segments of ischemia observed in the dobutamine echo. Yes, it correlated with the presence of left main disease. However, the C static was quite low, so the particular study subgroup analysis of ischemia says we cannot rule out a left main disease irrespective of the findings observed in the non-invasive finding. So they concluded that it is essential to do an angiography or a CT angiogram even if you follow ischemia study. Point number 1. So this is the angiography of the index patient. We have got a significant lesion in the mid LAD and a borderline lesion in the proximal segment of the initial portion of the proximal mid LAD junction. RCA, critical lesion in the distal RCA, long segment lesion in the mid RCA. So yes, to answer the first question, definitely we needed angiography, even if the patient, if you are a strong evidence-based medicine practitioner, also it is essential to do angiography to know whether left main is there or not, especially. So why ischemia failed is a different question. The hypothesis, again, subgroup analysis of the ischemia study showed whether complete revascularization is better than incomplete revascularization. This is one important point, though it is presented in 2021, published in 2022 early. So I am confining myself to most of the evidence published in 2022. So the completeness revascularization study clearly showed that there is a significant difference between complete revascularization and incomplete revascularization as compared with conservative strategy. Complete revascularization, whether it's anatomical complete revascularization, functional complete revascularization, they did better as compared with conservative category. So again, it's not the primary hypothesis of the particular study. So these are all the subgroup analysis. We have to take it with a pinch of salt. So any study that we may come across later regarding complete revascularization, similar protocol with complete revascularization as a primary hypothesis generating study in future. So as of now, the subgroup analysis showed that complete revascularization, if at all you are going for ischemia study, you have to do angiography or CT angio to rule out left main disease. And if you rule it out, if there is no disease and the patient has got significant angina, is excluded again. And if you are going for invasive strategy, go for a complete revascularization strategy so that the patient may get some amount of benefit in the form of reduction in even CV death or MI. So yes, it's a subgroup analysis, hypothesis generating. If at all, as I told earlier, you may go for a complete revascularization strategy. So you have to stratify the strategy of revascularization accordingly. Long segment CTO, if you think that it cannot be revascularized percutaneously, better send the patient for cabbage rather than partially revascularize the patient and do an incomplete job. So this is our index patient. I will go through the case relatively fast because of want of time. We did a PCA utilizing IVL for the LAD, which was image graded. We optimized the results. This is the I will go with the final shot for the LAD. I hope you guys remember the Remember this is the final angiography. There was a calcified nodule in this portion of the LAD. We didn't target. Usually, I target more than 90%. We have burnt our fingers targeting more than 90%, especially if there's a calcified nodule. So this portion of the LAD had an area of more than 80% as compared with the proximal reference area. Hence, we stopped at that portion, at that level. And then we proceeded with the RCA PCA after a week. After encountering significant difficulty in from the groin, this time we were wise enough to go radial. Since it's a radial with a JR guide, we utilized the guide liner, put it in the RCA, and we rotablated the RCA through the guide liner, and then we finished the RCA intervention as usual techniques. So there was edge dissection proximally after placing the second stent. Then we have had to put another stent to tackle the RCA. This is the way how we stopped RCA. So this patient underwent complete revascularization. So I believe he will have a better outcome. So there are some physicians who still believe that we may have to do routine functional testing post PCI. So this is the study published in NEJM post PCI, randomized one, more than 1,500 patients, 1,700 patients from Korea. So this particular study included 20% left main disease intervention, 43% bifurcation, and more than nearly 70% had multivessel and 70% had diffuse long disease. In spite of having such a complex scenario, at the end of 1 year, they did functional testing and found the outcome, what is happening at 2 years. They found that there is no significant difference. So absolutely, there is no need of post PCI functional testing unless the patient has got some symptoms. We have to be very clear. There are people who even do angiography. When there is no need to do a functional testing itself, absolutely there is no need to do angiography unless you believe that you did an incomplete job or some other specific reason is there, last surviving vessel, you don't want to take a chance. Otherwise, it is not needed. So coming to the second category, acute coronary syndrome, should I cath? There is no significant advancement that has happened in the field of STEMI actually. This is the only thing that has happened in the field of acute coronary syndrome. Should I cath all NST-ACS patient urgently? Here is a patient, 52-year-old male, controlled diabetes, ACS, non-ST elevation MI, good LV function. The available data says that there's a significant amount of discordance. There are almost 20-25 trials have been published. The meta-analysis of the particular study was published in European Heart Journal, which says that this is the list of studies that have been published. Says that absolutely there is no benefit with whenever we do an early invasive or urgent invasive strategy as compared with the conservative strategy, that is going for angiography after 3 days, providing good amount of antiplatelet and anticoagulant for such patients and going for it. Except for recurrent ischemia. If the patient is going for a conservative strategy and the patient develops recurrent ischemia, you have to cath the patient again. So even in a high grade score situation also, they didn't found a significant difference. So in this particular meta-analysis, in all comers have non-ST elevation. It's all comers, not very high age grades, all comers. An early invasive strategy is not going to be beneficial by reducing all-cause mortality, CV mortality. So you can comfortably sleep if the patient is hemodynamically electrically stable, clinically stable at 12 midnight or Saturday night, and do a cath on Tuesday or Wednesday if there is no clinical worsening. This is our particular patient for whom we did cath. This was in 2015. He had a long segment bifurcation in the circumflex and there is a borderline lesion in LAD. We did FFR for this particular patient. It was significant. We sent him for cabbage. Cabbage was done. He's a diabetic, so it was after freedom. So we sent it was easily we could have put a stent. Thanks, we didn't intervene with percutaneous. 3 weeks later, he presented with the empyema of gallbladder. But for cabbage, I would have been in a mess treating a 2-stent strategy in circumflex and single long stent in LAD. He did well after gallbladder removal surgery. So there is absolutely no need to do cath for non-ST elevation acute coronary syndrome patients. For all comers, for selective patients, yes, we should definitely consider. So should I use FFR imaging or anatomy to assess borderline lesions? Yes, this question has been answered clearly. Let's go with this particular patient. 60-year-old patient. She had acute coronary syndrome, 2015 or 16, I don't remember exactly. We intervened her LAD and RCA at that point of time. She comes back again with a kind of exertional symptoms and one episode of rest pain. So indication, this patient should this patient go for an FFR guided physiology or IVS guided physiology? Yeah, this has been answered by this particular study. I show the angiography later. It's a flavor published again in NEJM last month, presented in August, ACC last year actually, where they randomized 1,700 odd patients. All of them, one key point here is all of them are borderline lesions. None of them had a lesion more than 70%. They found that they followed a specific, criteria to identify whether the lesion is significant or not. And after intervening the lesion, they used specific criteria to know whether we have done a good job or not. So we should follow this criteria if at all we want to follow this particular evidence in our clinical practice. The lumen area less than 4 is not the only thing that needs to be emphasized. The plaque burden should be more than 70%. The lumen area should be less than 3, irrespective of the site of the lesion, if we are following IVS. If it is FFR, we all know it's less than or equal to 0.8. And after FFR, to have a better long-term outcome, the value they have represented is 0.08. Or a delta FFR across the stent should be, and the delta FFR across the stent should be less than 0.05. And they found that, let me go to the primary outcome, they found that there is no difference between FFR guided angioplasty and optimized angioplasty and IVS guided and IVS optimized angioplasty. So limitation, as I told earlier, all are borderline lesions and they have not, we cannot extrapolate the same results to OCT at present. So this is the final conclusion. This is our patient. She has got a borderline lesion. She had a critical lesion in the distal RC which was intervened, borderline lesion in the LAD. This was an interesting phenomenon. What we know, initially we thought of doing FFR. However, once we put the FFR wire, there was a good amount of accordion effect. So FFR was significant. So I don't know what is the influence of accordion effect on the particular by accordion effect and the lesion on the FFR value of the particular epicardial vessel. So that was the reason for me to go back and look at IVS. IVS showed a luminal area of 2.47 with a plaque burden of 75%. So we intervened the lesion. We put a long stent inside the ISR segment and then we dilated with a good amount of good non-compliant balloon and also with an OPN high pressure balloon. We got a reasonable 6.3 area in this particular segment. Then we did FFR again, it was still significant. Then I realized, okay, FFR will affect the accordion will affect the FFR, and luckily this same thing has been published in JACC cardiac intervention. So whenever you put a wire, a new lesion occurs and you don't trust the FFR, it's going to be positive. You may go for IVS in this particular situation. So yes, both can be utilized if you are assessing a borderline lesion. Another important thing coming to structural, sentinel for all in TAVR, 82-year-old male, diabetic hypertensive, severe aortic stenosis, class 2 symptom, normal LV function, calcified RCA disease, CT TAVI protocol done, incidentally diagnosed CA lung. He was a heavy smoker with a satellite nodule in the another same, left mid zone. He has got another nodule. Left upper lobe he has got a mass. I declined TAVI in this particular patient. Went for palliative BAV and PCA. We had a multidisciplinary meeting. Oncologist was categorical that he should go for a curative valve therapy because his predicted survival is more than 40 to 50% at the end of 5 years. So now we rechanged after this having multiple discussion with the family and multidisciplinary meeting. We changed our decision from PCA BAV to PCA TAVI. Family agreed with the plan. Family do not want to have a stroke. The risk of stroke, major stroke, is definitely decreased with sentinel in our observational findings. So this is the CT scan anatomy. Let me go through the slide relatively fast. The anatomy is suitable for is relatively a run-mill case for a TAVR. This is a tight RCA disease. So what does the evidence say? This case was performed by us in last year June. However, the study published here is in August 2022. Protected TAVI, more than 3,000 patients have been randomized in this particular study where any kind of valve could have been used. However, the patient should have received sentinel on one arm and no sentinel on another arm. Just to brief about sentinel protects 1.5 cerebral arteries. It does not protect the left vertebral artery. So these patients, the primary outcome is the major stroke. I found no difference for all stroke. However, there was a trend of difference in the major stroke. The conclusion in the NEJM trial was actually NEJM was quite amazing. I do not want to go into the conclusion. When there is a negative study, we have to accept that it's a negative study. Unfortunately, the result of there was a good amount of debate going across the world regarding the result, how the trial was projected in the NEJM conclusion itself. So from my perspective, this is a negative study. However, in our index patient, we put a sentinel and we got this mug. Whether this would have created a major stroke in this particular patient, we don't know. So in our patient, we did a PCA to RCA utilizing rotablation, and we went ahead and put a sentinel and did a valve with a 29 millimeter balloon expanding sapien valve. He is doing fine. 9 months now, he had a radiation-induced pneumonitis for which he was admitted. He has been discharged last week from our hospital under oncology services. So, from my point of view, sentinel is not required for all TAVR patients. It's a shared decision making. It adds cost to the therapy. The benefit has not been shown. However, in my clinical observation from my training period also, I have not seen any patient who has developed a major debilitating stroke with sentinel. That has to be told to the patient. If the patient is willing and take that risk of can afford the therapy of sentinel, I would go with sentinel on any day. Heart failure. This is a patient for whom we intervened in 2018. 82-year-old male, known triple vessel disease, the LAD circumflex RCA disease, RCA 100% occlusion, severe LV. He present in almost 10% ejection fraction status. He medically stabilized. He also had a mild to moderate aortic stenosis, had a CKD stage 3. We did, am I done? Do you have time? 2 minutes. Okay, let me go through it. Yeah. So we have we did dobutamine echo to assess the low flow, low gradient, which was actually not significant, no increase in gradient. However, he had chest pain during dobutamine. Then we did viability, and CMR showed viable myocardium in the LAD and circumflex. Let's come to this criteria revive study. Revive, this is published again in NEJM. It's randomized more than 1,500 patients in with the primary point is with viable myocardium. With viable myocardium, that's a key point here. They found that irrespective of providing revascularization, optimal medical therapy is equivalent to PCA with optimal medical therapy, and there's no decrease in all-cause mortality. That's a key point here. There was some decrease in spontaneous MI, however, they are all hypothesis generating subgroup analysis. So they did a lot of analysis in this particular patient to identify patients in whom PCA could have helped. Absolutely no benefit, and they also did whether this ejection fraction will improve after PCA. There was some improvement later, however, there was no difference seen at the end of a couple of years. So they concluded that severe LV dysfunction patients who are having a good amount of LV dysfunction, less than 35%, non-cardiogenic shock, no VTs, viable myocardium, the optimal PC medical therapy is equivalent to PCA and optimal medical therapy. So this is put question in front of myself. In my index vascular patient, I revascularized the particular patient. He lived for 4 years from then. He passed away last year January because of COVID. In spite of repeated advice by me, he didn't take COVID vaccine. So should he be revascularized in 2023? I would discuss now with the family that available evidence is not strong, but us, the senior colleagues, were clearly telling we cannot go with guidelines alone. This guy, I don't think he would have survived for next 4-5 years, 4.5 years without revascularization. Out of routine, out of box topic, pulmonary embolism. This is, I think this is a very, very important thing. Mortality of a massive PE is 30%, submassive PE is 8 to 15%, which is higher than a routine STEMI patient in our population. So this is it's a registry flash published from Europe, US and Europe, where 800 patients of the patient, with the majority being intermediate risk pulmonary embolism, underwent float fever, which is from Inari Medicals. It's a 22 French sheath going to the right femoral groin, all the way put it into a pulmonary artery, and then suck out the thrombus. That's it. And then they found that the mortality is in those particular 800 patients is something around 0.3%, and the RV pressure improved significantly. Though there is no randomized study that compares this particular mechanical thrombectomy device versus low dose or regular dose thrombolysis, I think this will change the way how we are managing such patients with thromboembolism. With this, I would like to conclude my talk. Thank you. I might have gone fast because of want of time.
Thank you, Dr. Bhupati. It was an excellent presentation. Actually, this is a time which is very exciting for interventional cardiologists. A lot of advances have taken place in the field of interventional cardiology. As you have pointed out, in coronary area, we got a lot of new devices which have come off late, which are making a big difference in terms of how we revascularize the patient. Similarly, in the structural area where we have, apart from the aortic valve, the mitral and the tricuspid valves which are coming up, then the endovascular repairs which are available for us. And then, of course, we are stepping into new areas of acute stroke intervention where cardiologists are playing a role. So these are all the exciting areas. But what is important, as you have pointed out in your talk, is where to do which procedure and what's the benefit which you are going to get out of it. But here I would like to, recall a small story which my professor used to tell me when I was in my MBBS. When you are an MBBS guy, you show a cow and you ask what is it, they'll say it's a cow. But when you finish your DM and then you ask him, you show what is this, they'll tell it can be a hypertrophic goat, it can be a hypotrophic elephant, or it can be a cow. So let's do a DNA test to decide whether it's a cow or not. So similarly, if you look at all these trials, there are a lot of confusing data which might come out in which patient, what to do, how to do, and when to do. And similarly, when we are doing an intervention, which device to use and when to use. I think the most important thing is the common sense in terms of the background knowledge which we have. But at the same time, we should know all these trials, understand what is the essence of that trial, use our common sense, and then go ahead and do the procedure. That's what I feel. Yeah, nice presentation. Thank you, sir.
So one more thing, I think your professor and my professor would have been taught by same professor. I also got the same stories.
I think the points made by Dr. Ramesh is very, very pertinent. The ischemia trial, I think at least 50 to 60% of my patients do not fall into the ischemia trial in your day-to-day practice. So it has got its limitations, which are very major limitations. So, and again, as for a STEMI patient, end-STEMI patient who is a diabetic, I would just not sleep over the weekend to cath him or do an angiogram. I think I would prefer to do a early study of the anatomy, then take a call whether I would do an intervention or not. I would not just take it easy, even if the data shows something different. The incidence of mortality and events rate is very high in patients who are end-STEMI. So I think we should individualize each patient and take a decision rather than going by the trial data what we have there. Thank you for your nice talk.
Thank you. That's actually a very interesting presentation of the data that's available, and perhaps at some point it's very confusing, but it highlights the point that you need to be lifelong learner, and what Narasimhan has done, putting things beyond the guidelines. Actually, your talk highlights that. But having said that, can you actually do nothing in presence of a triple vessel disease in a person who doesn't have symptoms, but we know that at some point he may get into an event. So where do you call? And Ramesh has just pointed out, for common sense after the knowledge is a very important aspect. The most important is that we are living in an era of technology which is making both functional assessment and anatomical assessment very easy and accessible. We don't know the full story of how to interpret them. And on the other hand, you have a very short follow-up. The PARC study is only 2 years follow-up, sorry. And then the other one also you mentioned there's a 2-year follow-up. So, if you look at ART trial, which was surgical trial for bilateral mammaries versus single mammary, there's no divergence in the survival even after 10 years. And there's a 15-year follow-up now where there is a change in the presentation of these patients. So we may have to look at longer term than 2 years to make a recommendation. But on the other hand, common sense, as Ramesh said, going beyond guidelines will become an important part of your day-to-day practice. Thank you for a good presentation.
Thank you, sir. But after CABG, so most of the surgeons don't do a routine functional testing or a CT angiogram, right, sir?
Yeah, we don't follow them up. We send them to cardiologists. But ideally, when where I was trained outside this country, we always did 1 year TMT to make sure that they're not in trouble. But again, that's intuitive. There's no evidence to that.
Yep.
I think basically we have to individualize. Suppose you have a patient, you've done left main to LAD, circumflex, complex, bifurcation, stenting, and he has a limited mobility or restricted. Symptoms may not be the guiding criteria. You have to look for inducible ischemia in this patients and follow up. You can't say that particular trial says you don't do stress testing, so I won't do a stress test. So I think that's where that's what I meant when I said.
Yes, I am also with you all, sir. I mean, I would call myself as interventional cardiologist, but I would like to give a comment, answer the comment what sir told. Once Narsimha sir told me, Bhupati, don't think that only you should do intervention. Doing antihypertensives for hypertensive is also an intervention. So we are not leaving those patients just like that. We are giving drugs that have been shown to change their outcome. Those drugs were not there during CAST study. Those drugs were not there during ART study. There was no powerful statin during ARTS group. So this is the era where we have got good potent amount of potent drug. And I'm very sure 15 years from now, there may be a canakumumab and inclisiran therapy that may eradicate CAD just like how Billroth 2 surgery has been eradicated by PPI. So that is one reason why I went into structural side.
Neurology wants to make a comment.
Thank you, Dr. Bhupati. It's a wonderful and very relevant talk.
Thank you, sir.
But we should make sure that when you give a talk, patients don't attend this.
I think we close. Thank you, Dr.
Thank you,
Bhupati.
sir.
Thank you.
Now we have our 10 minutes tea break for refreshment, and followed by which we'll have a discussion on management of ischemic mitral regurgitation. The next session is on management of a case with hypertension, severe ischemic mitral regurgitation, and LV dysfunction. The case will be discussed by Dr. Praveen Nagula, and a talk will be given on approach and management of ischemic mitral regurgitation by Dr. Rajesh Nair, and the expert comments will be given by Dr. B.K. Shastri. Dr. Prasad Reddy, Dr. GSR Murthy, and Dr. Sukesh Reddy will chair the session.
Okay, now.
I think you will start with the case presentation. Dr. Praveen Nagula is going to present a case scenario and then followed by a talk by Dr. Rajesh Nair on the approach and management of ischemic MR. So Dr. Praveen.
Okay, now, respected dignitaries on the stage and the off stage, my dear colleagues, good morning. I will be discussing about a case of ischemic MR. The case is of a 65 years female. She is diabetic, hypertensive, and she is having history of obstructive sleep apnea. She had a history of CAD, inferior posterior wall MI, and with the RVMI. She was thrombolized with streptokinase, and she underwent PTCA stent to LCX in 2013. Subsequently, within 1 month, she presented with stent thrombosis, and they have done POBA to LCX. She had presented again after 7 years in 2020 with unstable angina. At that time, the angio revealed LCX CTO lesion, and she was medically managed as they could not cross the lesion. Presently, clinically, she is having mild pedal edema, and she is obese with a BMI of 38. And her pulse is of 86 per minute. Her blood pressure is 160/90. She had a pansystolic murmur at apex with bilateral basal crepes. She could do her daily activities with no much problem. So this is the ECG of at the time of the presentation. You could see the ST elevations and QS complexes in inferior leads and ST depressions in V2 to V4 with the lateral leads showing the ST elevation, and this is the present ECG which is showing a T wave inversions in the inferior leads and preserved R waves in the lateral leads and STT changes in the lateral leads. So this is a chest X-ray showing the moderate cardiomegaly, and I will be showing the echo clips. This is the short axis view showing the regional wall motion abnormality in the inferior septum and the inferior wall. The inferior septum and inferior wall being totally akinetic. When compared to the other segments, the wall of the inferior septum has considerably decreased, and there is restricted of the commissures of the PML. This is apical 4-chamber view. A severe eccentric MR is being seen because of the tethered PML and the basal lateral segment being akinetic. The MR jet, when we have decreased the Nyquist limit, it is almost all occupying the whole of the LA, suggestive of severe MR. This is the apical 3-chamber view showing the akinetic segment of the LCX territory corresponding to that of the CTO lesion. This is a 4-chamber view. The basal anterolateral segment of the LCX territory being akinetic. And this is the M mode showing the dilated LV dimensions of LV IDD of 6.2 and the EF of 38%. And the MR jet velocity is almost all the velocity 6.6 meters per second with a pressure gradient of 147. When you take the systolic blood pressure of 160 and considering the patient not be having any aortic stenosis, the LA pressure would be very less, but how? And this is the left atrial volume index by the area length method. The left atrial volume index corrected to the body surface area is 34. And the M mode showing the decreased propagation velocity along with that of the MR being all through the systole. And we have done the strain imaging. The strain imaging, the average strain was minus 11.2. Again, most of the segments corresponding to that of the LCX territory. So, in summary, the patient is having a dilated LA of 4.4 centimeters with a LVEF of 38, dilated LV IDD of 6.1, GLS of minus 11, and left atrial volume index of 34. How to manage this case? It's open for the discussion.
Repeat angiogram was done or?
Yes, sir. Repeat angiogram was done, sir. It was LCX CTO. Again, the retrogradely filling from the collaterals from the right system. I did not have them. We have done the angiogram. It is retrogradely filling from the RCA.
What says blood pressure?
Blood pressure is 160 by 90, sir.
Did you do MRI viability?
MRI viability was not.
Yeah, the issue is the severe mitral regurgitation is obviously the cause for her heart failure.
Yes, sir.
Now, with ejection fraction of 38% and end systolic dimension of 5 centimeters.
Sorry. The format is we'll have the presentation on ischemic MR and then we'll have the discussion, please. Don't mind. Dr. Rajesh? We sincerely appreciate Dr. Rajesh Nair, who had a recent fall and broke his shoulder. Despite that, he managed to travel and come. Sincerely thank you for making it possible.
So as the mic is being set up, can I ask a question to Dr. Shastri? I see on the echocardiogram that the inferior wall is totally scarred. It's less than 5 millimeters, I think so. Do you still think you need a viability study here at this stage? Or just going by the thickness of the myocardium and looks almost akinetic there? Probably I would not do a viability study. I would just think of how else to treat this case rather than looking to revascularize the circumflex. Just a more question for discussion.
Sorry, probably he'll present. After that, we can discuss. That will be better.
Good morning to all of you, respected chairpersons, respected teachers. My sincere thanks to Narasimhan sir for calling me for this academic feast. First, approach and management of ischemic mitral regurgitation. There are two parts in it. That is an acute ischemic mitral regurgitation, which I won't touch, and the other is chronic ischemic mitral regurgitation, which is probably the area of interest today. So there is a disease of valve not the disease of valve per se, but it's rather a disease of the left ventricle, and I have written the valve is probably nearly normal. Now, for any epidemiological studies, you will have a criteria to define a condition. So it is defined as an MR occurring more than 16 days after MI, with one or more areas of regional wall motion abnormality and significant coronary artery disease supplying the area of RWMA. Now, in all cases of myocardial infarction, if you take all together, the incidence may be around 50%, but severe mitral regurgitation occur in around 12% of cases. It has both prognostic value. Even in asymptomatic patients, the mortality will be higher. It contributes to heart failure even in asymptomatic patients, mitral regurgitation contribute to heart failure. And the degree of mitral regurgitation, this is a graph showing the EROA and the incidence of heart failure. So as the EROA increases, the heart failure increases even in asymptomatic patients. So we all used to advocate patients with such ischemic MR to undergo CABG, if it is multivessel disease, CABG, and a surgical ring annuloplasty, and surgeons used to do restriction annuloplasty, thinking that the two valve leaflets are brought together and the coaptation is adequate. But the data from Cleveland Clinic showed that even 6 months after a successful mitral valve annuloplasty, the EROA as well as the regurgitant volume quickly comes back to normal in around 28% of patients. So the one up to 1/3 of the patients, the mitral regurgitation, severe mitral regurgitation comes back. So as practicing cardiologists, it is our duty to determine if an intervention directed at the mitral valve, whether it is surgery or intervention, is capable of changing the clinical course of the disease, not that we are capable of doing something. Now, when we were students, we were told that the mechanism of MR is simply papillary muscle dysfunction, but this term is obsolete because elegant studies have shown that if you induce papillary muscle dysfunction alone by ligating that small branch supplying that territory, you won't be able to induce MR. And what is more important is an interaction between the LV as well as the mitral valve, resulting in an impaired closure, what is called incomplete mitral leaflet closure, resulting from an imbalance of two forces, that is closing force as well as tethering force. Closing force means the force with which the mitral valve closes, that is the contraction of the LV, as well as the basal clockwise rotation. And the tethering forces are the forces exerted by the papillary muscles as well as the caudal apparatus, and the restriction offered by the annulus. Now, when the LV dilates, when the annulus dilates, there is restriction of the leaflet. It hold on to it. Whereas when the contractility decreases, when there is dysynchrony, the force with which the mitral valve closes comes down. So this imbalance results in many things. The first finding is, usually when the mitral valve closes, there is something called a triangle of coaptation, and that disappears. And depending upon whether it was an inferior or infralateral MI or anterior wall MI, as in this case, you can see that the posterior papillary muscle, the first diagram, it's an inferior and lateral wall MI. So there is a focal bulging there and an asymmetric closure of the mitral valve. And so this results in a significant MR. Sorry. Now, when the LV dilates, it results in a symmetric sort of a phenotype. You know that mitral regurgitation is more in inferior and lateral wall MI, as you have seen in this the previous case, and lesser in anterior wall MI, because the dilatation occurs mainly at the LV apex, whereas in inferior wall and lateral wall MI, it exactly occurs at the site of insertion of the posterior papillary muscle. And all these factors like LV dysynchrony, then LV dilatation, annular dilatation, it's an interaction, and our treatment must be targeted against all of these things. Now, why I told you it's a near normal leaflet is that all these forces lead to certain changes in the leaflet itself. It can get thickened. Then if it is the remodeling is good, it elongates, then the mitral regurgitation can come down. Whereas when it becomes fibrotic, thickened and retracted, it results in mitral regurgitation. So the valve leaflet also, the morphology is also very important. Now we were conventionally thought that the displacement of the papillary muscle is mainly apical, whereas subsequent studies showed that it is mainly a lateral displacement. And all these interactions of these multiple forces leads to a dynamic MR. So this is called a loitering pattern, which is minimum in the mid-systole, where the closing forces are the maximum. Now, the papillary muscle dysfunction must be addressed slightly in detail, because when the papillary muscle dysfunction occurs, the mitral valve prolapse occurs. Now, how to suspect an ischemic etiology of a papillary muscle prolapse is when the anterior leaflet prolapse rather than the posterior, when you get what is this appearance called a thorny papillary muscle, which is stretched and elongated. And when there is complete loss of the triangle of coaptation in any patient with the mitral valve collapse, you have to immediately suspect it. Now, papillary muscle dysfunction is not that benign or simple as we think. It may or may not induce mitral regurgitation, because in this diagram, what you see is, see there is a focal bulging, and the papillary muscle function is not as such bad. It is not stretched or elongated. So what happens is severe mitral regurgitation results. But when the papillary muscle also gets elongated, the degree of MR disappears. So it is slightly complex issue, that the morphology as well as the function of the papillary muscles. Now coming to the annulus, previously we thought that it is a posterior part of the annulus which is producing problem, and the surgeons used to do an incomplete ring, flexible ring, but now they have moved to what is called the rigid complete ring, because the entire annulus is weakened. Now I am not going to the annulus function assessment. So after going through all these pathologies, you know that there are two types of MR, that is asymmetric MR and symmetric MR. You should know that the symmetric MR is a condition where the LV is significantly dilated. Severe MR, there is higher tending area and tending height, and these subsets of patients are probably not good for a percutaneous procedures. So as cardiologists, when you doing the echo, you have to highlight all these points to the surgeon. For example, the leaflet length is very important. If the posterior mitral leaflet is very small, you have to tell the surgeon that a simple annulus reduction alone is not sufficient. They have to go to a procedure called a LEX, that is leaflet extension procedure. Then when there is a relocation, retraction of the posterior papillary muscle like this, that is the posterior papillary muscle displaced like this, how you do is you draw a horizontal line at the insertion of the RV, and from there you take the posterior displacement. So if it is displaced like this, you have to tell the surgeon that you have to do something called relocation of the papillary muscles. It simply means using a stitch, they have to approximate it towards the annulus. Now when the papillary muscle is elongated like this, you have to caution them and tell them that probably you have to use newer techniques like neocord. Now, sorry, some problem with everything was working in my laptop, but oh, sorry, it is not moving here, no problem. Okay, so in this patient, you can see the aneurysm. So in this such situations, you should ask the surgeon to placate this. Now this is one thing which all echocardiographers should note and report, that see, you see the anterior. Sorry, I can't see this. I have some visual problem also after cataract surgery. So okay, so you see that there is an acute bend in the anterior mitral leaflet. So this is due to tethering of the chordae called so you can see that this is holding a cord. So this the surgeon has to cut. So otherwise the result won't be good. So second order caudal cutting is another thing which you have to tell the surgeon. Now you look at this ventricle. So the LV is dilated, LA is dilated, significantly dilated, and patient has severe MR. So in this such patients, you should ask the surgeon to go ahead and do the mitral valve replacement rather than trying any percutaneous methods. Now I will come to the details later if time permits. So you have to tell in detail the valve apparatus, the left ventricle, as well as the severity of MR. Now a little bit complex, right? But I will try to explain it, because this is the reason why there were incongruous results between the two trials, that is co-op trial as well as the MITRA FR trial. Now in this first diagram, you see that ventricle is dilated and there is severe MR. In the second diagram, you find that the ventricle is not that dilated but significant MR. So there is something called a proportionate MR and disproportionate MR. So this can be very well a detailed question for the students. Now, when the EROA is significantly larger compared to the LV, like this patient, it is called disproportionate MR. So the co-op trial probably included more of these patients rather than the proportionate MR, and that is why they fared better. Now, in this patient, the LV cavity is larger and the EROA is late or is almost proportionate, and such patients fare better with probably mitral valve replacement and not your percutaneous procedures. Now, so this graph study shows that if there is a high value of EROA by LVD, all the medical treatments are going to fail, and probably you have to tune yourselves and as well as prime the patient for an intervention aimed at the mitral valve. Now, the Carpentier classification you all mentioned, but remember that it is not that easy in ischemic MR, because see, which class do you classify this patient? The annulus is dilated, the movement is restricted. So it is often a mixture of the classifications. And though I told in inferior and lateral wall MI, always the MR will be eccentric, you see that here the MR is almost central. So it's different types of presentations. Now, echocardiographic analysis should include multiple off-axis views, and this is an interesting study which showed that around 44% of cardiologists only could recognize severe secondary MR. Around 140 senior cardiologists were given severe case of severe secondary MR and were analyzed to quantify it, and only 40% of them could identify. So this is not easy, because you know that various factors are important. The pressure, your blood pressure is important. The time duration of the mitral regurgitation is also important. So as clinicians, it's your duty to measure the blood pressure of the patient, see the heart rate is controlled. Otherwise, none of your measurements are going to be correct. And you know that the spectral color Doppler simply indicates the blood flow velocities and not the volume. So just looking at, don't tell that this is severe. Okay. Now, as that doctor showed in the previous presentation, that the timing of MR is very important. So whatever be the measurement, if it is in a part of the systole, don't label it as severe. Now, you should make sure that the MR is pansystolic before applying any of these single frame measurements like vena contracta, jet area, proximal isovelocity, surface area, etc. Now, as I told you that the MR is loitering, that is dynamic, going on, varying throughout the systole, you have to take multiple
Rajesh,
measurements and
Dr.
then
Rajesh,
take
sorry to
average of
interrupt
it.
you. Dr. Rajesh,
Yes.
Sorry to interrupt you. We are running short of time. Just try to
Okay.
make it brief.
Okay, so so this is how you assess. Sorry, I'll have to. There is some confusion. I told I was given 15 minutes. Is it? So okay. Now I'll just go to. No, not much time is required for me. Now, so treatment of just 2 or 3 slides. Treatment of chronic ischemic mitral regurgitation. The first and foremost thing is medical treatment. That is what you should remember. All the 4 pillars of heart failure must be given, and a reassessment after 3 to 6 months, and then only you should go ahead and do any surgery or any intervention, because that is the cornerstone of the treatment. Now, how to predict? There was some question, there may be some question, that is, if you do only CABG, whether the MR is going to subside. Not in severe MR, but in moderate MR, yes. How to identify such patients? A large extent of viable myocardium, that is more than 5 segments viable, then absence of gross dysynchrony and relatively preserved annulus geometry. In such cases, you need not do anything and go ahead and do the surgery. So this is a patient who had a mitral valve repair but failed, as shown in this thing. So you have to select patients who are going to benefit from mitral valve repair. Now, the surgery should be the annulus, the caudal apparatus preserving technique, and you know that there is no significant difference between mitral valve repair versus replacement. So this is probably my last slide. I told you that the main treatment of ischemic MR is medical, 3 to 6 months treatment, including CRT, and then only refer the patient for a percutaneous procedure or mitral valve replacement. If anyone insists for a percutaneous procedure or or surgery, then you should be careful. Don't send patients for straight away for percutaneous procedures. Then coming to the surgery or repair, you should leave it to the surgeon, because there is data that there is no significant difference between the two procedures. Even in my hospital, there are two surgeons. One insists for repair and the other for replacement. So I simply show all these data to them, and probably they will decide finally what to do. Now, coming to the co-op trial and mitral heart failure trial, I have told you why the difference in the result came. So you have to select, if you are taking a patient for an intervention, make sure that the LV is not grossly dilated, whereas if the LV is grossly dilated, then better will be surgery than a percutaneous procedure. Okay, thank you. Now, can you go back to the, is it possible to go back to that original difficult? That case scenario?
Yeah, thank you, Dr. Rajesh, for your elegant lecture on ischemic MR in its diagnosis and management. I think now we will go back to the patient and then take the comments from the audience.
While that is being prepared, I would say a few things. The last slide that you projected about the repair versus replacement, we have to take with a pinch of salt. The reason is, it is true that the primary endpoint was not met, but there is a severe incidence of hospitalizations and progression of mitral regurgitation, residual severe mitral regurgitation in the repair arm. And the trial results maximum was about 2 year study that you presented. So 2 years is a short time while we're discussing. This mitral regurgitation begets mitral regurgitation, remodeling continues, and patient will not do well. So if you opt for repair, your surgeon should be prepared to do all aspects of the treatment, including the plication of the papillary muscles, neocardial insertion, or removing the card, resecting the cardae. It's not just doing a downsized complete rigid ring is not going to be sufficient. That is what they did in that study. So if you have to manage these patients, the surgeon has to come to the echocardiograph lab. Both have to sit, the echocardiographer and surgeon have to a complete anatomy. Most of the times you don't see the kind of reports that you mentioned. What is the tenting area, the triangle area, what is the height of the triangle, what is the annular size, none of the information is given. So unless surgeon who is interested, capable of doing mitral valve repair, he sits there, just deciding whether he will put a ring or not, it doesn't matter. Probably it is better to err on the side of replacing than putting just a ring and coming out. And coming to the point that 38% ejection fraction is a borderline, less than 40% with severe MR surgery is going to be a problem. Probably if you treat aggressively with medical management, you may improve the ejection fraction and MR may come down and patient may be better, but it is more of a cosmetic change. Personally, I think doing only revascularization of the CTO, leaving mitral regurgitation is not going to help at all. So the viability assessment is more to be sure, because echocardiogram does not give all the information. This kind of echocardiogram, if you clearly see a thinned out sclerosed LV, that is different. But many times it is a borderline case. So if you have got a viable myocardium, you can do a revascularization. But if you have got a bulging or dyskinetic posterior wall, then, and also the changes in the cardae and other mitral valve apparatus, you have to go for repair. Just doing a revascularization won't help. On the other hand, suppose if the area is totally dyskinetic, then probably you may have to go for, if you can't do a repair, you have to go for a replacement.
Yeah. Rajesh, nice presentation. As a surgeon, I have just a few comments. I fully agree with you that there is no difference in the mortality or morbidity with whether mitral valve repair or a replacement. That's number one. Number two, For ischemic mitral regurgitation, always a rigid ring, asymmetrical ring is used because it is the P3 segment of the posterior mitral leaflet which gets tethered, and that is the cause of mitral regurgitation. So what we do during surgery is we release the tethering and then we allow the posterior leaflet to come up, and then we put a rigid ring. In new rings like McCarthy ring has come, which is a fixed rigid ring, and it has got a special high intensity rigidity in the area of the P3, in the area of the P3 leaflet of the posterior mitral leaflet. And timing is very important. We see a lot of patients after MI who are referred to us for a CABG who have moderate to severe regurgitation. I usually don't encourage them to undergo surgery if they are asymptomatic. So we allow them at least 6 weeks of time so that some sort of a remodeling happens and then the mitral regurgitation comes down. And then suppose if the mitral regurgitation is very severe, best thing is to go and replace the valve. And if it is mild, usually we just revascularize. And if it is moderate, between 4 to 8 square centimeters of jet area, then probably we try and put a ring and then release the posterior mitral.
Yes, there is a difference in the management of pure mitral regurgitation and then ischemic mitral regurgitation. That, as you point out, this mitral regurgitation within ischemic heart disease and LV dysfunction here. So in this patient, that LV dysfunction may not be taken into consideration because the already patient is having ischemic heart disease. So probably we need to revascularize and then replace the valve also in this patient.
In this case, did you do a viability study?
No.
No, viability study was not done. What was the final angiogram diagnosis?
The angiogram, there was no disease in the LAD and RCS, but the LCX, distal LCX is total cut off. The stent is totally occluded and retrogradely filling from the RCA.
So what is the ECG finding?
This is that down one is a present. The first one is the initial presentation, sir, and the down one is the latest.
A lot of discordance between ECG and echo. Echo shows almost infarcted segment.
That is,
and here the ECG R waves have come back in the lateral leads. Almost it's like inferior non-HCMI. Is it the same patient or different patient?
Sir, same patient.
That indicates probably that myocardium is still viable. That also indicates.
But it looks like scarred also.
Now, about commenting on viability by looking at the echo alone, I think needs some discussion.
It's important to keep in mind that the electrocardiogram is not angiogram. The electrocardiogram has serious limitations in detection, ischemia, infarct, etc., whether acute or chronic in LCX territory. So don't be guided by electrocardiogram.
Yeah, thank you very much. We move on to the next presentation. I request Roshni to present her case.
So, Doctor, what would be your strategy, Dr. Sukesh? Before we go on with the next slides, for this particular case, what would be your strategy?
Praveen,
And as medical
first case, right?
The
first case which has been presented by Praveen. I think patient needs mitral valve replacement for sure.
Right.
No question. Revascularization plus mitral valve replacement.
So, Dr. Prasad Reddy, sir, what would you do, sir?
Yeah, I recommend the same.
8% ejection
So,
fraction.
but what happens if you preserve the leaflets, as you said, if you preserve the papillary muscle and then the cardia, usually they do well. I mean, they may require some inotropic support and probably they may stay in the ICU for a longer time, but I think they do well.
So the next session is on discussion on management of aortic dissection. Case will be presented by Dr. Roshni Agarwal. The talk will be delivered by Dr. Karthik Mikineni on surgical versus endovascular approach to aortic dissection, and expert comments will be given by Dr. Sukesh Reddy. Dr. B.K. Sastry, Dr. Imamuddin, and Dr. Sudhir K. will chair the sessions. Sorry, I'm so sorry, this is a continuation. I think the chairpersons are the same.
Good morning, everyone. I'm Dr. Roshni Agarwal, Junior Consultant from the Department of Cardiothoracic Surgery. Today I'm going to present a case of aortic dissection. So there's a 56-year-old male patient from Nagpur who is a known hypertensive and diabetic on medications. On 2nd of August, he developed sudden onset of pain in the interscapular area radiating to the front of the chest. So initially he was treated with antacids and analgesics. He continued to have pain, for which he consulted a cardiologist the following day. 2D echo was done immediately, which revealed severe aortic regurgitation and a flap in the ascending aorta. CT scan was suggestive of Stanford type A dissection, which was extending up to the renal arteries. So he is referred to AIG for further management. So usually the symptoms of aortic dissection may present as either heartburn, and it's important to differentiate it between myocardial infarction and aortic dissection. So clinical examination was essentially normal, with pulse was collapsing in nature. There was an end-diastolic murmur heard along the right sternal border. Rest of the examination was normal. ECG was normal. Echo was suggestive of a flap in the ascending aorta. Chest X-ray was suggestive of cardiac enlargement, mediastinal widening with basal lung congestion. So CT aortogram, as you can see, grossly dilated ascending aorta, Stanford type A, with entry point in the ascending aorta extending all the way up to the renals and proximally into the aortic root. So the management in these kind of cases is surgery. So the surgical goal and plan is to reconstruct the aortic root, and then next to have a competent valve and to completely replace the ascending aorta, to replace the aortic arch with true lumen patency of arch vessels, and to leave a distal uncomplicated type B residual aorta. So it was a standard procedure under general anesthesia. Medium sternotomy, pericardium was opened. As you can see, there's a grossly dilated aorta with inflamed and thinned out margins, and there was no blood in the pericardial cavity. So standard CPB with femoral artery cannulation we routinely employ, and venous cannula into the right atrium. And usually we cool the patient, then aorta was cross-clamped and heart was arrested by giving cardioplegia. Once the heart is arrested, aorta was opened, and then we carve out the coronary buttons. And since in this particular case the dissection was extending the right coronary artery, we gave an additional graft also. So this is the valved conduit. After excision of the aortic valve, we anastomose the conduit to the aorta, the distal end. And for the proximal anastomosis, we used a total circulatory arrest strategy because there was a hemiarch reconstruction also in this case, and under circulatory arrest, we did the proximal anastomosis. So once the circulation is established, the patient was rewarmed, weaned off CPB, and he was shifted to the ICU. So post-operative course in this patient was uneven, full, extubated on the first post-operative day, weaned off inotropic supports on the second day, and he was discharged on the 6th post-operative day. So post-op X-ray, ECG were normal, and as you can see the comparative image, the pre-op CT scan and the post-op CT scan, as you can see there is a reconstructed aorta with a type B uncomplicated aorta. And so aortic dissections are very rare. Incidence is 5 to 30 per 1 million people a year. 15th leading cause of death, and 2/3 of the dissections involve the ascending aorta. They are associated with very high mortality. So there are essentially two classifications which are used to classify dissections. Stanford is based on the involvement of aorta, ascending aorta, and DeBakey is based on the origin of dissection, where the dissection flap is extending. So 1/3 of the cases usually remain the same. 1/3 resolve, and 1/3 goes on to become the typical aortic dissection in the pathology, where there is a penetrating ulcer and there is an intramural hematoma. So type A interests the surgeon because untreated 1/3 die within the 24 hours, 50% die within 48 hours, and 80% within 7 days, 95% die within 1 month. So we need to intervene because of the following complications: cerebral ischemia, arm ischemia, free wall ruptures, MI, intestinal and renal ischemias. So outcomes following repair have improved significantly in the present era. In the 1960s, it was 30 to 60% mortality, which has come down to 10 to 15%. Survival rates have become better over years, with the 15-year survival being 24%. The deaths are usually cardiac related, and 15% of complications of dissection, and the remaining are unrelated complications. So aortic surgery poses a great challenge to the cardiac surgeon. Despite advances, mortality and morbidity is still very high. Aortic team constituting a cardiologist, cardiac and vascular surgeon, cardiac anesthesiologist to evaluate and plan treatment will help a long way in managing these subset of patients. Thank you.
So do you have Karthik online by any chance? Welcome, Dr. Karthik. This is Dr. Sukesh from AIG.
Hi everybody. Hopefully you're able to see my screen. Is everybody able to see my screen?
Yeah.
Okay, so we're going to talk about endovascular versus surgical approach to aortic dissection. I'll keep it very brief to the basic points of what it is going because of the exclusive and also exhaustive nature of this. This particular case that we have seen has repaired very well, and then now we have a type B dissection. What do we do with it? Vascular usually, until very recently, got involved only until type B dissections, but right now we are also going into the arch reflexes. Okay, first, what we see the national trends for the thoracic aortic aneurysms and type B dissection, as Roshni has pointed out, that is kind of an older data, but if we see the trends between 2000 and 2012, even with the advances in the antihypertensive medications that we have, the number of thoracic endografts that were repaired is almost close to 155,000 in the country, of which almost close to 500 were done at Stanford. And increased admissions for aneurysm is almost increased by 144%, and the dissections have increased by 71.8%. We are now tracking the national data from 2012 to 2022. The publication is going to be published by the end of this year. The abstract shows the aneurysm from the dissection has increased 200%, and the dissections have recently increased to 85%. These are alarming numbers despite our advances in statins and also utilization for antihypertensive medications. But the conclusion from this study, in which it still holds true, is use of endovascular aneurysm repair for dissection is increased, and also the inpatient mortality has significantly decreased. The overall mortality from these entities have also significantly decreased. So, as we all know, this is a favorite slide. No matter how many times we're trying to see, we always tend to get on the classification. It's like Stanford A and B. This is classic, which we know if the arch is involved and past the subclavian artery, we consider it as type B. But the recent Society for Vascular Surgery and Society for Thoracic Surgery has come up with a more robust classification. This no longer, we should never be approaching it as type A and type B anymore. As you see, we have now classified the arch, as you know, until the origin of innominate artery as zone 0, and up to the left carotid is 1 and subclavian is 2 and so forth. And then it goes on by each segment of the aorta all the way up to the iliacs and femoral, which is up to zone 12. So then we have seen if the entry tear is in zone 0, it obviously will be considered as a type A dissection. Then we have to see where the distal extent of it goes all the way up till the superficial femoral artery. In this particular case, as we have seen, it has extended all the way up to the renal, so it would be A8. Similar, the entry tear, if we know it is greater than zone 1, it is now considered, zone 0 is considered type B now. Even if it is not involving the ascending arch, it will be considered as type B going forward. And depending on the involvement of these visceral vessels is how we're going to know. So anatomic reporting of aortic dissections has changed and is based on the location of the entry, whether it is zone 0 would become A, and then the rest of it is B. And also there's a particular dissection, discussion and confusion about what is dissection, what is intramural hematoma, and what is penetrating aortic ulcer. So in all essence, any of these in the ascending aorta have to be considered as a dissection and repaired. When it comes to the distal part, pulse subclavian, intramural hematomas and penetrating aortic ulcer based on how symptomatic the patient is are largely managed medically. Again, on the chronicity of the dissection, if it is within 24 hours, it's considered hyperacute. If it is within 2 weeks, it's acute and so forth. So again, as we know from all the studies before, the risk-benefit ratio, any type A dissection involving the arch and also the ascending aorta, you need a surgery. In type B, the question comes whether it is complicated or uncomplicated. The complicated ones are the ones with the visceral malperfusion, and uncomplicated are the patients who just simply had a diagnosis. And this also is a very simplified slide. But The recent study on around 9,165 patients randomized study has shown that the inpatient mortality for medical therapy alone is significantly high, and it is also statistically significant. And it had a benefit in terms of survival rate. The TVAR had shown a superior survival rate for patients who have undergone thoracic endovascular aneurysm repair for type B dissection. So even for acute uncomplicated type B dissections, thoracic endovascular aortic aneurysm repair have actually shown benefit. Because the studies which were done before, where type A surgery and type B's medical management was concluded when before the endovascular era. After the endovascular era, we have noticed the aorta is remodeling favorably to the point where we consider doing TVAR now. So what are the results? The results have shown, I won't go to this one, the TVAR chronic type B dissection is safe with low rates of complications, and re-intervention at a median of 8 months is needed, which also has come down significantly. So what do we do? As I've spoken before, if it is acute type B dissection, it is complicated, then we go for TVAR. If it's uncomplicated, we do optimal medical management, yet also consider for TVAR given the advantage of aortic remodeling. And also, the Stable 2 trial has shown significant improvement in mortality and the stroke ratio for patients who are undergoing endovascular repair. So for type B dissections, the question of open surgery has almost significantly gone down to the point we do not even approach that unless the patient has visceral malperfusion and forces us to do so. Even for those, we do percutaneous fenestrations these days. So, and also, when is the timing? When do you do, for a patient who presents with an acute type B dissection, it has shown that if you wait for 2 weeks and then approach it, the results are significantly better. As you can see, in hyperacute or acute phase, doing a TVAR has higher incidence of mortality and major advancements when compared if you wait for at least 2 weeks to approach it. So this, and then the next comes, what are the advances next in our, this is a recent case we have done where there is a type B dissection and then there is a retrograde type A dissection for this particular patient, which is involving the origin of the innominate and extending all the way up to zone 0, but has been and has spared the root of the aorta. In this case, what we have done is we have done an on-table fenestration of the graft, and also a branch device has been placed. And within from the access into the arch, we have accessed the innominate from the right side and also the subclavian. And what we have done is we have deployed the graft and then also deployed a stent within the proximal fenestration. Now we have placed both the left common carotid and the innominate coming from the first fenestration, and the branch graft is used for the left subclavian artery, and the graft has been deployed. As you can see the post images, this is a total endovascular repair of the arch. So this is going to be the future era while preserving our technical skills for patients with open surgery. These are done relatively in a shorter time and the patients recover faster, and more data is coming on hybrid approaches and endovascular repair of the aortic arch aneurysm. And these are other hybrid approaches where both endovascular and open are employed, where you don't have to place the patient on a circuitous, but we do multiple approaches of deep branching and also doing endovascular aneurysm repair. I'm not going to go exhaustively into those. This is another interesting era that we have. These are currently available or under investigations. We have already started using the Terumo aortic graft, which actually replaces almost up to zone 0. And we have recently done a case where the patient actually underwent an aortic arch replacement endovascularly, and when the patient had aortic wall issue, he also had a TAVR done. So it was a total endovascular repair for that patient. And that being said, now we are in the era of ARISE trial, the first in-human evaluation of a novel stent graft by Gore, which has been deployed at Houston Methodist Hospital a couple of years ago, has been very successful. And the first data is out that a graft that has been dedicated to be deployed in the zone 0 of the ascending aortic artery is successful and also is very promising. So what I see in the future is we're going to talk about more and more endovascular approach for the arch, if from zone 0 and also valve replacement. So with that being said, I think most data and the current advances favor towards endovascular repair while preserving the fact that open surgery is always going to remain gold standard. Thank you.
Thank you, Dr. Rushni and Dr. Karthik, for the excellent presentation. Well, type A dissection surgery. Type B dissection, it's basically either medical treatment or TVAR. So recently, two randomized studies have come with type B dissections. One is the INSTEAD trial, and then the second is the ABSORB trial, and both have shown that with type B dissections, a TVAR is much better than medical treatment in the form of remodeling of the aorta and with even in terms of long-term survival. Do you have any comments, Doctor?
Yes, before opening it for discussion from the audience, I request comments from Dr. Sudhir.
Great case and great talk by Karthik. I do agree type A dissection is surgery, but I think timing is also important, right? So I'm sure Karthik and all have got IOTIC team. And what is the scenario in India? Do we all have IOTIC teams, the dissection teams, where a dissection comes and you quickly involve all the relevant specialists Roshni mentioned, so that there's no delay in getting them into the theater?
So over the last 2 years, we have performed around 6 IOTIC dissection surgery for type A dissections, and they were taken in for surgery within 6 hours after coming to the ER. First they came to the ER and then they underwent a TE echocardiogram, and some patients went down for a CT scan and they were on the table within 6 hours. So I fully agree with you. Time is the essence in managing these patients. With each powerful contraction of the heart, the dissection is going to extend and the aorta is going to be more fragile, and then it's going to rupture or cause occlusive symptoms. So timing is the essence for sure.
Thank you.
Are there any comments from anybody? I think if there are none, I think we will close the session, and I thank Dr. Roshni and Dr. Sudhir for his expert comments. Thank you. Thank you. We'll close the session.
So we have the next session on management of patient with cardiogenic shock with mechanical circulatory support. Dr. Bhishma is the case presenter, and we have a talk on patient selection for mechanical circulatory support by Dr. Auros Atreya, and Dr. C.V. Rao will give the expert comments. Dr. B.K. Shastri, Dr. Imamuddin, and Dr. Sudhir K. will chair the session.
Right, Shobhit.
Yeah, good afternoon, everyone, and the chairpersons. So I'll be presenting an unusual and a challenging case which we received to our center a few months back. So a 28-year-old lady with no known comorbs, 6 months postpartum, with history of seasonal allergies, was being managed with antihistamines and steroids. On the first day of the event, she developed skin rashes with swelling around the eye and lips, and there was sudden onset cough with worsening dyspnea. She was diagnosed as anaphylactic reaction with angioedema, and she was given IV Evel and hydrocortisone, and it was not resolved. So she was given an IM adrenaline shot to treat the anaphylactic shock. Post adrenaline shot, patient developed acute chest pain with frothy sputum. She was transferred to a local hospital in Guntur, and immediately an echocardiogram was done, which showed a severe LV dysfunction, EF of 15 to 20%. She was put on a mechanical circulatory support, on a mechanical ventilator, and an IBP was initiated. And in view of severe cardiogenic shock, inotropic support has been initiated, and she was shifted to our center on the second day. When we received the patient in the middle of the night at around 12 a.m., the patient was on a mechanical ventilation, IBP, and triple inotropic support on a very stiff dose. She was hemodynamically unstable. The patient had 2 episodes of VTVF, for which we had to cardiovert to sinus rhythm, and she was started on a xylocard infusion. So an examination, her blood pressure on triple inotropic support on and IBP was systolic less than 80, and sinus tachycardia with heart rates of 170, and LVS3 was present, diffuse bilateral Krebs were present, JVP was grossly elevated, cold peripheries. So this was one of the ECGs which was showing severe sinus tachycardia, and you can see the LV here. Almost the LV is very badly depressed with an ejection fraction of less than 10 to 15%. So this was the chest X-ray on admission showing a very bad pulmonary edema bilateral. So the provisional diagnosis after taking everything into consideration is an anaphylactic shock with a stress cardiomyopathy due to adrenaline. Was it a fulminant myocarditis, or was it an acute cardiogenic shock with underlying postpartum cardiomyopathy? So in view of the unstable hemodynamics and patient going down with VTVF episodes, immediately we had a discussion in our with our consultants here, and it was decided to go ahead with an ECMO to support the cardiopulmonary system. So the rationale again here was a multi-organ shock and recurrent VT episodes and severe pulmonary congestion. The VA ECMO cannulation was done with an antegrade limb cannulation and a right heart cath monitoring. You can see the videos here. We went ahead with a VA ECMO with one of the cannula in the SVC RA junction and the other cannula in the aorta, and with an IBP in place there. So immediately post ECMO, we went ahead and did a right heart cath, and we kept monitoring the cath over the night, and the pulmonary artery pressures were severely elevated and the wedge pressures were grossly elevated. So since we all know the effects of ECMO, because the ECMO dumps the blood in the peripheral system, causes a significant overload on the left ventricle and causes LV dilatation and increased left atrial pressures, and the filling pressures are grossly elevated, leading to increased pulmonary wedge pressures, and also increases the myocardial oxygen demand and delays the LV recovery. So this is a pressure volume loop. So this is, you can see a regular pressure volume loop, and when you put an ECMO in the patient, what happens is the endostaltic volume increases. So the loop shifts to the right, becomes narrower, and the afterload increases grossly. So these three things have immediately happen in this patient once you put an ECMO in any patient. So this particular patient, which we diagnosed as a stress cardiomyopathy with cardiogenic shock, the aim of all the treatment is to give the time for the LV to recover. So we had to do something else. Even though the patient had an ECMO and an IBP to decrease the afterload, it was not enough. The wedge pressures continues to be very high, and the patient is still not recovering. The chest X-ray was not improving, and the other options to decrease the LV afterload was to put a venting cannula in the pulmonary artery, put an impella or a tandem heart. So we had a discussion again among all the senior faculty and everybody. So we thought we needed to rest the LV, and we need to decrease the afterload to help the LV recover faster. So we went ahead and put an impella to decrease the afterload. So impella, by decreasing the afterload, also increases the ascending aortic pressure, causes coronary perfusion, and helps the LV to recover faster. So now that we saw what ECMO did to the pressure volume loop, I'll show you what ECPella does to the pressure volume loop. So this was the loop which we had on ECMO, where the endostolic volume, endostolic pressure, the afterload and stroke volume, was decreased and afterload was increased. Once you put an ECPella is ECMO and Impella together, it significantly decreases the end-diastolic volume, pressures, and the LV unloading. You can see all the isovolumetric phases going away because the Impella causes a continuous flow from the LV into the aorta. So the isovolumetric phases are decreased and the LV afterload is decreased and LV EDP and volume is decreased and completely resting the LV, which helps the LV to recover faster. So what are the studies on ECPella? So there are quite a few studies where ECPella improves the 30-day mortality and is an excellent bridge to a therapy until the patient recovers. So the clinical course over the next 3-4 days, the ECMO and Impella flows were coordinated. The fluid management was done based on the right heart pressures. The CRRT was continued, ACT was managed accordingly, and this was the chest X-ray slightly started to improve. And like I said, since we increased the ascending aortic pressure and unloaded the LV and reduced the endostolic volume and pressure, which further reduced the wall tension and the microvascular resistance, the LV started to show gradual improvement over the next 4 to 6 days. So there was a gradual LV improvement with a decrease in pulmonary venous congestion and improvement in organic perfusion, renal functions, and liver enzyme recovery. So these were the X-rays over the next few days. You can see a drastic pulmonary edema, which was which is going down, and the X-ray is much better compared to what we saw. So this was the echo, which showed the drastic LV recovery which was happening once we unloaded the LV and once we rested the LV. So LV started to bounce back. So slowly the LV recovery happened. So once the LV recovery happened, we immediately wanted to decannulate the ECMO to prevent peripheral complications. So the gradual LV recovery and improved hemodynamics and the concern for a limb ischemia, we decannulated the ECMO on day 7. On the day 7 to 10, after decannulating the ECMO, since we had to stop the anticoagulation to decannulate the ECMO for the surgeons, so immediately post decannulation within few hours, the Impella had a clot and the pressures was not transmitting. So we had to remove the Impella on the same day, continue the CRRT, the inotropic de-escalation was done, sepsis was managed accordingly, and she was discharged on day 10, and sepsis was managed with appropriate antibiotics, daily physiotherapy. Blood workup was simultaneously done to what exactly happened and why did she develop an anaphylactic shock. And our excellent critical care team and did multiple tests to find out there was an C1 esterase enzyme deficiency, which is an acquired disorder which increases the bradykinin levels in the body and causes recurrent angioedema. And from day 10 to day 22, on day 22 of discharge, this was her X-ray.
Can you quickly conclude, Dr.
Yeah, I'm done, sir. This is the echo at discharge, and this is the timeline of events from day 1 to day 22 of discharge. Patient was cannulated, monitored the right heart cath, and accordingly the Impella and the ECMO volumes were titrated. ECMO was decannulated on day 7, Impella on day 7, weaned off the ventilator on day 9. Physiotherapy and rehabilitation was done. Patient went home walking on day 22 and is still under follow-up, doing very well. So the conclusion, the short-term mechanical ventilated devices improves cardiovascular hemodynamics in acute cardiogenic shock. Percutaneous via ECMO and Impella provides circulatory support and rests the LV, helps to recover faster. Continuous CRRT and right heart pressure monitoring are crucial. Team specialized in circulatory devices consisting of cardiologists, vascular surgeons, and CVTS surgeon, critical care, helps in monitoring and managing the complications. Thank you.
Thank you, Dr. Bhishma. Nice management, very good. It's not uncommon to see in a long practice, we have seen, at least I must have seen more than half a dozen cases like this with catecholaminergic storm. Typically, this follows, spinal anesthesia, anesthetic give mefentermine push or IV adrenaline push for whatever reason. They end up with this kind of situation. I've never seen one like this, such a fulminant course. Suppose the similar case occurs next time, would you go via same route, ECMO and then Impella, or Impella alone would be sufficient? Because there is no basic pulmonary pathology. Oxygenation would improve as soon as you decrease the pulmonary wedge pressure. Do you think a simple Impella would be good enough?
Yeah, next time probably, see, this patient in the night, we didn't have Impella in the house. The immediate important thing was to support the cardiopulmonary system.
Short answer is Impella alone would be good enough.
Yes.
Just one quick question. I'm just thinking about it. Dr. Narasimhan may be the right person to answer. Narasimhan, this kind of catecholamian storm, do you think there is a role for stellate ganglion block? Theoretically?
Yes, if there is a VT storm, yes, we do a bilateral stellate blockade. It works quite well. It's common in patients who take cocaine and some of these catecholamian surges. Temporarily, you can do either a renal denervation we do or stellate block.
Probably this kind of patient.
We never thought about it. We never thought about it.
Just an idea.
Sure. We never thought about it.
For want of time, we'll move on to the next presentation.
Thank you.
So one question, as an inotropic support, do you think noradrenaline would be better, or levosimendan would do a better job for this group of patients?
Difficult question. Maybe I don't think there is no data, but it appeals that you give levosimendan if you can manage that. Next topic is.
I think it's patient selection for MCS by Dr. Aura Satre.
Good afternoon, everybody. I hope you can hear me. Thank you for the opportunity to speak here. So I'll keep this sort of summary really short. Very nice and illustrative case by Bhishma, which actually involved 3 different mechanical circulatory support devices, and pretty much all the ones that are available in India. So we'll just sort of give an overview of the various types of temporary devices, one slide sort of summary of hemodynamic profiles, and the indications. And I won't really go into the complications related to the mechanical circulatory support devices because we are short of time for this one. But overall, when we think about temporary mechanical circulatory support devices, these are pretty much the broad indications for the whole group of them. Most often it's going to be cardiogenic shock, either as, a bridge to a decision, or a bridge to other advanced therapies. And the most common form of cardiogenic shock that we see is after acute myocardial infarction, and that's what most of us have experience with. But increasingly, as people with advanced heart failure are getting other therapies and staying alive, they can have decompensations at any point in their life and present with severe shock. Post-cardiotomy shock, fulminant myocarditis, refractory arrhythmia-related shock are less common in practice. The other sets of indications for mechanical circulatory support devices increasingly are high-risk PCI, high-risk electrophysiology interventions such as VT ablations, and in the setting of cardiac arrest. So we'll just look at it in this perspective alone. And when you look at the new Sky shock classification, which goes from A, B, C, D, E. C is the classic shock, D is deteriorating, and E is extremis, shock in extremis. Basically, your MCS is going to be restricted to the C, D, E, and the profile of support that you use, increased cardiovascular support, is going to be more and more as you as shock progresses towards E or presents in extremis. So we'll talk mainly about the four main temporary support devices that are talked about, written about, and that we have experience in. Intra-aortic balloon pump that has been around for decades. Impella, which has been around for more than a decade plus now, with robust data, ease of use, and adaptability. Tandem heart, which is far less available, and then ECMO, which again has been there for decades, and a variety of physicians and surgeons are able to use it and implant it. So the balloon pump is, everybody knows, I don't need to talk about this. This is just a balloon that is counterpulsating in the descending aorta and it basically decreases the afterload. Very cost effective, very easily available, very good for coronary perfusion, but in terms of providing cardiac output, it's really very limited. It should not really be thought about as a cardiac output device, but it's a great device for coronary support and things like that. So when would you choose balloon pump? I would say in the Indian context, most patients with cardiogenic shock, it is the initial support strategy. It is less expensive, easily available, can be done immediately, especially in the post-MI setting, but also in the heart failure setting. Sort of simple, or when you look at high-risk PCI cases, the less complex type, I think balloon pumps can still be used. You don't necessarily need an impeller. Sometimes it is still being used in left main for pre-induction for CABG and things like that. But and as the previous case kind of illustrated, unloading for ECMO can also be done with a balloon pump. All right, so we'll talk about the impeller, which is, as most people in the audience would know, is a catheter that goes retro-aortic, has a pigtail, goes retro-aortic into the left ventricle, has an inlet. Here, I'll show you this picture. It has an inlet pump in the left ventricle which sucks in blood because there's an impeller here, and then it outputs it into the ascending aorta. There's various sizes of impeller which give various amounts of cardiac support, but the most commonly used one, and I think the 2.5 is essentially being phased out, but the most commonly being used impeller is the impeller CP, which gives about 3.5 to a maximum of 4 liters per minute of support. When you think about these devices, opposite to what the ECMO does, the impeller and the tandem heart both decrease or unload the left ventricle to a significant extent that if you look at the flow volume loop, the volume on the x-axis, pressure on the y-axis, for any given pressure, there's lower volume and less pressure in the ventricle. So it decreases the volume in the ventricle as well as decreases the pressure. So this is really helpful in terms of resting the left ventricle. I don't think we've already sort of covered this. Yeah, so these are just impellers that we have done at AIG for shock. This is a recent impeller guided VT ablation that I did. Anyway, but who do we choose an impeller for? So I would say selected patients with cardiogenic shock because most patients would have gotten a balloon pump initially, and these are people not responding to that, or we clearly know that the shock is progressing. And in this context, the SCAI cardiogenic shock classification is very helpful, and it informs decisions, and it's useful in discussing with patient families as well. So again, only a very selected group of high-risk PCI, high-risk VT ablation cases. And as the case where Bhishma illustrated, LV unloading with impeller when you have a VA ECMO is quite significant. It's obviously far superior to a balloon pump because you're actively unloading the LV, and it counter affects the afterload increase that a VA ECMO produces. So the afterload effectively decreases. So the LV is getting rest. At the same time, there is global circulatory support with oxygenation. The issues, the caveats are that you need to have adequate vascular access and the cost and availability. So obviously now in India, there's been large number of centers now have access to the impeller, but cost is a major barrier. So I think there was a question with the previous one that would a simple impeller be sufficient? And I would say to that if when cost is taken out of the equation, yes, I think the impeller is probably very easy to do, very quick to do. The procedure itself is about 5 to 10 minutes in the lab, but you have to get the patient to the cath lab. Tandem heart is not readily available in India and not sort of commercially sold, but you'd have alternative options in India. So I won't talk too much about it, but basically this is a cannula that goes transeptal from that you go from the vein, you do a transeptal puncture and part the catheter into the left atrium, inflow from the left atrium and output into the aorta. I'll just show this diagram. So this is what is happening with the tandem heart. So you have fenestrations there. So you're taking oxygenated blood from the left atrium, putting it into a pump that is outside the body, just like ECMO, and then the oxygenated blood goes into the descending aorta. Again, like the impeller, flow volume loop is very favorable. LV is fully rested because you're totally bypassing the LV, going from LA to the aorta directly. So again, selected patients with shock, not responding to other devices. I would still say that in shock, beyond IABP, the impeller is probably the best initial choice. The tandem heart is a choice when you want to rest the heart for several days and you think that you might be, cooling this patient down for transplant. Less commonly used in protected PCI VT ablation cases. This is an alternative to the LAVA ECMO, which is left atrial VA ECMO, where basically you're oxygenating and you're resting the heart all in one. Again, requires good vascular access, just impeller, ECMO, tandem heart, all require good, large bore arterial access, impeller up to 14 French, but tandem and ECMO can be 17 to 20 French. Cost availability in India is an issue. And the VA ECMO, lot of people again would be familiar. Just peripheral, I'm talking about the peripheral VA ECMO. The central would be surgically implanted. This is percutaneously implanted with a catheter in the IVC, catheter in the and the return catheter in the descending aorta. We've talked about the hemodynamic effects where it actually pushes the PV loop rightwards, so it increases afterload. So that's deleterious. And whenever you think about VA ECMO, it is fast, it is quick, it provides circulatory support, it will keep a patient alive who is in VF. But long term, it's going to do the LV harm because the LV balloons. So if you're thinking about VA ECMO for support, you have to unload with either a balloon pump, with an impeller, with a conversion to a LAVA ECMO or a tandem heart ECMO. All of this is important if you want to use the
Dr. Athreya, can you finish?
We're done. Yeah, we're done. So how would you choose from all of these? So I think we've covered when we would do ECMO. I would say the ECMO is the initial strategy in myocarditis or cardiac arrest, but everything else is similar. These tables are widely available comparing the various devices, and I would urge the audience to have one of these as reference. Again, this is just showing the spectrum of support. And we'll end here and take questions. Thank you so much.
Thank you very much. For want of time, maybe I take the privilege and ask a quick question. What do you think about the chronic long-term use of intra-aortic balloon pump through the axillary artery for patients waiting for transplant? Number one. Number two, is there any role for Centrimag as a extracorporeal mechanical support? Centrimag.
Absolutely. Yes, great question, sir. I actually deleted the slide I had on ambulatory mechanical support just for want of time. Any of these devices can be implanted axillary. There's good data with axillary IABP where patients can be ambulated. That way they are not deconditioned while waiting for a transplant. And now if they need additional level of support, then an axillary impeller is possible. That's usually, you can use a CP impeller or you can use a 5.0 impeller, which is more support, but you would have to do sort of a graft that the surgeon would help with. Same with a graft, you could do a VA ECMO also in an ambulatory fashion. So return cannula would be in the axillary artery and inflow cannula would be in the jugular vein or the subclavian vein. So all of these are very important when you're considering someone for transplant and you don't want to decondition them. That's one. Sir, second question?
Centrimag.
Centrimag. I mean, so basically the Centrimag can be used. We use the Centrimag in the ECMO circuit, but it's basically just an extracorporeal pump. So we can do the tandem heart configuration with the Centrimag. You can put a cannula in the LA RA and then use a Centrimag. So basically, if you have an inflow and outflow cannula, the Centrimag will work. And the Centrimag is predominantly marketed as a surgical device, but it can be used perfectly well as a peripheral device, and the rates of hemolysis with Centrimag are much lower, unlike with ECMO, because there's a membrane oxygenator which is chewing up platelets. So if you want pure hemodynamic support without oxygenation, Centrimag is a better cardiopulmonary bypass device, as you can keep them for longer.
Thank you very much. I think we'll close that session. we'll move on to the next session. Now, may I invite the next set of speakers onto the dais, Dr. Suresh Erra, Dr. Tiny Nair, and Dr. Murthy.
Start on that. Good afternoon, everyone. It's an interesting case about a young male with recurrent vascular events. I'll keep it very short. I know it's just before the lunch break. Coming to the patient details, he's a 48-year male resident of Hyderabad, known to have hypertension and diabetes over the last 9 years. So he had unstable angina in 2014 with a good LV function. So angio done showed left main plus triple vessel disease. So he underwent CABG. Lima to LAD and venous grafts to diagonal OM and PDA in August 2014. So with his background history, in October 2020, he came to us with again unstable angina with a good LV function. So we have done graft angio then, which showed native triple vessel disease with occluded venous graft and patent Lima to LAD and SVG to D1. Male, sir. In the booklet, it was given as a female. He's a young male. So this was the angio, left side angio. So heavily calcified distal left main and L6. As it is a protected LAD, we underwent PCI to left main to L6 with the 2 stents. So with adequate bed preparation using Rota and IVL and using 2 stents, so this was the final stents were well optimized. Similarly, PCI to RCA was done with 2 stent strategy. So I'm just cutting the technical details. So this was the final result achieved in short of time. So with a good result achieved, again in December 2020, he came to us with acute ischemic stroke. He had a right hemiparesis with the right UMN facial palsy. So MRI stroke protocol showed acute infarct in the left pons. So neurologist has seen and he was started on triple therapy with high dose statins were continued. So he was started on apixaban twice a day along with the dual antiplatelet regimen, ecosprin and clopidogrel. So with triple therapy in May 2021, he again had a hemorrhagic stroke. He had a right temporal hemorrhage. So antiplatelet, anticoagulants was withheld. Again in July 2021, he had a acute ischemic stroke with the right hemiparesis. In August 2021, again he came to us with unstable angina with a good LV function. So angio done showed the previous stents which was deployed in left main to L6. He had a borderline ISR of around 50 to 60% in the proximal L6, and in the proximal RCA and mid RCA there was around 70% tight ISR. So at that point of time we had done stress volume which was negative. So we kept him on optimal medical management. Coming to the labs, hemogram was normal, lipid profile was under control with high dose statin. His homocysteine was slightly elevated compared to the reference limit, and his HbA1c was 8, which was later well controlled. So coming to the timeline of events, so in 2014, when he was in late 30s, he underwent CABG. Again in October 2020, he had a unstable angina, underwent complex PCI to L6 and RCA. In December 2020, he came to us with acute ischemic stroke. Then he had a hemorrhagic stroke. Again recurrence of ischemic stroke. Again he came to us with unstable angina in August 2021 with tight ISR of the previous deployed stents. So fortunately over the last 1.5 years, he was doing okay with no recurrence of events. So this is the interesting case which we need to discuss.
Yeah. Huh? Okay. I think the audience knows Dr. Nair very well. He is the very knowledgeable person and versatile.
Thank you. Good afternoon. Good afternoon. Thank you. So we'll keep it short and sharp. So where are we? Right. Which one is it? Oh, this one. Thank you. So, okay. I'm sorry. So where are we? So we have done the best. I mean, you have done the best that is possible for not her but him. We have given a chest call. We have treated him sufficiently well with antihypertensive, anti-diabetic, lipid lowering therapy using RAS inhibitors, SGLT inhibitors, statins. I'm sure we have done that. Attained recommended goal of blood pressure, A1C and lipids, and then loaded him up with sufficient antithrombotic drugs that even his wife is afraid to touch him because he would bleed. Right. Now, this is all guideline, right? Now, this, as you see, is beyond the guidelines. So let us try to see what we can try to do for this gentleman beyond the guideline. And the first thing is that if my resident presented this case to me, I'd first thing say that, did you check for the lower limb pulses? I'm sure you would say, are you crazy? We have done all this kind of stuff. You think we have not checked the lower limb pulses? You certainly would have. But I am also sure that you might not have. Hey, it's moving fast. Yeah, you might not have, in this big melee of CEBGs and all that, done the ankle brachial index of whether it is less than 0.9 or so. You might say, what is the big fun? The reason for this, why we are talking about a peripheral vascular disease or an ABI of less than 0.9, is because if you look at this data, this came from Alabama, Birmingham, and that's where they did the trial. This data of 27,000 patients of extremely high risk. Look at that. This is all on MI events, right? Now, those who are just high risk, no events, their outcome was good, right? If that one event, outcome is there. If that multiple events, their MI events were very high. Acceptable, right? But what is surprising is that those who had no events, they had 27.6% of them had associated POVD, often asymptomatic, detected by ABI, right? And when there was multiple events like this gentleman, 64% had associated POVD. Okay, so association. Why are we bothered? We are bothered about because if you look into the polyvascular data in the Euclid registry of 13,000 patients, you see very clearly that when you associate PAD with a CAD, you have, if you look at what? Primary endpoint, 5.5 times higher. Cardiovascular death, 2.5 times higher. MI, 3 times higher, right? So not just POVD is associated with polyvascular disease, when it associates, the outcomes are pretty bad. But that is not the reason why we are talking about it here. The moment you know that there is some kind of peripheral vascular disease, two important things come into my mind, all of our mind, it should come in. And that is, one is inflammation. And that's why when there is associated peripheral vascular disease in a polyvascular background, think about inflammation and keep CRP in mind. In that background, CRP is a risk marker, right? Also understand that we should also think about thrombosis the moment we are thinking about a multivascular disease, multi-territory disease with a POVD, and there thrombosis comes in and we need to keep D-dimer in mind. But again, these are not the reason why we are presenting about this POVD or ABI altered. Now look at this data. It's Fourier data where 27,000 patients of high risk with an LDL of more than 70, evolocumab, the PCSK9, was tried out, right? And we know the data that on PCSK, there was a massive reduction of LDL by what? 59%. And that translated to what? That translated to 15% reduction of MACE. So, 59% reduction of LDL translated to 15% reduction of MACE. Now, if you tweeze out the peripheral vascular disease group in this polyvascular data, in this data of Fourier, you see that those particular group who had POVD by reduction of similar amount of LDL you get a relative risk reduction of what? 27%. Right, far more than the normal cohort. So what are we talking about? We're talking about PCSK9s. Today are not limited to bare reduction of LDL, but we are talking about far more multiple effects, inflammation reduction, transformation, oxidation of LDL and all stuff. We'll not waste time. So probably I would very seriously think about evolocumab in this patient to once in 2 weeks, 140 milligrams, whether the LDLs are at goal or not. So that is point number one. Point number two, by then the resident comes running saying, sir, you were wrong. The ABI turned out to be normal. There is no POVD. Oh, is it that? But still, our point is valid. Because if you look at this data of this is Odyssey outcome with alirocumab, you see that 18,000 patients. In this data, 1,025 patients had CABG to start with, baseline. Right? And see what happened. Those patients who didn't have CABG, there the PCSK9 reduced risk by what, 14%, while those who had a previous CABG, like our patient here, had a 23% relative risk reduction with PCSK9. So yes, our logic stands. We are giving our patient PCSK9 beyond guidelines, right? Point number two, we were always focusing on platelets, dual antiplatelets, and today things have opened up. Today we know we were neglecting the coagulation cascade. Now we are talking about factor 10, we are talking about direct thrombin inhibitors, and that's why, and as you saw, this patient was treated at one point of time with triple therapy, right? So today we know that if we are talking about this COMPASS data of 27,000 patients, rivaroxaban 2.5 and a small dose of aspirin reduced risk by 24%. So dual pathway inhibitor. Now the point is, many often we fail to understand the impact. If you look into the MACE and mortality and compare it side by side, for example, lipid lowering of 1 millimoles, which with 40 milligram percent, what? Reduction of 21 and 9%. You reduce blood pressure by 10 millimeters, 20% and 13%. ACE inhibition, aspirin. So when you put into perspective the COMPASS data of vascular protection, giving a small dose of rivaroxaban 2.5 BID along with aspirin, you reduce what? MACE by 24% and a mortality of 18%. And very clearly, when we are talking about, why we talked about ABI, because even those patients who had asymptomatic ABI less than 0.9, in this multivascular subset, they reduced risk by 30%. And this is the most important stuff, 8% of those PEDs were asymptomatic. So we might have missed it out unless we did an ABI, and who has the time to do ABI, right? We don't have the time. The hazard ratio in those subsets were also reduced by what? 27%. So PCSK9, rivaroxaban, one small thing is we all know the CVOT trials in diabetes, and we extensively use SGLT inhibitors, right? But we fail to recognize that there is something else called GLP-1RAs, right? As cardiologists, we forget. And they reduce CV events by 14%. So, and not just that, apart from all this, we'll skip all that. Today we know we have oral tablets of GLP-RAs like semaglutide. And you see there, MACE is reduced by 14%, MI by 10%, stroke by 17%, and CV death by what? 13%. Now the point is, this data in this essay in Lancet says that why not? Why not combine the benefit of SGLT inhibitors there on the left, which is about a MACE reduction of 15%, along with GLP-RA, which reduces MACE by 25%. And they said that in patients like this, who has polyvascular disease, CABG, PCI, graft occlusion, what? And finally we say we have nothing else to offer. For him, this gentleman, for his MACE reduction, we should try to control his diabetes with a combination of SGLT inhibitors and GLP-RA. Yeah, so finally at the end, what are we left with? You saw that this gentleman has a little elevated homocysteine. Homocysteine has always been on the fringe, sideline, sitting there, right? Doing their job only when everything fails and nobody is looking at them. But the things have changed. Understand that things have changed. Today we talk about pre-diabetes. We know that data shows that if we are looking into control on the left bar, pre-diabetes is the center, and right type 2 diabetes, there's progressive rise of mean homocysteine. This is not the standard homocystinemia we learn in medicine, right? Like a Marfan syndrome with a hyperhomocystinemia. No. This is a person who is diabetic, who has a tendency for a little elevated homocysteine, like what you saw. We did community trial in Kerala, we found that the standard homocysteine level of everyone is about 20 milligrams, right? We are not talking about that. But if you are talking about connection between type 2 diabetes and homocysteine, a lot of new things have come, including that. This group of people, for example, you see homocysteine more than 15, the lipid profiles are altered, but that is not the thing. We are talking about this here. If you take a neutrophil and put it in a certain specific situation, the neutrophil funnily extrudes part of its DNA outside, what we call as neutrophil extracellular trap. That is actually DNA material coming out of the neutrophil, right? It is like a fisherman's net and studded with those histones, MPOs, elastase, cathepsin G and whatnot. And we today know that in situations, this NET or neutrophil extracellular trap can catch hold of an RBC, a platelet, and set up an entire clotting process, right? Why are we talking about NET here? We are not clinicians, right? We're talking about NET here because this gentleman here has an elevated homocysteine. This gentleman has type 2 diabetes. And today we know that the mechanism by which homocysteine slight elevation along with diabetes creates a atherosclerotic thrombotic event is by activation of this so-called neutrophil extracellular traps. So, there is data here where homocysteine in type 2 diabetes is elevated, and experimentally they have shown that if you take diabetes and expose them to higher and higher levels of homocysteine, there is very clear those green ones are NETs, the NETs increase. So they're pretty well connected now, right? So at the end, we are talking about better diabetic control and probably instituting some folic acid. At the end, this is the last thing. Understand that we were talking about, remember, peripheral vascular, we are talking about inflammation, we're talking about thrombosis, the connection. If you have C-reactive protein elevated and an LP little a, which we call as the connecting link between thrombosis and atherosclerosis, you see in this data, if you have an association of C-reactive protein and elevated LP little a, the risk is high. See, that square box is far away from the line, right? And when you apply these patients, you give this patient a little bit of alirocumab, a PCSK9, the risk significantly comes down. Yeah, so ladies and gentlemen, we are talking about the medical therapy of such patients who had multiple stuff and we have very little to offer. Remember, you are looking at this, right? A very unstable plaque. Think about lipids, think about platelets, think about coagulation, think about inflammation, and think about a lot of stuff which is coming new. Can keep your eyes and ears open. Thank you for your attention.
Dr. Murthy, your comments, expert comments?
I think it's an excellent talk. I think all the information was given by Tiny Nair in a concise form. I don't think I should comment more on this. I think the session is open for discussion.
That is my job. Okay. I think we're already, time is up, so short of time. So I'll just make one comment unless there are comments from the house. I would put it this way. Atherosclerotic vascular events, we should look at as three different components: atherosis, inflammation, and thrombosis. The atherosis part, cholesterol business, we know, probably irrespective of what the guidelines are saying now, probably data will be there that you target a LDL cholesterol of less than 50. If not PCSK inhibitors, probably next week we'll know whether the bempedoic acid will do the job. Then LPA, of course, you have covered. The inflammation, canakinumab has come but not marketed because of the mortality. The colchicine data is equivocal. I'm sure that a lot of work will go on in this area. The inflammation and oxidative stress go together, and we have to look at the oxidative stress also. And thrombosis, of course, they have covered with antiplatelets. Probably in short future we'll have factor 11A inhibitors. But one area is about the homocysteine. We didn't find any difference in the cases and controls, but vitamin B12 deficiency seems to be important risk factors, especially in Indians. We should look for vitamin B12 in your patient and target LDL cholesterol to less than 50. That will be my take on that. Dr.
So, I have a question. Since it's beyond guidelines, what is the role for inclisiran? Let's presume it's available now, number one. And is it essential for such individuals to check their polygenic risk score? It's an upcoming data about polygenic risk score. and let's presume canakinumab is available based on Cantus data, will he get the benefit if we give some I don't know. This is a poor guy. And what kind of antiplatelet was given after this stenting?
Which one here?
No, yeah. That question is directed to the doctor.
I think because of short of time, we will quickly cover up. See, inclisiran, I don't have any practical knowledge. All that we have read is one thing that sets apart inclisiran is that it reduces LP little a. The LP little a is something we are not looking at. Most of the centers were not doing. One LP little a is enough for our lifetime. Even if I take statins, my LP little a, what was 5 years back, will not change. So LP little a once a lifetime gives us a risk score. But there are very few agents that actually reduce LP little a, and one of them is inclisiran. I think it should be good when it's introduced. And if we look at LP little a, we can perhaps write. The other answers, I don't know. Polygenic risk score on paper looks good, and probably should go one step ahead in predicting the.
He got ticagrelor and ecosprin initially, later clopidogrel and ecosprin with the triple therapy.
I think this is too important a topic to be ignored, because all of us are so focused on doing procedures, and when the patients come back with a problem, especially if it's a stroke, we don't even see the lifelong misery that the patient goes through. What would you think is an indication to trigger introduction of colchicine or canakinumab in your, suppose this patient, despite doing everything, his HSCRP remains high?
I think if the HSCRP, unfortunately, the only way we can assess plaque inflammation is HSCRP, which I personally feel is a bad tool, because it is just a general inflammatory marker. But there are emerging new data coming out that we might in the future have a good biomarker for inflammation and atherosclerosis. Still that comes, I think, if the CRP is high, and we have a patient like this who is getting recurrent events, if canakinumab is available, I would go for it. Colchicine, I really don't know, but the data is plus minus.
Now, the reason I'm asking is we started doing PET on several of these patients, not necessarily because of my interest in granulomatous disease. We tend to pick up not necessarily FDG. Gallium dotatate is picked up in some of the places in aorta and the myocardium. Gallium is highly specific for macrophages. It is not picked up by myocardium. So if there is so much of macrophage migration in the aortic wall or within the myocardium, it tells me something. And as I said, it's a poorly studied thing. Probably FDG markers will be more specific. So what happens is, just like NET, when the cholesterol crystals are there and the body is not able to dissolute, they form a set of macrophages and seal it off as a granuloma, and they remain active, and that's what lights up on the scan. So this may not be a long-term treatment. I think the problem we fail to understand is temporarily you may have to give it for 3 or 4 months, at which time everything may settle down. You may be able to withdraw. More to be learned.
Just a quick comment before we close this. If this guy presents to you now, would you give him a PCSK9 inhibitor beyond the guidelines?
For me, yeah, sure, because the last cholesterol I saw was bad. Right, LDL was high.
LDL was 90.
I presume he has not been given PCSK. This is one patient I would certainly give PCSK, guideline or no guideline.
No, if he presents acutely now, I mean, this is the first presentation.
PCSK doesn't do anything to an acute event, right? Once an acute event has happened, PCSK would only prevent a subsequent event. But I would put him on a PCSK, no doubt about it.
So then one more comment I would also do is, I think that's a very interesting case. I think one thing we all should and our juniors should learn is the LPA and the homocysteine are one of the forgotten topics these days. So I think wherever it is indicated, I think we should go with that, and the simple CBP, you just look in for RDW. I think that with patients with such a thrombotic events will certainly help. And we just had a patient whom we did an emergency angioplasty yesterday. In spite of giving sufficient heparin, the patient was, the catheters were getting clogged in between.
And at least once, don't forget to check the peripheral pulses. Those who have trained with us know that for every patient who comes, we make it sure that we start the examination even today, despite all these cath labs and our procedures, and check the dorsal spadius and posterior tibial. at least make sure if you don't have access to ABI, at least tie an ordinary blood pressure cuff and see whether there's a difference of blood pressure. You might get a lot of findings.
Now, after radial came, I think none of the current cardiologists are seeing the. Another thing about colchicine, there's a study for myocardial infarction. I think colchicine is a good drug which we can add for such patient because it's cheap and then and once a day dose. I think we can try colchicine also in this patient.
Thank you. Thank you so much.
Thank you, speakers. Thank you, chairpersons and the audience. Now we'll break for lunch. I request all the participants who are participating in the echo quiz to stay back for the preliminary quiz. And I request all to join back at 2 o'clock for an interesting session of echo quiz that we are going to have. I request the participant to spread out, can come in front. I didn't understand. I'm just waiting. So, can you please come forward, all the participants? So 1, 2, 3, 4, 5, 6 teams. 6, 7. Okay. So I request you to first connect your device and join this Google form. Please enter your details as quickly as possible so that we'll start the prelims.
only one device per team. The other devices to be switched off or in airplane mode. Is everyone ready? Okay. You need to connect to AIG guest, not AIG Wi-Fi. One. And second, if there's any issues with the connection, just let us know. We'll provide alternate devices. If there's any problem scanning the QR code, please enter the URL. Still teams having issues, please raise your hand.
Come on, guys.
It's done.
I request all of you to submit the Google form. There's a specific button, submit. So yeah, so that's all. We can break for the lunch. We'll declare the results after the end of the lunch.
Thank you for your participation.
Number ఏంటి 何度いくかですね。頭出てきて。6つあります。 Click. Okay, sir. అంటే పొడుకుని పెట్టానా ఇప్పుడు కూర్చుందినా ఫ్రీనా
I request the selected team to come forward. Team A will be Srikanth and Abhinay, Dr. Srikanth and Dr. Abhinay from Team A is this side from NIMS Hospital. Team B is Dr. Zia and Dr. Abhi from Osmania. Team C is Dr. Srikaran and Dr. Rajshekar from NIMS. And Team D is Dr. C. Sai Shankar Vinod and Dr. N. Sivakrishnan. Good afternoon. So the intention of this is actually to show you some images, that's all, and to stimulate you to enter the echo room also in between rather than always entering the cath lab. Okay. Are we ready? Can we start? Can check the buzzer, please. That's not working. Second one is not working. Okay. Just search yours. So shall we start? So first, I think I'll show a trial one. Why? Can you please come? Tamal, please come. It's not working. Okay, this is a trial. What is a window? And try what is the diagnosis. Okay, you're saying LV, aorta, LA, RV. Very difficult to get. Arch, all those things, isn't it? So this is actually an unconventional echo window. In some patients, through the right supraclavicular view, you can get it. Okay. Can anyone tell me what is the diagnosis? Pass. Okay, we don't have time to waste. So this is LV, this is ascending aorta, arch, and it stops here, isn't it? You see two. So what is it? Interruption, aortic interruption. And what is this? One pulmonary artery arising from ascending aorta. So the diagnosis is, from this view, it's a hemitruncus with aortic arch interruption. Okay. So now we are going to the real quiz. So this will be about windows. Okay. So I will be showing one picture. You have to identify what is a window and what is probably the diagnosis. In some questions, there will be only identification of windows. Okay. So team A. Now what is the diagnosis and what is the window?
RV outflow.
Okay, what is this window? What is the name of this window specifically? This is for looking for what?
Main pulmonary artery.
What?
Outflow, main pulmonary artery.
No.
And pulmonary valve.
Okay.
Pulmonary artery branching pattern.
No. Team B. Pardon? Suprasternal wave. No. Team C.
Basal short axis at the level of great vessels.
No. Team D. Modify? No. So this is what is called the ductal window, ductal view. Okay. This is to identify patent ductus arteriosus. What you see is the RV pulmonary artery, RVOT. This is the left pulmonary artery, and to the left of it, you see patent ductus arteriosus. Now this window is very important because in patients with severe pulmonary artery hypertension, you may not see the brilliant color. Okay. So you will easily miss large PDAs if you don't take this window. So that's the importance of it. And so this is the window. So no score for anyone. So who is taking down the score? Somebody is yours taking the score. So okay, that you can put whatever it is. Okay. Because the rules are shown. Okay. 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 Okay, what is a window? And try what are the structures labeled 1, 2, 3, 4, 5. Okay.
Suprasternal short axis window.
Okay, what is this view standard view called? It's suprasternal view, but what is it called? Pardon?
Crab view.
Crab view. Okay, good. Then, okay, what are the structures? Start from here. What is 4?
Left atrium.
Okay. 5.
This pulmonary vein entering into the left.
This is
pulmonary vein.
Pulmonary vein. This is 3 is
3 is right pulmonary artery.
Pardon?
Right pulmonary artery.
Right pulmonary artery. This is
2 is aorta in cross section.
And this is 1 is
1 is SVC. SVC.
Pardon?
Innominate vein.
Okay. So full mark for team A. Okay, which structure is imaged? One structure which you seldom image is specifically imaged. It's important in congenital heart disease. May have some importance when you are doing interventions. Yes, team B? Very good. So this is the right infraclavicular or supraclavicular view to image the azygous vein. So this is the azygous vein which arches and enters into the superior vena cava. So full mark to team B. Okay. So what is being imaged? What is the purpose of echocardiograph? What is he doing? Yes, team A. Pardon? Deep pressed.
Lung ultrasound.
You pressed, isn't it? Okay. So what's the diagnosis? What is being imaged?
Lung ultrasound.
Lung?
Ultrasound.
Louder.
Lung ultrasound.
Lung?
Ultrasound.
Ultrasound. Okay. So what is the finding? Okay, pass. You get half mark. Any comments? What is it finding called? You see a lot of lines here, isn't it? What is it called? It's a term for it. I am surprised. So this is called B lines. So you should be familiar with lung ultrasound. Okay. So when a patient comes to you to the casualty with acute dyspnea, just place the probe on the second left intercostal space and look for it. Okay. This simply indicates fluid in the lung. Okay. So I think half mark you can give it to team A, isn't it? Okay. What is this echo window? What you have to name it and for what purpose it is taken. Because I have shown the structures, it is LA, RA, IVC. So okay, what is it? Who pressed? D, team D. What's the window? I am sorry, this is not subcostal. Subcostal doesn't look like this, isn't it? There's a chapter in Naveen C. Nanda's book, Unconventional Echo Windows. How many of you have read it? Pass? Anyone? Okay, this is called a right parasternal window to demonstrate the IVC rim of ASD. Okay, so this is ASD with absolutely shaved off IVC rim, and this is very high risk for device embolization. So this is right parasternal window to assess the IVC rim. Okay. Now the next session is called bubbles. Okay, you know contrast echo, just saline, agitated saline contrast. So we poor guys have only that. Okay, costly contrast agents are not there. Okay, so I'll be showing images. You have to carefully see and tell your diagnosis or at least describe where it is injected. So be careful. Okay, team A.
Bubbles are seen from LA to LB. Possibly injected from the left basal vein to the left persistent LVC. Bubbles are entering from left atrium to left ventricle. Maybe basically entered from left basilic vein, persistent LVC, LSVC.
Excellent. So this is actually the bubbles, that contrast is injected into the left upper limb. So the left SVC draining into LA. So actually this patient was diagnosed to have a normal heart from 3 institutes. Okay, so the patient saturation was low, say just 92%. So to avoid such disasters, what you can do is when the moment the child enters into the echo room, you connect the pulse oximeter, and if it's below 95%, you have to find out a reason. Okay, this is practiced in many institutions. Actually, this patient had brain abscess. So that was undetected in multiple hospitals. So when if you want to put a IV line for doing a contrast echo, you always put it on the left upper limb. Okay, so they get the full points. Maybe slightly difficult one. Team C.
Bubbles are entering from LA to LV and from LV to RA, maybe Gerbert effect. LA to RA also.
Okay, you carefully see from where exactly the bubbles enter into LA. First shot. Is from pulmonary vein, isn't it? So no more for you, but I will explain why you didn't notice this thing. What is the structure? So I will give you a clue. I was doing something in the cath lab. Structural intervention is a weakness for me. I have given a clue. Pulmonary? No marks for you, but just to stimulate you to have a curiosity. So this is a catheter into the pulmonary artery. So I was closing a pulmonary AV malformation. Okay. So injected straight into pulmonary artery because why this patient had a ASD also and severe RV dysfunction. Okay. This is a very complex case published in Indian Heart Journal, biventricular cardiomyopathy with pulmonary AV malformation. So there is a right to left shunt at the atrial level. Okay, and to demonstrate this, so I injected the contrast into the pulmonary artery. So you can see it is coming from, see it arising from the pulmonary vein. Okay, so no marks for any of you. So you can, using little bit saline and bubbles, you can do wonders. Okay. Now again, look carefully and tell me the complete diagnosis. Okay, team B, you will have to tell all findings, only then you will get the full mark. Okay, you press 10. What is the complete diagnosis? It's a contrast, isn't it? It's coming serially, this contrast first in RV, then after 3 beats or more than 3 beats, mostly AV pulmonary AV malformation. Okay, so can you see it anywhere? Can you see the pulmonary AV malformation? Here in this window, sir. Okay? Yes, sir. The down. Okay, so just concentrate on this cavity and then serially see how filled here, and then see, you can see it being filled here and then so it's a pulmonary AV malformation. So it's another case which we closed. It is a hereditary hemorrhagic telangiectasia. Okay. So okay, you get half mark. Okay, you are not that prompt. Okay, no clue will be given. Nothing. Yes. TB.
Suprasternal view, sir.
Okay, suprasternal view.
Aortic dissection possible.
What is the diagnosis?
Dissection.
Wrong. Okay. So you get negative mark. Why should I do contrast echo for a aortic dissection?
No, dissection.
Okay, anyone? See, just see carefully. This is aorta, isn't it? So what happens to the contrast? It is entering into aorta. So when it is injected into the RARV PA, enters into aorta. So what is the diagnosis? PD. So in all Eisenmenger syndromes, I told you first the ductal cut. It is easy to get in small infants, but you will miss it in adults. And before saying it is just primary pulmonary hypertension. So you always do it because see in what percentage of patients you get all these differential cyanosis and all? Not in all, isn't it? Okay. The final one, contrast. Okay, team B.
This is ASD with negative contrast.
Okay, very good. So it's a simple one. You can easily see the ASD flow. See, and see the negative contrast. It is described in all the textbooks, but occasionally it's interesting to do it. Okay, so you get 4 marks. Compensate for the last negative mark. Okay. Now when we reach the time, please inform me. Okay. M mode. Okay. So what is the M mode diagnosis and what is measured? What is being measured? Okay, team D. Pardon? I'm sorry, you get negative marks. Anyone else? Okay, not prompt, pass. I will give you a clue. See, what is here? RVOT, isn't it? It's dilated. So it's a condition where the RVOT is specifically dilated. Congenital heart disease with RVOT is specifically dilated. Epstein. So there is a closure of the tricuspid valve, closure of the mitral valve. So the M1 T1 interval is what is being measured. Okay, so no marks, and you get negative. So what's the M0 diagnosis? Okay, team A.
PML prolapse.
Very good. So see, we do daily see cases, but never ever put M mode or critically evaluate pulse Doppler, continuous wave Doppler, etc. Isn't it? So you are fascinated by interventions in the cath lab. So spend time with the echo machine. Okay, at least sit with the echo technicians and learn from them. So you can see it is being put and see the systole, that is pansystolic prolapse of the mitral valve. So this is MV. Okay, team B. Okay, color M mode, but what is the diagnosis? I won't show it, simply a color M mode for you.
Reduced propagation velocity.
Okay, so I'm sorry that the QRS complexes are very small amplitude. So carefully see between the QRS complexes and then comment.
Restrictive filling?
No, you are wrong. Answer is wrong. Not asking you what are the causes of diastolic mitral regurgitation, so you go and read. For exams, it may be asked. So none of you get, so probably you get unfortunately negative marks. Okay, M mode. I thought you will tell in fraction of seconds. Please stop me when the time exceeds, okay? Okay, so I'm not saying, see, this is the typical appearance induced by LA myxoma, okay? So it prolapses through the mitral valve in diastole, okay? So put M mode everywhere, okay? So what is it? Last question in the M mode session. Okay, pass. I'm sure you are not. So what is this thing? In between you find opening of the leaflets, isn't it? Okay, it is an AV block. Okay, it's too difficult. I think I will pass it. Now coming to intervention. You people are all interested in interventions, isn't it? So let me see. So what intervention is being done? We have done only once in a patient who was dead against surgery. Okay. Anyone? Pardon?
Mitral clip.
Mitral?
Clip.
See, this is mitral valve, isn't it? So I'm not passing the question. I think it's too difficult. This is a mitral valve, but if you're careful enough, you could have easily answered. This is a mitral valve. This is the aortic valve. This is LVOT, and balloon is inside the left atrium, and this is a membrane inside the left atrium. What is it? Core triatrium. So it was a very tight core triatrium. Patient had a severe PAH, bronchial asthma, then some scoliosis. The patient was not willing to undergo surgery. Anesthetist was not willing to give anesthesia. So we took and we had a wonderful result. Okay. So this was again a mess up from my hand. Okay, what blunder did I do? Okay.
I guess. Two station.
Always not. Actually, after the T, I myself have written in the can you please connect it? OP ticket in echo report that there is a prominent eustachian valve. So be careful. But this was not conveyed to me in the cath lab. So I just scrapped it. I just asked what is the next case. They told AST device closed. So I went it and deployed. And so what will happen if I do it like this? The IVC blood will be directed to LA. Okay. So the patient had to be taken to the theater and then AST had to be closed. So there are various techniques. You can go and read the catheter cardiovascular interventions. There are various techniques to handle this issue. Okay. Maybe tougher one. You may think that I wanted to show you all these things which I have done recently, but not that way. Maybe 15% is correct, but my intention is to stimulate you. Interventional echo is another very fascinating area. I know it's a tough one. Okay, because I won't put negative mark for you. You can just try. So it's fantastic. So it's a gerbo defect which is closed. You can see ASD device, part of the device inside our right atrium, and the other is probably not seen, but you can see a prosthetic mitral valve. So during surgery, an LV or a shunt was inadvertently created, and that I closed with the device. Okay, I think this will be easier for you. Okay, team A. Yes.
Prosthetic.
Pardon?
Prosthetic mitral valve.
Okay, prosthetic mitral valve. What is the intervention? What is the procedure which is done? What intervention is done? Oh, it's a bioprosthetic valve, isn't it? The appearance is that of
Carpentier-Edwards valve.
Okay, so what is the procedure which is being done? That's a question. So, pass. Team B. I thought it will be quite easy for you. Widely done. It's a complication induced by surgeon which is handled by us. That is why it is a cardiothoracic team, isn't it? So we will help them, they will help us. See, okay. No more mark. What is the structure? What is this thing? Yeah, it's a paravalvular leak closure, isn't it? Okay. Please inform me if I exceed time. Now next is post-operative congenital heart disease So which condylar disease was operated? Okay, team, which team? Raise your hand. Okay, what is a? Oh, I'm sorry. See, choroidity is a membrane like this, isn't it? Which divide LA into upper and lower chambers rather than right and left. Okay, I will tell you, it's a congenital cyanotic heart disease. Anyone? Okay, I won't wait for, pardon? Very good. So this was a common, so no more for you, but this is a common chamber which was connected to left atrium. Okay, so no marks for anyone. So this was again a surgery for a congenital heart disease. Okay.
Stuff tough.
Oh, fantastic. Oh, what surgery? I thought you were going to tell the answer also, but what surgery is done? How many exits from RV to PA? Eh? 2, isn't it? See, both are regurgitating also. So, okay. So, what is it? What is this? I am showing something like this. It's called double barrel surgery. Okay. So, what condition do you do it? When there is a large artery crossing the RVOT, surgeon cannot incise the RVOT for a patch. So they put a RV to PA conduit also. Okay. So there are, that is why there are two. That's why I showed you like this, double barrel. Okay. I think this will be easy for you. You should tell. Anyway, you are not going to see. Now I am 55. I might have seen, but you may not see. You are youngsters. Now surgeon is doing something else. I thought it will be easy for you. Tried even as a palliative procedure in Eisenmenger physiology. Surgeries and interventions in Eisenmenger syndromes. That is one of the theory questions which I read from somewhere. Okay. So what's who pressed? B. Okay, what is it? Pardon?
Procedure.
Eh?
Rash kind procedure.
What? Pardon? So what do you find? Is it too interatrial septum? Nothing, isn't it? You cannot have like. So there is some baffle inside. So what's it? For what surgery? The palliative sending is the clue which is given. So this is a sending for, that is, these are the baffles inside the, so atrial switch operation for TGA. Okay. Now people are doing left and right arterial switch, so you may not see it. Now, if you try, just try, otherwise I will tell the answer. Name the palliative surgery done. The surgeon has done something. He has closed off, but little space is given. So what is this surgery called? Starness procedure. Okay. Okay. I will leave it here. It's an extremely rare complication after surgery. So can you tell what it is for a cyanotic heart disease with low pulmonary blood flow? What surgery and what complication? Pause. Okay. What's the complication? Agree. It's a BT shunt. It's coming and it's a continuous flow here. Then what complication did the surgeon induce? So you get half mark to say huge aneurysm at the insertion of BT shunt. Okay. So you get half mark. This you should be able to tell, especially those who have a pediatric cardiology department in your, it's a post-operative case. The way in which the VSD is closed, the way in which the patch is put, gives a clue. Okay? Okay? Now, this is a patch put by the surgeon. Why he closed the VSD like that? Pardon? No, actually, this is a tunneling of from LV to aorta in which procedure? TGA, VSD, PS. Which procedure is it? Okay, I will recount. Okay. Now post-operative adults.
Sir,
Sit time.
last 2 minutes, sir.
Pardon?
Last two, 3 days.
Two or
5 minutes, sir. 5 minutes.
so 3 more images. Okay. Okay.
Sir, the scores have been updated there. It's the screen.
Just
above.
tell you just read.
Team A is 30, Team B 40, Team C 20, Team D minus 30.
So there is no tie.
At present.
At present there is no tie. Okay. So what is the surgery and what is the complication? Anyone? So how is it a normal aorta or looking different? Is it refractile or I have given much clue for you? If you have done echo once, I think you should not miss it. Is the aortic valve replaced? What is this? So aortic valve is replaced and this is replaced. So what is it? Ventral surgery with AV, isn't it? So the complication is a huge pseudoaneurysm. I think it's too difficult for you, but now I will leave it. This was a mitral valve replacement. So this is not a paravalvular leak. You may think like that. This was actually a aorta to LA tunnel. I don't know how the surgeon induced it. So we closed it with a device recently. Okay, this you should tell. The complication. Okay, full diagnosis. Only then you will get mark.
It's a
Team C.
prosthetic mitral valve.
Okay, prosthetic mitral valve with
replacement with
pardon?
LV2 RA.
Okay, so this is a unique complication. Only very few cases are reported. Well, some 10 cases are reported. So mitral valve replacement with an LV RA shunt. So what to say? Shall we stop?
There's a tie between B and C, sir. So
Time?
B and,
Oh,
B and
tie.
C with 40 points equal. So we'll have one more.
Okay. Between B and C, isn't it?
Yes, sir. Only B and C.
Read it, isn't it? Patient with AV block. Pardon? Unfortunately, you get negative mark. So I told you this is an AV block, and you see something, a space-like thing. So that means something is compressing the conduction system. So what is it? I won't pass it because so it's an unruptured sinus of valsalva aneurysm compressing the conduction system. Okay. Whoever press the button quick will get through probably. Nothing will be told. This is sort of just look at it and make a diagnosis. Of course, definitely after a clinical diagnosis. Patient under follow-up in gastro has cirrhosis liver, portal hypertension, ascites. For Disney evaluation, they refer to cardiology, and I have had to have a look at the JVP and then I diagnosed it. So what is it? Still, they are not saying. So what's it? What is the diagnosis? I am surprised. Not surprised, depressed. Because the way cardiology training is going on, I'm sorry, I'm not making any comments against anyone, but Even my own students are all interested in interventions only. Okay. 24 hours primary angioplasty going on, so they will be doing left and right. So I have given you the clue. What is this?
Constrictive pericarditis.
Somebody undergoing treatment as cirrhosis, ascites. Then I looked at the JVP and told this is not cirrhosis, something else. So what is it? Constrictive pericarditis. So what is the finding? Okay, I think still the
So B and C both are giving each negative answer, so still they are tied up.
So again you need a tiebreaker.
This one correct.
This you.
This you will have to tell the correct term for it. Okay, pardon?
So no, they didn't answer correctly. Then, see, they didn't. Both B and C didn't answer the tiebreakers correctly. Sir. There's one more question. We need to break the tie along for B and C.
One more question. Only one. This you will have to tell the correct answer, correct term which is used in textbooks or publications. Okay. Aortic dissection, agreed. But what is the term? I told you, you have to tell the correct correct term which is used in publications. How is it prolapsing into the LVOT? So you look at it only if you have read articles and case reports, you will tell that. Okay, you won't get marked. So this is called intimo-intimal intersusception. Okay, that's the way it is used. Anyway, one more to break the tie. Okay, sorry. Can you just help? Oh. An echo of a 2-year-old deaf child who had eye surgery in the past diagnosed as severe coarctation of aorta and small PDA and referred for balloon dilatation to us. What are the two mistakes made by the referring doctor? So read the question once more. Echo of a 2-year-old deaf child who had eye surgery in the past diagnosed as severe coarctation of aorta and small PDA referred for balloon dilatation of coarctation of aorta. What are the two mistakes done by the referring cardiologist? This looks like coarctation. So indirectly I am saying that it is not coarctation. You know why I came all the way from Calicut to here despite a shoulder subluxation? Because the invitation was from none other than Narasimhan sir. It was a big honor for me. And not only that, even on Thursday is our case discussion day. So before entering every Thursday to that room, I just read Somaraju sir's book. Okay, that old book with the green cover is still with me. So he has given a lot of clinical scenarios in that book. How many of you have read that book? I might have read more than 100 times. How many times you have read? So this is looking like coarctation, isn't it? So what are the two mistakes done by the referring doctor? Okay, so I thought you will immediately tell the answer. So aorta is clean. So what happened? What mistake? So that's a PDA. What mistake did the referring cardiologist do? I thought you will tell that. Okay, pause still. So this is the left pulmonary artery, isn't it? This is again the ductal cut which I have taken. See the flow acceleration at that time, at that point. So what happens is the left pulmonary artery, your pulmonary artery divides, left pulmonary artery sharply descends along. This is the way it moves. When you put the continuous wave Doppler, always palpate the overlaying movement. Why we all start. Nervous when the patient is lying, the way I start, one, examination also that may be your ultimate. You touch the weight of the patient, feet of the patient. Go and palpate the overlaying. Don't palpate the overlaying. It's a flow. Referred by cardiologist to another cardiologist for doing walking. LPA, there is enough clue also. This patient had a deafness, like surgery. What's in the
Congenital tuberculosis.
arterial stenosis? Is it? What to do? You will divide the prices or
Yes, sir. Yes, sir. Now the tiebreak is clear. No, it's clear.
okay. Okay, last one. Last one. If possible, share the prices. Okay. It's an excellent. Endometrial fibrous, no. Probably all seniors sitting here might have seen. It's now almost extinct. This is endocardial fibroelastosis with mitral irritation. So anyway, I think they will have to divide the price.
Present C has told less negative, so they got
One team,
they told less negative than B, so they are the first place.
So which team?
Team C.
Team C. Anyway, don't get depressed and all. My intention was only to stimulate you, just to show you some images. That's all. Okay.
Sir, we'll have Krishnam Raju sir and Dayasagar Rao sir to hand out the prizes.
Like to thank the quizmaster first because it's not easy to put together a wonderful collection of these cases. A big hand to Dr. Rajesh for making this possible. May I request the two doyens of cardiology, Dr. Krishnam Raju and Dr. Dayasagar Rao, to come over and hand over the certificates for the winners, please. Dr. Dayasagar Rao, sir. Certificates, Pritam. Team C. Team C is the winner, no? Please come. Team C is 39 points. I don't know. Can you just identify yourself? Team C, can you pass on a mic to them? Thank you so much.
I'm Dr. Srikiran, sir, final year cardiology resident from NIMS, sir.
My name is Rashekar. I am also a third year resident from NIMS.
From NIMS. Both of them.
I'm Dr. Syed Zia, final year cardiology resident from Usmania Medical College.
I'm Abid Hussain, third year resident, Usmania Medical College. Yes.
For the next session, I'd like to invite Dayasar Rao sir, Dr. Pramod Kumar, and Dr. Rajiv Garg to join us on the dais. That's
Very good afternoon. After a very educative eco quiz, we'll be discussing a case which involves a condition in which if we manage it well, it gives us good dreams. But if we are not able to manage this condition, it can give us nightmares. So this is a case of a 66-year-old female. She's a hypertensive, diabetic, COPD on bronchodilators. Diagnosed as severe LV dysfunction, DCMP on follow-up with a EF of 32%. She had persistent atrial fibrillation for almost 2 years. In and out of the hospital, has been taking medications, has been NYHA 3, sometimes 4, recurrent hospital admissions, all with heart failure, AFib. She was optimized on medical management with rate control drugs, antiarrhythmics, and standard GDMT also. Still, the heart failure admissions continue to happen. In this center, as most of our atrial fibrillation patients, we tend to cardiovert. So that was also offered to her, but the cardioversion intervals reduced. She kept coming to the ER requiring multiple cardioversions. They were failed. Transient conversion to rhythm, initially sinus, but then most of the times in AFib. So this was her baseline ECG when she came. She was having a right bundle AFib with a QRS which was 160 milliseconds. And 2D echo showed that there was severe LV dysfunction with mild mitral regurgitation, mild RV dysfunction, and just about dilating LV. And there was, of course, evidence of diastolic dysfunction, mild pH. So we have a lady who's multiple comorbidities, severe LV dysfunction, almost going into permanent atrial fibrillation now, and recurrent heart failure admissions with conducted rhythm. So what options do we have? Normally, if you talk about managing atrial fibrillation, first thing that nowadays comes to our mind is whether they are candidates for catheter ablation. The other...
Can we see the echo report again?
Sure.
I often wondered how you got the A wave in a patient who is in atrial fibrillation.
So the A is, it's not to be seen at all because if it's been reported, yes. Because it's anyway 0.3 and that's not, it's varying.
See, the A wave, so-called A wave in atrial fibrillation is actually H wave, mistaken for A wave. Thank you.
But H wave is described in the hemodynamics, not on the Doppler. H wave is described in the hemodynamics.
Yes. So coming back to the treatment options, catheter ablation, of course, for this patient was not on the card. She was permanent AFib and heart failure, elderly, multiple comorbidities. So the other option that we tend to offer is a device and AV nodal ablation. She is a patient who has heart failure and recurrent heart failure. She has atrial fibrillation, so and likely to develop a pacing indication also in future. So this is a candidate for a cardiac resynchronization therapy with an ABJ. The other two options, of course, the heart transplant is using a shotgun to kill a fly in this situation, and of course not very practical. Of course, continuing medical therapy was not an option for her because she was already on that. We had reached an end where we had to do something for her. This patient had a right bundle and mild RV dysfunction. So if you go by the traditional indications, doing a traditional CRT may not provide good results as per whatever data we have. When she came, we were doing conduction system pacing, so that is what we offered her. We took her up for a conduction system pacing with an RV lead ICD backup. So in this image, you can see that there is a RA lead. There is a smaller lead which is around, there's one catheter coming from the groin, which is at the his, and that is an ablation catheter. Just near that is a smaller 4-inch lead, which is basically the conduction system lead, the his bundle lead, and there is an ICD lead in the RV. So this was when we were manipulating and placing the lead and doing the ablation, AV nodal ablation. This is the EGM that we can see where we are trying to locate the his bundle using and pacing it. And this is where we ablate. Normally we place the his bundle lead anteriorly little bit, and the ablation is done posteriorly. One thing that we do is we always keep the sheath through which we pass the lead in place when we are doing the ablation, acts as a protection. And after we are done with the successful ablation, we slit the lead. This was the final position. See, the RV ICD lead also acted like a backup RV pacing lead in case in future the his bundle lead tends to either there are raised thresholds, since this patient is now pacing dependent. So this was the post-operative follow-up ECG. You can see that it is, the ventricular rates are pretty regular, narrower, and on follow-up, this patient has had a significant improvement in quality of life and has been coming on routine follow-up with us. Follow-up echo also tend to show better progression, almost near normal EF. So now in hindsight, maybe it was just tachycardiomyopathy which was acting to her troubles. Open the case for discussion.
We have a presentation and have discussion after the presentation, or we want to have some questions? We'll have a talk. Okay. Good afternoon, all and one. Thank you for this opportunity. I'd like to thank Dr. Narasimhan for having me here. So my talk or my part is to talk about the integrated management of atrial fibrillation. Over the next 20 minutes, I'll be talking about the integrated management of atrial fibrillation. So why we are talking about atrial fibrillation? All of us are aware when we sit in the clinic, in the OPD, this is one of the commonest arrhythmia which we see in the clinical practice. So it is not only an arrhythmia, it's a systemic disease we all are aware of. And with the improvement of the management of the cardiac diseases, coronary artery diseases or heart failure, longevity, we are all aware that the incidence of the atrial fibrillation has been rising exponentially, so much so that if you see the recent data, 8% of the world's population has atrial fibrillation. Next, the problem with the atrial fibrillation is 2/3 of the patients with the atrial fibrillations are first diagnosed when they come up with some of the complications related to atrial fibrillation, because this disease is associated with the dreaded complications of the stroke. So early diagnosis is challenging in patients with the atrial fibrillation. Next, I would like to emphasize this. There's no one time point answer or solution to atrial fibrillation. It's a progressive disease. More is the age, more is the chances of atrial fibrillation. And if you leave patient in atrial fibrillation abnormal rhythm, it begets atrial fibrillation. The chances is more that patient will go into permanent atrial fibrillation. Because it's a case-based discussion program, so I would like to discuss with the case as a 62-year-old gentleman having hypertension since last 12 years. And we all are aware that this is after the age, one of the commonest cause of the non-valvular atrial fibrillation. He had shortness of breath. His main symptom was, apart from shortness of breath, syncope and frequent episodes of blackout. If you see the echo of the patient, he had predominantly restrictive physiology on the echo and he had shortness of breath. and is one of the ECG. He had sinus rhythm ECG, but one predominant one of the ECGs, he had atrial fibrillation with fast ventricular rate. So when we go and talk about the management tree of the atrial fibrillation, we should be talking about the domain. There are some 5 domains for the management of atrial fibrillation. When the patient comes to the hospital with atrial fibrillation, what is the acute management? Once the patient comes, whether should I go for rate control or rhythm control? Should I jump on suddenly for the rate control or rhythm control, or should I stabilize patient first and regularize the rate? Second most important is there is substrate for atrial fibrillation, there are triggers for atrial fibrillation. So we should search for what are the triggers for the atrial fibrillation, or what are the precipitating factors for the atrial fibrillation. I should be first treating the precipitating factor, which can be uncontrolled hypertension, which can be undergoing ischemia, which can be heart failure, refractory heart failure, septicemia, or patient having lung disease, having a COPD, or having a pneumonia. Next is, once you have managed patient acutely, we need to see the stroke risk. Chadwa score, I think we all are aware of. If the Chadwa score is more than equal to 2, we should consider long-term oral anticoagulation for this patient and assess the heart rate of the patient. If you are not able to give rhythm control, you should see the assess, can I regularize the, can you slow down the heart rate so that patient improves. So apart from this, when we talk about the management of the comorbidities of the atrial fibrillation is very important. So what are the comorbidities? Commonest is hypertension. We should be thinking about controlling the hypertension. In that, ACE or ARB plays a very crucial role because of its antifibrotic properties and in modifying the substrate of the left atrium, not only left atrium and the heart, and improving the outcome of atrial fibrillation. Role of mineralocorticoid receptor antagonism in heart failure, role of statins for vascular complication, and sleep apnea management of, because this is one of the underdiagnosed thing in patients with atrial fibrillation, managing sleep apnea. And last but not the least, cardiac rehabilitation, that is explaining patient about the weight reduction program is very important. So once we detect, as I said, not only treating the underlying conditions, examining the patient, we are talking since morning, the importance of examining the patient. Any patient young patient who comes with atrial fibrillation, we should ask detailed history, proper examination. There is a common term used as a lone atrial fibrillation. For my understanding, there is nothing called lone atrial fibrillation. If there is an atrial fibrillation, there should be some harboring, something disease should be there, we should be searching for, and we should not be diagnosing anything as just a lone atrial fibrillation. Look for any addictions, look for any lung diseases which we can treat and make patient improve. This improves the outcome of management of atrial fibrillations. So if you see the 1-year mortality in patients with the atrial fibrillation, as I already told, by the time patient reaches us or we detect that patient has atrial fibrillation, already this disease must be going on since last few months or over a year. And by the time you diagnose the first detection of the atrial fibrillation, survival decreases drastically. So it is very, very important that once you first detect atrial fibrillation, we should be doing thorough workup at the same time to improve the outcome or improve the survival of the patient. Going back to our case, and if you see a simple extended monitoring then shows this. So what were his predominant symptoms? His predominant symptoms were syncope and blackout. So this patient has underlying sick sinus syndrome, and along with that, once there is a bradycardia, he had atrial fibrillation and had termination pauses. So what do you do in this patient? When you do a pacemaker in this patient for sick sinus, it's very important that if you see with the lower rate setting of 60, he is almost more than 99%, that is 100% A pacing without any V pacing, because you have kept a very long AV delay. So managing these patients are very important, because you don't want to pace ventricle in this patient. You want to just pace A in this patient, and if required, give drugs for the underlying disease. He improved over the time. He didn't have any heart failure hospitalizations. This is another very interesting case. 26-year-old gentleman, recurrent palpitations, no comorbidities, thin guy, diagnosed as lone atrial fibrillation. And if you see his Holter, there are recurrent episodes of atrial fibrillation with the baseline normal ECG. So why this guy who's a thin, normal, no comorbidities to treat should have atrial fibrillation? So because before jumping on, because he was advised pulmonary vein isolation or catheter ablation for atrial fibrillation, before jumping in for this, we should be thinking why it has happened. So what do you see here? What's there in this patient in this MRI? So you can make out what is this. He had an LV, big segment of LV non-compaction. And if you properly ask family history of this patient, his grandfather had dilated cardiomyopathy. One of the paternal uncle had early complete heart block required pacemaker. You do genetic analysis of this patient and he has filaminopathy, that is FLNSE mutation. So you know that whatever you do, you cannot give cure to this patient. You should be knowing the underlying disease of the patient. So regarding when we talk about the targeted therapy for underlying condition, this is a very good trial. I thought I should mention about this trial. It's a randomized trial, RACE 3, which was done over 14 centers, in which targeted integrated therapy was compared with the conventional therapy. So what is the conventional therapy? You do pulmonary vein isolation only. And what is the targeted therapy? Along with pulmonary vein isolation, you treat all the underlying diseases, that is treatment of the hypertension meticulous, treatment of the sleep apnea, cardiac rehabilitation. You tell them that you have to, there's a program, you have to decrease weight, decrease BMI to less than 25, treat the heart failure. If you take care of all these things over 1 year, the patients in whom targeted therapy was done had a more patients were in sinus rhythm as compared to the patients in whom only conventional therapy was done. And the patients, if you see the burden of the atrial fibrillations, patients in whom the integrated therapy was given had more atrial fibrillation, free of atrial fibrillation as compared to the patients in whom conventional therapy is done. So when we talk about new onset versus chronic persistent atrial fibrillation, as I spoke about, AFib begets AFib. So once you have taken care of all the underlying diseases, we should plan or we should target for rhythm management. And for the rhythm management, what thing comes in our mind is pharmacological cardioversion. And I would say that always have a very low threshold for DC cardioversion of this patient. We keep on poisoning these patients with multiple antiarrhythmic drugs, whereas the cardioversion is a much safer option. And I would like to emphasize here one point as cardioversion is not only a therapeutic, it is diagnostic as well. Because if I do a cardioversion for a patient and if patient reverts and maintains sinus rhythm, I know that whatever therapy I use, for example, if I want to do pulmonary vein isolation, the chances of success of the procedure is much more, whereas the patients in whom if I have done a cardioversion, it doesn't revert. And when we are taking patient for the cardioversion, when you do transesophageal echo, always try to see for the LA appendage velocities. If your LA appendage velocities are very low, for example, less than 20 centimeter, it's a very low LA appendage velocity. That means it's already an aneurysmal LA. It's a big LA, aneurysmal LA. It may not revert. Patient may not maintain sinus rhythm, and we should forget about rhythm control. We should target about the rate control therapy in those patients. So always have a low threshold if there is no clot inside the heart to go for the cardioversion in the patients. What is the problem with pharmacological therapy in these patients? World over, if you see, there are a lot of trials which says that if you prolong long time, if you give multiple pharmacological drugs, there is no improvement in the heart failure hospitalization or survival. What is the reason? The reason is not a failure in the rhythm control. The reason is we are not able to bring the antiarrhythmic drugs which are free of toxicity. Because major antiarrhythmic drugs are having a lot of toxicity and lot of interactions. So we are not able to bring the drugs which can maintain the sinus rhythm. That's why the role of non-pharmacological management has come into play. And I think we all are aware of, after managing the comorbidities, you can think about doing the pulmonary vein isolation. And earlier you do this kind of procedure, better is the outcome of these kind of patients. I'd like to give an example of 61-year-old lady, chronic rheumatic heart disease, post-mitral valve replacement. She had chronic atrial fibrillation, and this was persistent atrial fibrillation going on at least since last 3 years. So we always attempt cardioversion. This patient, we were used to do cardioversion, she used to revert, and after few months, she'll again go into atrial fibrillation. So the last 1 year, we had done 3 DC cardioversions in this patient, and she was not responding to medical therapy. So in this patient, you take for the we call it pulmonary vein isolation or substrate modification of the left atrium. She had a diseased left atrium. This black area or gray area shows that the amount of scar is big in this patient. And this below the long fractionated area shows that yes, there is a scar burden is high in this patient. But you do an ablation in this patient and you can see this halter. She reverts to sinus rhythm. And you pace after the ablation, there is no atrial fibrillation again, and her quality of life has improved, her hospital admissions has improved, her number of drugs she is using for atrial fibrillation has come down. This is another case example I'd like to show is 70-year-old male who had atrial fibrillation diagnosed since last many years. He was in persistent atrial fibrillation since last 2 years with lot of comorbidities. He had coronary artery disease, hypertension, hypothyroidism which was controlled, Parkinson's disease, obstructive sleep apnea, and normal BMI, NYHA class 2, 3. One thing I'd like to emphasize in this patient, this is the list of the drug. When he comes to you, this is the list of the drugs he is on. Anytime when you see a patient in the cardiology OPD, and all of us would have seen, as soon as your number of drugs goes more than 10 or 12 above, we all know that there is a lot of interaction between each and every drug whenever there is a polypharmacy. And if you can see here, at least 4 drugs, antiarrhythmic drugs at one time point this patient is on. So this is not good. You cannot continue these patients on these many drugs. So this case was taken unlike the previous case where radiofrequency ablation was done. In this patient, cryoablation, we took the patient for cryoablation. The only difference is radiofrequency is a hot therapy, cryo is a cold therapy, and it's a balloon-based therapy. Only advantage is it's little shorter procedure for us, and it gives confluent lesions. Like 4 PVs, you go into 4 PVs, you isolate. The isolation is much quicker and easier. Even for the operator, it is little bit easier. So what you do, you go, you inflate the balloon, you make it sure that there is no leak from the pulmonary veins, and with the ICE guidance we do it with the intracardiac echo guidance to make it sure that the seal is good and there is no leak, and you put behind one esophageal probe just to make it sure that the temperatures are not going very low. And while doing one of the pulmonary vein isolation, right superior pulmonary vein isolation, there is a persistent atrial fibrillation. You can see that it has been terminated nicely, and post ablation you can demonstrate, this is the termination, and you can demonstrate that all the 4 pulmonary veins are neatly and nicely has been isolated. And most important thing is your number of drugs has come down along with diuretic. He didn't require diuretic after that because there's a heart failure has come down in this patient. He has finished 14 months of follow-up without any recurrence and has improved quality of life. So when we talk about the real world data on the comparison of patients in whom we are doing a pulmonary vein isolation versus pharmacological management, there is a superiority in terms of improving. There is a trend towards improved survival, improvement in the quality of life. There is an improvement in ventricular function, and there is reduction in the heart failure hospitalizations in this patient. Now, I'm repeatedly talking about what are the uncorrectable, correct the comorbidities. It's very important to take care of the underlying diseases. What if I'm not able to take care of the comorbidities? You have uncorrectable comorbidities. We are all aware of the patients who are having a chronic kidney disease on dialysis, and I cannot reverse this. This is an uncorrectable comorbidities. Patient has a COPD, like last case Dr. Mallav showed. This patient had a bad lung disease actually. Cor pulmonale, I cannot correct that. So that trigger, that substrate doesn't go away. I cannot take care of that substrate. So these are difficult to eliminate substrate. So the real world data says that the patients with the severe comorbidities, we cannot correct the comorbidities. The recurrence of pulmonary vein isolation is very high and the outcome is not good. So what to do in these patients? We have to get rid with just a rate control therapy. But how to do that? With the optimal pharmacological therapy, can we achieve a very good rate control in these patients? Can we achieve almost perfect ventricular rate control in these patients? And what do you mean by a perfect rate control? This, because we all are aware when we give a lot of pharmacological drugs to these patients, you may see one time point rate is very good. And when you do extended monitor, some point they'll have a long pauses, and immediately after few minutes they'll have a very fast ventricular rate. So with these drugs you cannot achieve a perfect rate control. When they sleep at night they may have a very long pauses. So what are the options you have in these patients? So next option you have is, which Dr. Mallav showed a case, is pace and ablate strategy. With this, what happens if I pace and ablate, like I've given a pacemaker and I've disconnected the upper and the lower chamber. So what I have done, I have regularized the RR interval so that there is an adequate filling and adequate emptying of the ventricle. This improves the outcome of these patients, and you can come down with the number of the antiarrhythmic drugs you are giving to the patients. So there is a data on the AV junction ablation and RV pacing. It's going on since last more than 2 decades. Why didn't it come in a very big way? The reason of it not coming in a very big way is we know the detrimental effect of only doing RV pacing, because if you do RV apical pacing or RV septal pacing, there are chances of pacing induced cardiomyopathy, and there is a real world data shows that up to 50% of these patients may have pacing induced cardiomyopathy. So now you are going back to your problem. That's the reason. The role of what he showed, instead of doing the RV pacing, you can consider either BiV pacing, that is CRT pacing, or you can consider nowadays what we have, a conduction system pacing. Similar to the previous case which Malav showed, there is one more patient who was during the COVID, he was admitted. He had a persistent AFib going on since more than 5 years, but during COVID he had a bad pneumonia. He was in hospital for more than 1 month and he was in cardiogenic shock. He was on amiodarone infusion, digoxin, inotropes. We were not able to manage him. He was in NYHA class 4. So this patient had a severe LV dysfunction. So if you can see this video, I think it's running. Yeah, you can see the rate in this patient going on. So this patient was actually almost taken up for emergency AV junction ablation. So this patient, we have given a conduction system pacing lead and immediate AV junction ablation done. His EF improved because it's an arrhythmia-induced cardiomyopathy. And you can see now it's a narrow QRS, unlike the RV pacing wide QRS. You don't need CRT in this patient because you know it's an arrhythmia-induced cardiomyopathy. You don't need defib lead in this patient. You can get rid with the simple pacemaker in this patient and the outcome improves. So already there is a real world data. This is a very good trial, which is a randomized control trial in these kind of patients of a permanent atrial fibrillation with refractory heart failure, which were compared in these patients. CRT and AV junction ablation was done, that is BiV pacing, which showed improvement in all cause mortality, heart failure related mortality and decrease in heart failure related hospitalizations. This is my last slide. So what are the key points? Treat underlying precipitating causes aggressively, including the comorbidities in the patients who are having atrial fibrillation. Try for early rhythm control because AFib begets AFib. Don't push patient towards a permanent AFib because the outcome is very bad in those patients. If there are no comorbidities, consider for early intervention, pulmonary vein isolation. It may be radiofrequency based, or it may be you can do cryoablation, which are better than the real world data says that the outcome is better than the pharmacological therapy. If there are uncorrectable underlying diseases and the patient is highly symptomatic, you can consider for pace and ablate strategy. Patient is already having a CRTD and having atrial fibrillation, you can just ablate the AV node so that you can decrease the number of medications in these drugs. Last but not the least, any patients who's going for surgery, either for valve surgery or for bypass, and you feel that patient is already having atrial fibrillation, can consider for surgical ablation in these patients. Thank you.
Just wanted to know whether we can predict which patient is going to develop like a cardiomyopathy.
So this is actually difficult, whenever you have a heart failure patient, sometimes we feel that heart failure has led to atrial fibrillation or atrial fibrillation has led to heart failure. One thing, if LV dimensions are not huge, they are mostly the arrhythmia-induced cardiomyopathy. Second, as I already said, that the cardioversion is not only it's not only therapy, but it's diagnostic also. If I perform a cardioversion and patient improves drastically, I know the symptoms are because of the atrial fibrillation and I should be aggressive in treating this atrial fibrillation.
Is there a role for cardiac MRI with gadolinium? For us
Very
to know,
well, yes, especially
whether it is reversible or irreversible?
So there is a data on the atrial fibrosis in these patients, but the problem is to pick up atrial fibrosis in patients with atrial fibrillation is difficult. But yes, even ventricular fibrosis, any patients who has more of a ventricular fibrosis, for example, more than 10 to 15% scar, the outcome in atrial fibrillation is not good in those patients. So yes, there is a data, there's a good data in the role of one is diagnosis also. Many patients like I showed one of the patients, young patient who's having atrial fibrillation roving around as a normal case. So diagnosing the underlying disease also is important. Yes, so you have patients who are going for valve replacement surgery and having a huge aneurysmal LA. So LA reduction surgeries, but I'm not sure whether the outcome of whether the episodes of atrial fibrillation comes down. I'm sorry, I'm not aware if there is a good data available.
Yeah, thank you, Dr. Daljit. Here.
Sir.
Thank you, nice talk. My questions are related to rheumatic atrial fibrillation. One of the common problems is after valve replacement, mitral valve replacement, they start having atrial fibrillation. What are the treatment strategies in them? Do you think this any LA reduction surgery or pulmonary vein isolation along with mitral valve replacement or post-op atrial fibrillation with pulmonary vein isolation or your cryos ablation, are they going to be helpful? Is there any role for flecainide? Is it really helpful?
So truly we don't have a very long-term data and we are already working on it. So we are collecting patients for these kind of patients. The only thing is each and every such case, we are trying to maintain them in sinus rhythm. So as you already said, any patient comes to us with rheumatic heart disease having atrial fibrillation, we tried for rhythm control management. So first thing is we make it sure there is no uncorrectable disease is there. Once we are sure about that, I try for the rhythm control. So rhythm control, we are using flecainide, sotalol or amiodarone. Amiodarone, why is the last choice? Because many patients who are on acetrom, as soon as you start giving amiodarone, INR becomes very high. So it becomes difficult to manage. So I think I have data which I am collecting. We are giving flecainide. Few patients who are not very old patients, LA is not very huge. They are doing good on flecainide. We are continuing flecainide. Few patients are doing good on sotalol. If it doesn't revert, we call them, we do daycare DC cardioversion in these patients. And we are following, I have a data of some 68, 69 patients. So the patients in whom sinus rhythm is maintained, their heart failure hospitalizations has come down, their complications, stroke complications has come down. Already I have a data. I'm trying to jot it out and I'm trying to write it, but few patients in whom we are not able to manage the rhythm, we have done pace and ablate strategy, that is conduction system pacing and AV junction ablation.
If I may, with the permission of the chair, I would like to. Rheumatic AFib is difficult to treat, and one of the things when they come with atrial fibrillation, we have picked up subclinical valve thrombosis. So valve thrombosis sharply increases when they develop atrial fibrillation, number one. Daljit is currently, you got about 20 patients, AV junction ablation. The results, when the atrium is large and you find that the velocities are low, we don't attempt ablation, we just ablate the AV node and put a simple pacemaker. The results are excellent. Surprisingly, the results are very good in these patients. Almost 60% of them come back to sinus rhythm. We didn't expect them to come back. So it's still a process in evolution. It's still we are learning more. And the third group of patients where sinus rhythm really helps is hypertrophic cardiomyopathy. HCM patients, when they develop atrial fibrillation, some of them, I don't know, the important question Dr. Dayasagar Rao asked, which patient developed tachycardiomyopathy? We don't know. But one thing is, in HCM patients, after 4 days of continuous atrial fibrillation, they come with extensive infarction of the septum. Epicardial coronaries are completely clean, but it's diffuse microvascular ischemia. So the prognosis of this patient gets ventricular fibrosis increases because of atrial fibrillation. So tend to be it need not be ablation, but aggressive rhythm control helps in this patient.
Just have one more question. Is it the rate or the regularity that really contributes to the cardiomyopathy?
I think both, because initially once you, because we are learning with this AV junction ablation. Yeah. So once we perform AV junction ablation in these patients, they improve 30-40%. They reach some states. and they remodel to some extent, their EF start improving and all. And once that achieve after 6 to 8 weeks, we try to give rhythm control in these patients. But this question is very pertinent because in the rheumatic patients also, there are few patients who are still in AFib and there are few patients who are maintaining sinus rhythm. Short outcome in these patients, there is no difference in the outcome of these patients in whom sinus is maintained with regular rate and in whom AFib is still there with a regular rate. So I think there are a very short group of patients in whom with regular rate also AFib they are not tolerating. And one of those patients are, I think, who are having a very high pulmonary venous hypertension. For example, that mitral valve intervention is done very late. So there are some lung changes already. So for them, atrial kick is very important. But vast majority, they do well.
Yeah, Dalit, there is one patient interesting. This patient has a double valve replacement. It's a item size is almost normal, and he has repeated episodes of atrial tachycardia. It's a regular tachycardia, rate of 180, 200. During tachycardia, the LVEF is falling, but with cardioversion, he is coming to sinuses. But we are not able to maintain on drugs. But for some time, he is going on with drugs with sinusism. Again, he had recurrence twice. What do you do for that patient?
So yes, well, we can have a debate that we can consider RF ablation for this patient, substrate modification, but longer term outcome like over 2-3 years, I'm not very sure. So other thing is if patient wants like one time point solution, I always tell patient these two things. I always tell, because as you said, it's not atrial fibrillation, it's a LA flutter, which is a regular flutter, and we can map and try to ablate it. But atrial fibrillation is a progressive disease. DVR itself is a disease. It's not a normal heart. We are not sure that whether he or she will maintain this over next 5 to 10 years. So as soon as you tell the patients that we will ablate, but we are not sure that after 3-4 years again he'll go to atrial fibrillation. So if they accept that no, we don't want any device, we don't want any more hardware, we should consider ablation. We don't know the answer for how long they'll maintain. We can consider ablation for those kind of patients. But the patients who have financial problem, who want one-time solution and who are okay with the device, better to consider device and do AV junction ablation. That's what strategy we are using now. That's what, it's an arrhythmia-induced cardiomyopathy. So we have to do something, either ablation or pace and ablate strategy.
Daljit, it was a very good talk. One question I have is in people with multiple comorbidities, after a successful ablation, what is the anticoagulation protocol you follow? And how do you look for the recurrences in between?
So anticoagulation protocol depends upon CHA-DVASC. So if the patient's CHA-DVASC is more than equal to 2, patient will need anticoagulation. You cannot claim that we have not reached, as I said, it's a progressive disease, especially non-valvular old patient. Patient will need life. If CHA-DVASC score is more than equal to 2, patient will need anticoagulation. Whereas if CHA-DVASC score is less, we give for 3 months because we have done ablation in LA, and then we can again repeat halter for like a week or so, make it sure that there is no AFib, and patient can be off anticoagulation. Whereas rheumatic and HCM patient, they need anticoagulation lifelong.
Yeah. So thank you everyone, and thank the speakers and the presenter for a nice discussion. We'll close this session now.
Thank you, faculty and the audience. We will have a short break of 5 minutes, tea break, and then we'll back.
See these two slides I want to hide.
We'll start with the session 7. I request chairpersons Dr. Sai Satish, Dr. Arundhati and Dr. Rajshekhar. Please join us in the dais. I call upon Dr. Vijay Shekhar to come. Dr. Sonali is not joining us due to unforeseen circumstances.
Very warm good evening to all respected teachers, senior colleagues, and friends. So, first of all, I would like to thank my mentor Narasimhan sir for having me here. And my topic is on newer advances in electrophysiology. So, probably through the next 15-20 minutes, I'll just show what has happened over the past last decade. Which of the innovations have created a major clinical impact and what is likely to have a bigger impact in the years to come. So I may have left a few, but these were the ones I thought had good clinical impact. So we have come a very long way from like almost 1901, where the first ECG recording, you see how cumbersome this procedure was. And now we have digital recordings where the Apple Watch or smartphones can record ECGs and provide us ECG tracings. So most of the invasive EP work has happened over the past 5 decades, and not to mention some of the pioneers who have contributed significantly to the development of EP in the late 60s and 70s. So for the sake of talk, I have just divided the advances in the management of bradyarrhythmias and then the management of tachyarrhythmias. So I will start first with bradyarrhythmias. So now the standard of care is to give the transvenous pacemakers, that is pacemakers that have a battery unit and then the leads that are positioned in the right atrium and the right ventricle. Now what has happened over the few probably last 5 years is, one is the conduction system pacing, that is completely revolutionizing the pacing mechanisms and technology, and the second one is the leadless pacemakers. So now what is conduction system pacing is that we all know the conventional pacing is when we position the lead at the RV apex or in the septum or in the right ventricular outflow tract. So that is, we are stimulating the endocardium. But what the conduction system offers is a more physiological pacing, either by directly engaging the His bundle or by the left bundle. So this offers a more physiological pacing method. So just to go back and see how this conduction system pacing has evolved over time. So this is a concept not very new. It was started almost in the late 70s. There was this proof of concept of His bundle pacing was present. And then the first human His bundle pacing was done in 2000 by Deshmukh and colleagues. And since then, it has slowly gaining importance, and only after conduction system pacing adapted to left bundle pacing in 2017, it has made tremendous progress. So initially it was only considered as an alternative to the conventional pacemakers, but now we are finding increasing indications for conduction system pacing in the form of CRT as an alternative to cardiac resynchronization therapy, as well as AVJ and CRT that was highlighted by the previous speakers. So what a brief description of what this conduction system pacing means is that we have specialized sheaths as well as leads. Through these leads are lumenless, in contrary to the routine conventional leads that have a central lumen, and with the help of these preformed sheath and the leads, they are directly penetrated through the septum and they reach the left bundle or the His area. So these leads have now been approved by the US FDA for His bundle in 2018, and the more recent approval for the left bundle band pacing in 2022. And we do have another host of other sets of leads, namely the stillet driven leads that again have the preformed sheaths as well as specialized leads to able to capture the conduction system. So how is it being done? The procedure is very similar to that of a pacemaker implantation. The only difference is we find exactly where the His bundle is and then either screw the lead either exactly at the His bundle if the patient is in need of a His bundle pacing, or just 1.5 to 2 centimeter below the His bundle location to capture the left bundle. Now left bundle, because of its technical ease and a shorter learning curve, has superseded His bundle pacing, and more often now conduction system almost means a left bundle pacing except in few selected cases. Now after conduction system pacing was found an effective alternative to RV pacing, it had expanded its indication because it was an effective alternative to CRT. So CRT is generally offered for patients who have a baseline left bundle branch block and refractory heart failure. And because by conduction system pacing we are able to correct the left bundle branch block, this has become an effective alternative for patients who are candidates for CRT. So it was again proved in multiple studies that CRT and His bundle pacing or the left bundle branch pacing is able to effectively restore the electrical dyssynchrony that these patients have. So again, studies have also shown they can be safely performed in patients who are originally for CRT candidates. This left bundle branch pacing is able to correct the electrical abnormality and thereby offer improvement in terms of ejection fraction as well as in terms of symptom relief as well. So this is just one case example showing that the patient, you can see that there is a severe LV dysfunction and there is an apical rocking motion of the LV that shows that it is likely this LV dysfunction is due to the dyssynchrony induced by the left bundle branch block, and there is a baseline left bundle branch block, and this is the conduction system lead we have been discussing that is screwed inside the septum to reach the or capture the left bundle, and here you can see the QRS is narrowed to a great extent. And this is again has been proved prospectively in studies that this narrowing of QRS is also followed by improvement in ejection fraction as well as symptom relief. So now there are randomized data. This was published in the recent HRS that conduction system pacing was compared with the conventional biventricular CRT and has shown promising results. Probably in the years to come, CSP will become an effective alternative to CRT. The other important advancement that has happened in the field of pacing is the leadless pacemakers. There are again the Micra one that is from the Medtronic and the NanoStim from the Abbott. So this leadless pacemakers were approved in 2016, and what these leadless pacemakers offer is through a specialized delivery sheath, the entire unit of the leadless pacemaker, which houses the battery as well as the capture unit, is implanted into the RV septum. So now it eliminates the Achilles heel of a conventional pacemaker, that is, it eliminates the risk of pocket infection and lead related complications, especially infective endocarditis. So in patients who have a risk of recurrent infections, especially of pocket infections, or in patients whom venous access is not available, they may have subclavian occlusion, this is an effective alternative. And now it has progressed from a single chamber leadless pacemaker to a AV synchronous pacemaker, where the device through specific 3D accelerometer can detect atrial signals and synchronously pace the ventricle. So this is how it looks on the fluoroscopy. So these are advantages of leadless pacemakers that we have already been discussed. And the other thing that has come up with respect to bradyarrhythmia treatment is the ablation of the ganglion plexi, which is called as the cardio-neuroablation. So this was earlier described, although in 2014 it has evolved over years, and it's now specifically used for disorders where we feel that there is a vagal hyperactivity. For instance, sinus node dysfunction, functional AV blocks, and vasovagal syncopes. In these subset of patients where we feel vagal hyperactivity is the predominant contributing mechanism, we try to identify these ganglionated plexus. So they are given different names, namely the RSPG, which means the right superior ganglion plexus, then the left superior ganglion plexus, right inferior, left inferior. These are on the left atria. And then on the right atria, we again have the aorta SVC group of ganglion plexus and the other PML group, that is the posteromedial left ganglion plexus. So these plexi may be targeted for ablation and may be helpful in such subset of patients. So this is again a video that shows it's a 3D anatomical mapping where they try to localize the location of ganglionated plexi, and this study that was published in Circulation showed significant improvement in patients who had functional AV blocks. They did not require a pacemaker at all. So this is something that is effectively coming up for bradyarrhythmia treatment. Next, to move on to tachyarrhythmia management. So most of, I think, tachyarrhythmia's advancements have come in the field of atrial fibrillation. Right from understanding the pathogenesis and genetics and treatment aspects, I think most of has been dealt by the previous speaker and in the previous session. So I'll just touch upon or highlight few things that have that needs emphasis. So the long debate of rate versus rhythm control was based on these trials in 2002, the Affirm and RACE, which said that rate control was as good as rhythm control. But if you closely look at the data published from these trials, it was actually not the strategy that was at fault, but the mode of strategy that was adopted to achieve rhythm control was at fault. That is, the antiarrhythmic drugs produced more adverse effects, and so the benefits of achieving a rhythm control was offset by the adverse effects of the antiarrhythmic drugs. So again, now recent data, that is the East AFNet 4 trial, shows that if you are able to achieve early rhythm control by either by antiarrhythmic drugs or by catheter ablation techniques that have been described, then it is good for the patient. So now there is a shift from the rate control is as good as rhythm control to rhythm control is a superior strategy for patients with AF. So this again is again the outcomes of the East AFNet trial. So decrease in CV death, stroke, hospitalizations for heart failure and so on. So again, there are a lot of trials supporting this notion. It is not a single study. There have been a lot of meta-analysis. Either ablation strategies by means of radio frequency ablation or cryoablation have proven to be superior to antiarrhythmic drugs in achieving a better rhythm control and also favoring an outcome for the patient. So the most common modalities currently available are the radio frequency ablation. So the cornerstone of an AF ablation is pulmonary vein isolation, because the most common triggers are the pulmonary veins. So we by either radio frequency ablation or by cryoablation, what we try to do is we try to electrically separate the pulmonary vein ostia from the rest of the left atrium, so that we eliminate the triggers for atrial fibrillation. So again, there have been lot of refinements in how you should perform an RF ablation, whether you isolate only the pulmonary veins or you should give additional lesions. But again, there have been conflicting reports. But again, the most important thing is to get an effective and durable pulmonary vein isolation that is important for the long-term outcome. Cryoablation, I think Dr. Daljit madam had discussed previously. So it is being even offered as an initial treatment for patients with AF. And again, there are studies that tell you, comparative trials with RF ablation tells you that cryoablation is non-inferior to RF ablation. So cryoablation is available in the West for almost more than a decade or so. In India, it is available for the past 1.5 years, and I think people who are using it find it really a very effective tool for patients who have been on long-term AF. We are able to achieve good results with cryoablation. So apart from radio frequency ablation and cryoablation, both of these techniques are not without complications. They are associated with high recurrence rates in specific subset of patients. And again, there is collateral damage in the terms of esophageal injury as well as phrenic nerve damage. So these adverse effects can be offset by the newer technologies like the pulsed field ablation, where this tends to kind of destroy the myocardium by giving high amplitude electrical impulses. So the sarcolemmal membranes are destroyed by electroporation. So this eliminates the collateral damage that was previously created by cryoablation and RF ablation, and it is said to be more tissue specific. Only the myocardium is selectively targeted. The rest of surrounding tissues is usually spared. So I think this again was touched upon by the previous speaker. In patients with permanent AF, if you are unable to achieve a good rhythm control or rate control, doing an AVG plus CRT has mortality benefit. So then newer mapping tools and techniques this has again revolutionized the way we have understood the mechanisms of arrhythmias. The things that we are going to look at is about contact force catheters and newer mapping tools. I just touch upon. So what this has provided for the electrophysiologist is that it has greatly improved the outcomes and the acute procedural success, and it has greatly shortened the procedural duration, minimize radiation exposure and lesser complications like in the previous technology that I have told you, and most importantly it has made us understand the arrhythmias in a better way. So this is again the just a running frame to tell you a contact force catheter. So this is ablations being delivered in the left atrium. You can see that in the top panel there is something that tells you in terms of grams. So it exactly tells you how much contact the catheter has with the myocardium. So this helps you to deliver durable lesions, and at the same time it helps you to minimize complications like cardiac perforation and so on. The other thing is multipolar catheters. Previously ablation mapping was mostly done with single pole catheters. So where these catheters like HT grid or the Pentaray or the basket catheters, they have multiple poles. So what it does is it collects multiple activation points at the same time, thus minimizing the duration of the procedure and also improving the accuracy. So this again has been proven in trials, especially for complex arrhythmia ablation like VT ablation, where identifying the re-entry circuit and ablating the critical isthmus, that is the diastolic corridor, is very important to achieve procedural success. Such multipolar catheters have greatly improved the success rate. So this again is VT ablation strategies using the multipolar catheters. So another thing that has newer mapping tools has offered is localization of accessory pathways to a very pinpoint location. So this is something called as open window mapping, and here so it exactly shows you the direction of wavefront and where exactly the breakthrough point is, enabling us to localize the accessory pathway to a very precise location. So again, more advancements are coming in terms of identifying the direction of the wavefront as well as the propagation of the wavefront. This again is the one on the left panel is the conventional activation map. The other is a velocity or vector integrated maps. It exactly tells you where the re-entrant circuit is located. Yeah. So you can see here, this is the IVC, this is the coronary sinus. So the conventional map fails to show you the re-entry circuit, but here you can see that there is a localized re-entry going on, which enables us to precisely identify the underlying mechanism of arrhythmia. So it greatly shortens the procedure duration and also allows us to give fewer ablation lesions, which is good for the patient. And then another advancement is the zero fluoroscopy procedures or minimal fluoroscopy procedures. There has been a lot of emphasis for both the interventional cardiologists and for the electrophysiologist for the radiation exposure and the hazard. So minimizing fluoroscopy and radiation exposure has become a priority. Both ablation and device implantations have been performed with minimal fluoroscopy with the aid of 3D anatomical mapping as well as imaging. So this is a cryoablation, so where a pre-procedural CT is being done, then during the procedure a real-time intracardiac echocardiography is being done with the help of 3D anatomical mapping. So we merge all these things together and we completely eliminate the need for a fluoroscopy. In fact, many of the Western centers, they don't even wear a lead apron when they walk into the cath lab to perform AF procedures. So this is data from the West again to show that the number of zero fluoro procedures have been increasing with time. So the need for radiation exposure will greatly come down in the years to come. So this again, even pacemakers can be implanted without the need for fluoroscopy. So this again is the video that is showing the yellow, the green wandering point is the point where we exactly want to precisely locate the lead and penetrate the septum. So all these have become possible with the help of pre-procedural imaging as well as 3D anatomical mapping. And for patients who cannot undergo conventional ablation procedures, stereotactic radiotherapy has been advocated. So where a very high dose radiation is being delivered to the area of interest. So pre-procedural CT or MRI is being done. The area of scar or the area of reentrant circuit is being mapped prior to the radiotherapy, and high dose radiation is being effectively delivered at this point. So when conventional ablation is not possible, this is a treatment option. Finally, to the last part of my study, now we have lot of tools to monitor our rhythm, especially after the COVID thing. Many people have started using pulse oximeters on a regular basis and also smartwatches. So they have frequent alerts saying that your heart rate is high, your heart rate is low. So how reliable can we, we can use these devices is that, as you see, these are some of the studies that had looked at how accurate these devices are. The smartphone apps and watches have reasonably good sensitivity and specificity. Most of these tools use something called as the photoplethysmography to detect changes in the heart rate, which is very similar to what a pulse oximeter uses. It just emits light radiations and then looks for the fluctuations in the pulse rate. So if your device has only photoplethysmography, it might give you an alert. But then these photoplethysmography devices have to be equipped along with tachygrams. That is, they should be capable of producing at least a single late tracing, which is there in case of Apple Watch and other watches. So if your device has these tachygrams, then you can be reasonably sure that the rhythm recorded is abnormal. So the final message is that there is a golden rule in cardiology that every 5 years, 50% of our knowledge is replaced by new information. And it especially holds very true for arrhythmias as well. So with this, I conclude probably this talk, if I give after 2 or 3 years, it will be a completely outdated talk. So we'll continue to learn and evolve with newer things. Thank you.
Thank you, Dr. Vijay Shekhar, for an excellent review of the latest developments in electrophysiology. Now I open let's have a brief discussion before we go on to the next topic. If there are any questions from the audience, you feel free to ask them.
Dr. Vijay Shekhar, what are your views of existing hardware to do left branch per area pacing, whether it totally replace the CRT because the leads, they will understand the mechanical trauma, mechanical stress for long term. What are your views on that?
Sir, so there are certain anatomical factors we would like to consider before the patient is candidate for left bundle branch or a conventional CRT. Generally what these patients with left bundle branch induced cardiomyopathy, that is, they don't have an underlying coronary artery disease, they don't have a scar on the myocardium, these patients respond very well to the left bundle branch pacing or the conduction system pacing because we are able to penetrate the septum. But on the other hand, patients with ischemic etiology, lot of septal scars, they don't do very well with the left bundle branch pacing. So in those subset of patients, we have to adapt to conventional CRT or BIV pacing. So on a patient to patient basis, left bundle branch pacing may not completely replace CRT. On a patient to patient basis, we may have to choose which patient will benefit from the CRT or left bundle.
How confident are we in recommending left bundle branch pacing for a patient who's got a complete heart block with a preserved heart? He's got a complete AV block, but he's got a preserved LV function. So are we there? Are we still there that we can just do a left bundle pacing and be confident about the long-term performance of the lead?
Sir, there were few concerns, especially when his bundle pacing was the predominant conduction system pacing model, because the lead thresholds were high and there are unstable thresholds and so on. But I think with left bundle branch pacing, the lead parameters, everything seemed to be stable over time. So we have stable leads, especially if it is a left bundle branch pacing. Of course, we don't have very long-term data, but at least data up to 2 to 3 years are currently available. which is quite promising, that we can be confident enough to offer as an alternative to RVPs.
Dr. Narasimhan, what are your views on this? I mean, what do you...
Daljit is saying something.
Okay.
So the reason is because we are confident, because unlike his bundle, if your threshold goes up, there is a loss of capture. Whereas if you do left bundle branch area, that's why the term left bundle branch area is used. You're going deep into the septum. You're going through and through the muscle. So even if you lost the conduction capture, you have a deep septal pacing. So threshold issues won't be there. So that's why we are quite confident in the patients, unless there is a septal scar or disease septum. So we nowadays, now you are going towards, like, you can use in each and every patient who's having high grade AV.
There are points for left bundle in patient with normal LV function, when the patient is completely pacing dependent. There's not been completely proved where the left bundle pacing would be really helpful. There are some points against left bundle also, like increased pleuro times, and now the paper is suggesting there are some increased risk of TR with left bundle pacing. So those points also would be taken into consideration when you do a left bundle pacing completely. So the TR, I think, is as you go closer, more basal, the incidence of tricuspid regurgitation is higher. As we more try to place the lead more distally, the tricuspid regurgitation comes down.
If good afternoon. If there is no other comment on this, I believe Dr. Sonali Arora is not going to be here, and we can move to recent advances in preventive cardiology by Dr. Tiny Nair.
Thank you. Good evening. Good evening. Thank you. So recent advances in preventive cardiology. You know, the last topic in prevention and in recent advances should have been the first, right? Everywhere you see prevention comes last. Right. Now, the point is, we will talk about 5. It's difficult to choose what should we include in recent advances. What I've done is, I've taken from the year in cardiovascular medicine 2022. This came in Jan in the European Society Journal, and JACC, the editors pick from 2022. All this data is from 2022, so they are recent, they're new. I picked up articles with an idea where they're not just theoretical, where you can try to apply this knowledge tomorrow morning, not tomorrow, it's Sunday, Monday morning when you go to your clinic and see your next patient. And not just that, just we have opened a glimpse of what you see in a bigger picture. We have also done something, is that every topic, these 5 topics, we would go a little background, a rewind to see why we are talking about that, the background and then the new data, right? We start with number 1. And that is pollution in the heart. For a long period of time, we never believed that air pollution, atmospheric pollution, damages the cardiovascular system, and it was never thought to be a major player in cardiovascular diseases, right? Apart probably from smoke, cigarette smoke. Now, this data that came in 2019, this is not new, 2019, Sanjay Rajagopalan and his colleagues from Cleveland wrote this paper in NEJM, where they showed that if you look at 2.5 ppm, particulate matter 2.5 microns, and look at the hazard ratio of cardiovascular disease, you see that as the particulate matter increases, the incidence of stroke and ischemic heart disease clearly increase, right? But the point is, why are we talking about it here in India? It is because of this. Again, same article gives this graph. PM 2.5 pollution levels, India tops the chart. One of the top, right? So it is far ahead China, far ahead global, far ahead US or recommended levels. So we are on top as far as the PM 2.5 pollution levels. And not just that, if you look at the heat map, global heat map of pollution-induced cardiovascular disease, India is in red. So it is important that we learn about pollution-related heart disease. But this is all from 2019, and this is new. This came in 2022 in JACC, talking about air pollution and the connection between unobstructed coronary artery with INOCA or MINOCA, ischemia with normal coronary angiogram, or myocardial infarction with normal coronary angiogram. So your patient has angina or MI, do an angiogram and it is normal, right? So is that connected with air pollution? Because we all see that we are seeing more and more of them, right? We are seeing more and more of them. Angina, we do an angiogram, maybe we are doing more angiograms in normal people, maybe. But look at the data. The data clearly says that if you look at INOCA and MINOCA, this data picked up 287 from a large US cohort who had normal coronary angiogram, but had either INOCA or MINOCA. And then they found that in this group of 287, provocation test was positive in 62%, right? And they found very close correlation between PM2.5 in the area where the person lived and provocation test positivity. So the paper clearly says that yes, the increase in INOCA and MINOCA possibly is related to the increased air pollution that we see. I think it's important in India because air pollution is increasing. So you might say, okay, after all this blah, 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 do we have a way out? Yes, there is a way out. Despite COVID going away, maybe we should still wear our mask. You might say, is there data? Yes, there is data. The use of N95 respirators decrease the incidence of cardiovascular disease. So maybe you might see that all of us keep the masks on as we get out, not maybe inside the hospital, but maybe when you get out. Interesting point number 2. For the first time, we are recommending last benchers can always go to sleep, it's good for your health. Why? Why? Because again, 2019, JACC wrote out 3 major articles, and one of them was this, sleep duration and myocardial infarction. And that time made big news. If you had missed it out, this was 502,000 patient data from the UK Biobank data, 502,625 patient data, right? And when they assessed it in short, 2019, they said that this is it. If your sleep is less than 6 hours, if you have been studying last night for your presentation today, and that had been continuing for some time, all of us do that, the risk of MI increases by 20%. Right? 20%, very clear. So you might say, what is this? In my family, nobody has ever got an MI. Do I really have an increased risk? So they looked into the risk cascade. Look at that first. If you have a low genetic risk and you are sleeping well, you are right at that straight line. Now, second, you have no genetic risk. None of your family members ever had an MI. You don't have dyslipidemia, diabetes, nothing. And you are sleeping less, your risk goes up 1.5 times. And if, unfortunately, you have a genetic risk and you are not sleeping well, oh my God, 2.5 times. Right. So, genetic risk, yes or no? Very, very clearly, lack of sleep is bad for you, me, and everybody. And this is in the same issue 2019, they covered that sleep irregularity in the MESA trial. Data very clearly connects with cardiovascular events. So even if you are sleeping today at 7 o'clock, tomorrow at 9 o'clock, day after tomorrow at 4 o'clock in the morning, then it is not good for health. And also in the same issue, there was sleep duration quality with subclinical atherosclerosis, where they tried to correlate it with carotid intima media thickness. So surely it correlates. But the new data is here. Very, very interesting. This came last year in again JACC. Look at that. Experimental sleep restriction and visceral obesity. Okay, never knew that, right? Interesting. What they did was they took volunteers and put them on a restricted sleep pattern for 4 hours a day for 21 days. And then they shifted them on to normal sleep 9 hours for the next 21 days. And then they crossed over. Long sleep, no sleep. Right. And the data, in short, the central illustration is very interesting, is this. During the period of sleep restriction, their calorie intake went up by 308 kilocalories. During sleep restriction, they gained 0.5 kilogram of weight. During sleep restriction, this is more vital, their visceral obesity, fat, increased by imaging by 7.8 square centimeters. So, you are producing metabolic syndrome. We are producing in our children when we make them competitive and ask them not to sleep at night, right? So, do have a good sleep, right? Go home and sleep. Don't squeeze time out of your sleep. It's not for the patient, but for all of us, perhaps. Number 3. Antibiotic. This you heard in the morning about infective endocarditis. If you remember the first case, it's so very vital, right? And now there's so much of confusion regarding antibiotic prophylaxis and infective endocarditis. In a short summary, they say that in Britain, they've downgraded so much that the newer generation doesn't even know that we have to give infective endocarditis prophylaxis, right? We were all groomed into any short murmur, any MVP, we were on the extreme. Any small defect, we would write amoxicillin 3 grams, 6 hours, 2 hours prior to dental extraction and all that. From there today, we are recommending only for high risk, right? And we are very lax about it because we say what? There is no direct connection between a dental procedure and your endocarditis. Now this data from Medicare data, 7,951,000 patient data, they tried to connect proven infective endocarditis with a previous 4-week previous dental procedure. And the data is huge, unquestionable. And this is what they found. If you look at the infective endocarditis incidence on the y-axis, very clearly, look at that. The red bars are those who got a prophylaxis and the blue bars are those who didn't. So those in this categories did not get antibiotic prophylaxis, had a very significantly higher risk of endocarditis. So people who need it do give endocarditis prophylaxis, very, very vital, right? We still reflexively write for everyone, right? But I see the younger generation, they tend not to right now. If you pick out, this is all in the high risk, moderate and low risk doesn't have risk. But in that group, look at that data. I mean, this is important for all of us, right? Tomorrow morning, your patient would come and say, doctor, can I go for a tooth extraction? If you take just DE or the dental extraction, you see the odds ratio of infective endocarditis increased by 11.8 times. Look at that confidence interval, right? And the p-value is 0.0001. So high risk patients, those who need endocarditis prophylaxis, please make sure that you write an antibiotic so that they don't land up with a severe big problem. Fourth is a very interesting one. It is about, and this is the India ABPM trial, which many of our colleagues and we did it together. This was 27,000 patients, and it turned out to be one of the largest ABPM database from India, the India ABPM trial, right? We learned a lot of things from this trial, but one thing what we learned, which the Westerners doesn't see, is masked hypertension. 20%, 19.3. So 1 in 5 of a hypertensive patient have masked hypertension. Everybody knows what is masked hypertension. It looks like this, right? It's the ambulatory blood pressure record. The green is systole, the orange is diastole. Look at that, daytime. Right, daytime, see, the systolic blood pressure, the diastolic blood pressure is near normal, hovering near that dotted line, right? But at night, significantly increased. That is what is masked hypertension. So this person comes to my office, to your clinic, in the morning you see your blood pressure is normal. You miss out that severely elevated blood pressure. But what we should realize is that daytime blood pressure is mostly sympathetic driven. I'm standing here and talking, right? My sympathetic system is active. You are those who are not sleeping, your sympathetic is active, right? So sympathetic drives the blood pressure maintenance during daytime. But as we go to sleep, sympathetic goes down. It gives a golden handshake to the rest of it. What is it? That is the renin-angiotensin system and the volume status. And that's why we say that the night blood pressure is the best indicator for renin-angiotensin levels and volume status in a hypertensive, right? And we know that very early in diabetes, RAS is upregulated. Okay, and with that data, if you see the IDACO data took out those who had masked hypertension and diabetes and looked at their ambulatory BP. Look at the data, just one thing. Diabetic with masked hypertension at the highest cardiac event rate. Right, so masked hypertension, if you pick up, they have the worst outcome. But the point is, this is interesting. The 10-year follow-up of masked hypertension, if you see, for example, this is male, you see that in the male population, compare with the sustained hypertension, SHT, it is the event rates are almost equal like the standard hypertension, right? So we should not miss it out. But what I had hidden is, yes, women. In women, the event rates are far more higher with masked hypertension. Now, this is almost not highlighted because in the West, Mass hypertension occurs in about 7 to 8%. We have about 19%, right? So a lady with masked hypertension has a risk of cardiovascular disease which is 2.8 times higher, right? And so the next point would be about women. But this is, I'm sure, if you've not read this paper, you've missed out on something fascinating. This is about midlife women and the effect or the trajectory of blood pressure and menopause. Very interesting. Very interesting. This is why it's interesting, because it is just 3,305 patients, women, but follow-up of 25 years. Look at that data. Very, very interesting, right? In the y-axis, you have blood pressure, systolic blood pressure, right? And that straight line is menopause. So you have 10 years prior to menopause for the lady and 15 years after that. So they found that blood pressure in women have 3 distinct trajectories. The top trajectory is called high and slow decline. So you see that it starts from somewhere, 150, 160. So the blood pressure increases, hypertensive. But after menopause, her blood pressure tends to drop. So high, slow decline. Second group, medium, linear rise. It doesn't care about menopause, it goes on rising. But these two are not the focus today. Focus is this, low, accelerated rise, right? Which means till menopause, this lady is fine. And then she gets hypertension. We might say, oh, it's like any other hypertension. I might get at the age of 50, so what? No. This is a group which has a very high cardiovascular event rate. In fact, in this central illustration, they show that if you menopause right center there, so they're not talking about the high rise on top or the medium linear acceleration, but they're focusing today on low accelerated rise. Not just that, they're saying that, see, today a lot of women have early menopause. Why? Because either surgical or naturally, early menopause, right? And that pushes up the cardiac event rate, because at that point of time, they suddenly become hypertensive. And perhaps the target organs which were not used to hypertension suddenly get exposed. It's like an accelerated hypertension and problems come in. And they say even early onset vasomotor symptoms, you don't really need to have a full-fledged menopause, but an early vasomotor symptom also gives you a clue that the blood pressure might increase and the lady might belong to this low accelerated subcategory. We end with the last paper, which is a series of 4 had come together in gaps in JACC, and that is about this. We all know about this one, right? LDL, we have studied and talked about LDL so much, but I've hidden the other part, and that is, yes, now you know what it is. It is LP little a. Now, LP little a is an LDL molecule that is connected by a disulfide bond to a ApoA, right? And that ApoA, if you see, it looks so much like a plasminogen. So that's why we say that when we look at LP little a, it is basically on one side plasminogen, which is that clotting character, and the other side has got LDL loaded, so atherosclerosis. So perhaps this is one that connects atherosclerosis with thrombosis, right? And yes, we did find a lot of important data has come in the last 3 years on LP little a. One of them is that, yes, it is clearly indicative of residual risk. So somebody who's on statin, LDL has come down to 50, we still gets a cardiovascular event. We should think about LP little a, right? We also learned that LP little a is very clearly associated with sclerotic aortic valve disease and progressive aortic stenosis. These two have come in the last couple of years. Now let us see what new data has come in 2022. Now, this is a repeat measure of LP little a and cardiovascular risk. This is in 15,432 patients from Amsterdam. They looked into the central illustration. There is very strong correlation of LP little a with incidence CAD, fine. But that's not the point. Point is, in a 12-year follow-up, they found that 85% of patients, LP little a didn't change. So you have a parameter which will not change but give you an idea of risk. Whether you take statins, whether you take bempedoic acid, whether you take fried food or whatever. So one particular, if you just measure one, it gives you a lifetime risk. So lifetime risk assessment, because 85% of patients over a 12-year period LP little a didn't change. And of course, they found that this change, even in those who had slightly changed, that has no correlation with progression of coronary artery disease. So change doesn't matter. If I do an LP little a for a patient, that patient risk is that 30, 50 or 60 or whatever milligram percent of LP little a, right? So strong correlation, and generally LP little a doesn't change over time, right? Another connection with LP little a is aspirin. People ask us when we talk about LP little a, sir, what is the treatment of LP little a? Does statins have effect? No. What about PCSK9? Yeah, little effect. Inclisiran, good effect. Available? No, it's not available. So, we have very little stuff, right? Niacin is available, but nobody knows whether it's good effect or not. What about aspirin? If you look at the ASPRI RCT trial of about 19,000 patients, look at that. Looks like if you look at the green is MACE reduction, red is bleeding increase. They balance, right? It clearly showed that in the overall population, there was no benefit of aspirin. But when they looked into the genotype of LP little a by two different genotypes, we saw that the green is more than the red, meaning that the green, the MACE reduction, is more than the bleeding. So they've clearly said that while the whole population, aspirin was kind of balanced, in people who had a genetic background of LP little a, they had clear benefit with aspirin. Despite whether LP little a had come down or not gone down, because LP little a doesn't change, the risk comes down. Number 3 about LP little a is this. LP little a and atherosclerotic plaque progression. Right. Now, this is 191 patients of very high LP little a, picked up in Europe and followed up, very clearly showing that if you look at a coronary CT angiogram, in a 12-month gap, 1 year gap, you see there's a progression of coronary atherosclerosis in patients who have a very high LP little a. Not just that, they recalculated that 10.5% increase in plaque volume in 1 year's time, 12 months time, per 50 milligram of deciliter of increase of LP little a. So, not increase LP little a. So, LP little a's amount of 50 milligram correlates with a 10% increase of plaque volume every year. And the last LP little a data, very interesting again, is LP little a, body mass index, and calcific aortic valve disease. We know that calcific aortic valve disease and LP little a are correlated. Now this gives more data. This is 69,000 patients from Copenhagen, Denmark. And look at the data from Copenhagen. This is not data from Copenhagen. This is different data. Now this shows that top 10%, look at that. Top 10% of LP little a, top 10% of LP little a increases hazard ratio of aortic stenosis by 1.9 times. The top 10% of BMI increases hazard ratio 1.8 times. And if you combine both, so if you have a person with obesity and that person has a high LP little a, the risk is increased to 3.5 times. So interestingly, they back calculated the absolute 10-year risk of a 70-year-old person, lady or male, as to their risk. So you take a 70 to 79-year-old male and you look at their BMI, let's say BMI more than 30, significantly obese. Look at their LP little a, more than 80 milligram percent, significantly elevated. You have the lady, absolute risk of 9%, and the male 15%, 14% risk of calcific significant aortic valve disease. So aortic valve disease is related to LP little a, especially that relation is stronger when there is obesity. So, we have talked about the LP little a's connection with aortic valve disease. We have talked about progression of aortic atherosclerosis, about the stability of LP little a value, that it doesn't change over time. We have talked about sleep. We have talked about We have talked about blood pressures. We have talked about women blood pressure trajectories, which are different. And that's it. So all that we tried was have a glimpse at something that might change your practice tomorrow. Thank you for your time and attention.
Thank you, Dr. Tini Nair, for your thought-provoking publications in the last year, the recent terms of cardiology. Now the topic is open for discussion.
Any data from India about the LP little a among Indian population, either hospital based or in general population? What's the prevalence of LP little a?
I didn't get your.
What's the prevalence of LP little a?
Oh, we have no idea.
So
Any
are
data
Indians
available?
more prone or?
No. We have no data because see, LP little a is two things are there. One, it's expensive. Apart from that, the way you measure LP little a matters. If you just measure the one that we measure is in milligram percent, right? Even if you measure that, sometimes that might go wrong because there are so many variants of ApoA connected to the LDL, so that the LP little has so many variants, and how much of these variants account for what disease we don't really know. So Indian data I'm not aware, but if somebody asks today where does LP little a stand, one, it's a single measurement, so we can assess it once in a lifetime to assess a person's risk. Second, incident atherosclerotic disease connection, yes. Aortic valve disease, yes. Residual risk, especially those who are already on high dose statins, yes.
Yeah, I think you said it all right. There are different methodologies. One is measuring the particle number, which is expressed as nanomoles. The other one is total weight of LP little a. Because the total weight which is mentioned can be contributed by LDL particle also. That will show a reduction when you treat them with statins, borderline. But that is not what is measured. The stable therapies where they've done Mendelian randomization studies have shown that it's over a period of decades, it remains stable.
Just a comment about LP little a. Of course, we don't know about the statistics in India, but recently the paper that was read out in European Journal of Cardiology, it shows that about 30% of the American population do have elevated levels of LP little a. And we don't know the correct methodology as of now what we're using in our labs. If you use a proper methodology, I'm sure we will be able to also know what your incidence of LP little a is. Another question about this woman and heart disease is catching those women who have as pregnant individuals hypertension and toxemia. They have a very high risk of developing in future a coronary disease and also bad cardiac outcomes. So we need to catch them and follow them up so that they don't have the high instance of CVD in the future.
Few points about the prevention. You have covered most, but I thought I'll share a couple of my ideas. One is you spoke about the sleep duration. Of course, more studies have to be done, but sleep is related to the melatonin release. If you don't sleep well, melatonin decrease is reduced. Melatonin is the most powerful antioxidant. So there is a correlation, strong correlation in multiple papers, the melatonin levels to the antioxidant status, and that may be the mechanism. And recently, I mean, some of you may be knowing there is a good paper from All India Institute, not yet published properly, but they collected data that the sleep induction through yoga, that seems to be more beneficial in terms of the quality of life. So in middle age, it's not uncommon to get patients in the clinic who complain of insomnia, and sleep deprivation precedes occurrence of myocardial infarction. So probably we should catch them there and teach them. And second point is, while we talk about some of the uncommon risk factors, whether be it LP, small a, vitamin B12 or sleep duration, etc., I personally think all patients with event of acute coronary syndrome should be studied. I'm not talking about the general population as a primary prevention, but a secondary prevention, because these are the patients who will have more recurrent events, like in the morning case that we have presented. So personally, I feel that any patient who comes with acute coronary syndrome, you should look at all these uncommon risk factors, including fibrinogen levels, whatever. And third, general simple principle preventive method, if the mother has coronary disease, the son has very high likelihood of having more severe and premature coronary disease. Because genetically it is there and woman is protected. if a woman has manifest coronary disease, with all the hormonal protection, the son will have higher chance and severe disease.
Thank you.
If no other question. Yeah.
What is the take-home message of LP little one? Should we start aspirin to all patients who have high LP little?
No, not really, because this is just a study showing that the risks come down, but I will not recommend that. One, where will we use LP little tomorrow morning? Right. One, we will use for a person who is to look into residual risk. Let's say a person, we have given him statins, his LDL is down to 50, 55, and like the case we discussed in the morning, has recurrent events. It is possible that we are targeting LDL, brought it down, but his LP little might be 100 or 90, might be very high, right? So there is something we pick up, number one. Second thing is unexplained aortic valve disease progression, number two. Okay, now the point is, if we pick up, what do we do? Practically, our statins have no benefit. Niacin brings down, but we don't know whether it's beneficial, because now they have picked up those old, if you remember, niacin, liraglutide trials, and took out the subsets and found that in every subset where niacin went in, there was significant reduction of LP little. But we are not sure whether this reduction translates to a better cardiovascular event reduction. I mean, any reduction, we don't know. Aspirin, yes, maybe if somebody has a coronary artery disease, he must be on aspirin. If not on aspirin, it is a question of, I don't know, whether absolute healthy person coming today with me with a very high LP little, will I start aspirin? No, I will not start. We don't have data. I think that's all about it. Inclisiran, those who have access to inclisiran, fantastic reduction. I think 50 to 55% reduction of LP little with inclisiran. But I have not used. If anyone has used, sir, it's just coming to India. We are just getting primary flyers. That probably in a couple of months it should be available to all of us.
We thank Dr. Tini Nair and Dr. Vijay Shekhar for their excellent presentation, and we close the session.
Thank you. So now we'll come for the last session of the day. I invite the chairpersons, Dr. M. Srinivas Rao, Dr. Sunita, and Dr. Satish.
Well, we got a very good, interesting session now on amyloidosis and the heart. And we have three speakers today to actually highlight the topic today. That's first one will be by Dr. Chandramukhi, who is going to speak us about echocardiographic diagnosis of amyloidosis. And it will be followed by a very interesting topic in CMR and PET scan in amyloidosis. And the third would be by Dr. Muthaya, who is going to speak to us about the tafamidis treatment in TTR type of amyloidosis. So I welcome the first speaker, Dr. Chandramukhi, to take over the session.
Good evening all. I thank you Narasimhan sir and the organizing committee for giving me this opportunity. Today I will take you through the echocardiographic evaluation and diagnosis of amyloidosis. So to start with, a 53-year-old male who presented with dyspnea on exertion function class 3 for a duration of 1 month. He also had leg swelling, abdominal fullness and loss of appetite. He was a known diabetic but a non-hypertensive. On clinical evaluation, he had signs of congestive heart failure with raised JVP, pedal edema, S3 and tender hepatomegaly. The ECG showed normal sinus rhythm with the borderline voltages and no significant any STT changes. And then comes the echocardiography. We see the parasternal long axis view. The first thing we appreciate is the dilated LA, and the left ventricle is normal sized, but it shows hypertrophy And if we observe the RV free wall, we can also notice the hypertrophy of the RV free wall. So the findings on parasternal long axis are hypertrophy of the LV and RV and the dilated LA. The aortic valve is normal. The short axis view at the level of the mitral valve shows hypertrophy, concentric hypertrophy of all the segments of the LV, and all the segments, they appear to be contracting equally. Apical four-chamber view shows dilatation of both the left atrium and the right atrium. The LV is hypertrophy, and if we carefully assess, we can appreciate the sparkling granular appearance of the interventricular septum, and the hypertrophy of the RV can be appreciated. Both the mitral valve and the tricuspid valve are thickened, and the interatrial septum is also hypertrophied. The assessment of the tissue velocities of the mitral annulus showed that all the E prime, A prime and S prime, they are reduced and they are less than S5, suggestive of significant decrease in the longitudinal function of the LV. And then comes the assessment of the IVC. IVC is dilated without any respiratory collapse, suggestive of plethora. And on assessment of the color Doppler interrogation across the hepatic veins, we can see that there is a systolic flow reversal in the hepatic veins. So, coming to the summary of the two-dimensional color Doppler and tissue velocity assessment, both the ventricles are hypertrophied, atria are dilated, and there is thickened interatrial septum, and there was also restrictive filling pattern. I thought the slide got missed here. There was a restrictive filling pattern suggestive of grade 3 diastolic dysfunction of LV. So these features, they are suggestive of restrictive cardiomyopathy. And then we went ahead and did the strain rate imaging in this case, and we can see that the longitudinal strain of the LV, it is decreased and it is around 15%. And if we carefully look at the bullseye of the strain rate imaging, then we can clearly notice that there is a reduced strain in the mid and the basal segments, and there is a relative sparing of the strain in the apical segments, giving the bullseye, giving the cherry at the top appearance, which is very classical of patients with amyloidosis. So at the end of the echo, we came to a diagnosis with these echocardiographic features of biventricular hypertrophy, dilated atria, thickened interatrial septum, restrictive filling pattern, and this patient also had LV systolic dysfunction, which was mild pH, reduced myocardial tissue velocities of the LV, dilated IVC, systolic flow reversal in the hepatic veins, and reduced average global longitudinal strain with apical sparing, suggestive of amyloidosis. But I want to say that echocardiography is not definitive for the diagnosis of the cardiac amyloidosis, and we have to further go ahead and do the multimodality imaging, making use of the cardiac MR and scintigraphy for the confirmation of the diagnosis of amyloidosis. So this patient was subjected to cardiac MR, which showed the diffuse late gadolinium enhancement of the LV, which is characteristic of cardiac amyloidosis. Further, we went ahead and did the fat pad biopsy of this patient, which showed adipose tissue with vessels showing thickening of the wall by pink waxy material that is suggestive of amyloid deposition, and thus the diagnosis was confirmed in this patient that this patient is having cardiac amyloidosis. Now coming to the cardiac involvement in amyloidosis, it leads to atrial arrhythmias, conduction system disease, and progressive heart failure. Echocardiography is the basic imaging modality for the diagnosis of cardiac amyloidosis, and early and successful diagnosis, it is dependent on the awareness of the sonographer and also the reader of the cardinal features of the disease on the clinical examination. It requires high clinical suspicion and careful assessment of the echocardiography to search for the features of restrictive cardiomyopathy, especially amyloidosis. We all know that echocardiography is safe, it is easily available, portable, can be done at bedside, and it is cost effective, and it provides both hemodynamic assessment and also the assessment of the diastolic function. While echo is not sufficient by itself to definitively diagnose the cardiac amyloidosis, but it is an essential part of diagnostic, prognostic evaluation, and also guiding the therapy and assessment of the response to the therapy. So now what are the red flags in the echocardiographic assessment which point towards the possibility of the amyloidosis? Already we discussed these findings like ventricular hypertrophy, biatrial enlargement, interatrial septal thickness, diastolic dysfunction, which should be at least grade 2 diastolic dysfunction, and significantly reduced annular tissue velocities, and on strain rate assessment, the decreased longitudinal strain. And the key echocardiographic feature is the sparkling texture on two-dimensional echocardiography. And mind you, in such cases, you should exclude chronic kidney disease, because in patients who are having renal failure with end-stage renal disease, they will have such appearance. So you have to be careful to rule out the renal failure in such patients who are having features suggestive of myocardial edema. So when we see these features and there is severe reduction in the longitudinal function of the LV, severely depressed tissue velocities, then you should suspect cardiac amyloidosis. Then comes to the second case, who is a 55 years old lady with progressive dyspnea on exertion and pedal edema. She is non-diabetic, non-hypertensive, and she is euthyroid. She did not have any past history of coronary artery disease. Clinical examination again revealed features of congestive heart failure, and ECG showed low voltage complexes with QS pattern in V1 and V3. Again, coming to the echocardiography, we see that the LV is hypertrophied, LA is dilated, and there we can notice the small pericardial effusion which is present posteriorly. The short axis view, so again it showed that the LV is hypertrophied and there is presence of the pericardial effusion. Four chamber view shows the dilated atria, hypertrophied ventricles, and the thickened interatrial septum. And the diastolic function assessment showed a restrictive filling pattern. The tissue velocity assessment showed reduced myocardial tissue velocities of the LV, including the systolic velocities of the septum and the lateral wall, and the IVC was dilated and plethoric again in this case. So now what are the differentials in this study? So can we suspect hypertrophic cardiomyopathy in this case because of the hypertrophy of the ventricle? But the echo findings are discordant with the low voltages on the ECG. Whether it is hypertensive heart disease, again low voltages go again on ECG, they go against the diagnosis of hypertensive heart disease. And in does this patient have aortic stenosis, that is degenerative aortic stenosis? Usually in patients with aortic stenosis, the longitudinal strain will be normal, and I want to emphasize here that in patients with restrictive cardiomyopathy, especially amyloidosis, there is a frequent, we come across frequently the low flow, low gradient aortic stenosis, especially the paradoxical pattern, and the atrioventricular valves, they will be thickened. So again, we need some further evaluation in this case to come to the confirmation of the diagnosis. Cardiac MR was done, which showed diffuse transmural enhancement of the LV, confirming the diagnosis of cardiac amyloidosis. Serum electrophoresis was normal, and again the gold standard, the endomyocardial biopsy, it showed typical amorphous extracellular congruent stain positive deposit consistent with amyloidosis. Then coming to the case 3, a 72-year-old male, known hypertensive, diabetic. He presented with dyspnea on exertion, pedal edema. On clinical evaluation, he had signs of congestive heart failure with raised JVP, and he also had ejection systolic murmur in aortic area which was radiating to apex. The ECG showed sinus rhythm with left bundle branch block. So the parasternal long axis view, again we can see here that both the aortic and the mitral valves, they are thickened, the left atrium is dilated, the LV is hypertrophied. The short axis view again shows hypertrophied LV, and here we can just make out that the segments of the LV are contracting adequately. The short axis of the aortic valve shows that there are specks of calcium over the aortic valve. The aortic valve is trileaflet and it is thickened, and we can appreciate some restricted mobility of the aortic valve leaflets. And the apical four-chamber view showed that the left atrium and the right atrium are dilated. The left ventricle is hypertrophied. Also, the right ventricle is also hypertrophied. If we see carefully the right ventricular free wall, we can appreciate that. And again, the interatrial septum is thickened. The colored Doppler interrogation of the aortic valve velocities, it was found that this patient was having aortic stenosis, and the peak velocity it was reaching 4. It was just less than 4, and this patient also had aortic regurgitation. So the gradients across the aortic valve, they were measured at a peak of 52 and a mean of 38, suggestive of moderate aortic stenosis. And the assessment of the pH with the help of the tricuspid regurgitation showed that this patient had mild pulmonary arterial hypertension. The diastolic function assessment showed restrictive filling pattern and the IVC was dilated. The tissue velocities assessment showed depressed tissue velocities of both the medial mitral annulus and the lateral mitral annulus. And then coming to the speckle tracking strain rate imaging, we saw that this patient is having LV dysfunction because the average global longitudinal strain was decreased, but there is a patchy affection of the various segments of the LV. They are not uniformly affected, and we can see that some of the basal segments are affected, and there is some sparing of the apical segments of the LV. So what are the atypical findings in this case for aortic stenosis? This patient is having biventricular hypertrophy. The right atrium is also dilated in addition to the dilated left atrium. He had restrictive filling pattern, and the patient had low flow, low gradient aortic stenosis because this patient was having LV dysfunction and the intraatrial septum was thickened. And on biomarkers, they showed that there was significantly elevated NT-proBNP and troponin I. So can we suspect cardiac amyloid in this patient? Yes, we can suspect. So cardiac amyloid may be present in approximately 15% of patients with aortic stenosis. The clinical and imaging red flags for cardiac amyloidosis should be systematically searched in patients with aortic stenosis during the echocardiographic examination. And in this case, TAVR rather than SAVR will be a preferred modality of treatment. And in patients who are having TTR amyloidosis, pharmacotherapy should be instituted as soon as possible. So the red flags pointing towards the cardiac amyloid in patients with aortic stenosis are disproportionate LV wall thickening, LV diastolic dysfunction which is disproportionate to the severity of the aortic stenosis, right ventricular wall thickening, the presence of the pericardial effusion, and biatrial dilatation, the speckled granular appearance of the myocardium, impaired LV longitudinal systolic function which can be assessed by the strain rate imaging, and mitral annulus S prime velocity less than 6 centimeter per second. So when we find these findings, we should suspect cardiac amyloid. These features have been shown to be useful to screen cardiac amyloid in patients with aortic stenosis. And how to confirm the diagnosis? With the help of the multimodality imaging, taking help of the CMR, which shows increased biventricular wall thickness, increased LV mass, and diffuse subendocardial or transmural LGE, and increased native contrast T1 and extracellular volume. Bone scintigraphy can also be done to confirm the diagnosis of the cardiac amyloid. If there is grade 2/3 myocardial uptake, it confirms the diagnosis of the cardiac amyloid. And then serum or urine monoclonal free light chain protein assessment has to be done. If it is present, then it favors the diagnosis of the AL amyloid, and if it is absent, it favors the diagnosis of TTR amyloid. And gold standard endomyocardial biopsy can be done for the confirmation of the diagnosis with the congruent staining. And so this is the cartoon which is showing the various features of the cardiac amyloid in patients with aortic stenosis. I have already discussed this, and these are the various findings on echocardiography which should be looked for patients in whom amyloid is suspected. And if on echocardiography we find that the LV is having normal wall thickness, normal mass, and the atria are of the normal size, septal or lateral mitral annular tissue velocities, they are normal, they are more than 10 centimeters, then cardiac amyloid will be ruled out. And it will be strongly suspected if there is increased LV or RV wall thickness, increased LV mass, restrictive filling pattern, typical apical sparing on the global longitudinal strain, and the annular tissue velocities of the mitral valve, if they are less than 5 centimeters, if there is biatrial enlargement, and presence of the pericardial effusion and pleural effusion, they go in the favor of the diagnosis of cardiac amyloid. So the take-home message is echocardiographic is the basic imaging modality in patients with suspected cardiomyopathies, whether it may be restrictive cardiomyopathy or dilated cardiomyopathy. The left and right ventricular hypertrophy, diastolic dysfunction, impairment of the longitudinal strain with relative apical sparing and valvular thickening, they are the typical pattern suggestive of cardiac amyloidosis. However, echocardiographic abnormalities may be absent or they may be slight at the onset of the disease, and then we have to take help of the other modalities for the confirmation of the diagnosis like cardiac MR and scintigraphy. to confirm the diagnosis. Thank you.
Thank you, Dr. Chandramukhi, for excellent presentation of echocardiographic features in amyloidosis. Before the audience have any questions to get the ball rolling, I just want to point out that you said that you have done a biopsy of the fat for confirmation of amyloidosis. So such kind of confirmation of the biopsy of the fat is only contributed 15% in the case of TTR type, whereas it may be more useful in the case of AL type of amyloidosis. So if you are suspecting TTR type of amyloidosis, the biopsy of the fat may not be yielding much. In fact, one of the best modality of actually screening a patient for diagnosis or pinpointed diagnosis of cardiac amyloidosis would be technetium pyrophosphate, in a patient, because once technetium pyrophosphate becomes positive, that means that is definitely the cardiac amyloidosis of TTR type is there. So that's how we actually proceed. Then of course we have features suggestive or in echocardiography which are near diagnostic features of amyloidosis by actually having certain of the parameters recently described as a regional the relative regional strain ratio, which where we say that apical strain we say, and then we divide it by summation of basal and mid cavity of longitudinal strain. If it is more than one, it's very diagnostic or suggestive, not diagnostic, suggestive of a cardiac amyloidosis. But however, best thing is to do is a bone scintigraphy where technetium pyrophosphate shows positive response in the cardiac muscle. It shows definitely it is a TTR type of amyloidosis and not the AL type.
Correct.
Any questions from the audience?
Ma'am, can you just suggest few red flags? Because through echo, whenever we start do echo, we usually tend to miss the early part of the amyloidosis disease. Because during the early stages, the echo features would be fairly normal, or probably could be a grade 1 diastolic dysfunction with mild thickness of the LV tissues. Can you just enumerate 2 or 3 red flags where we can diagnose them early?
So in addition to the left ventricular hypertrophy, many a time we tend to miss the hypertrophy of the right ventricle. So we have to look especially for the hypertrophy of the right ventricle, and the best window for assessing the right ventricular hypertrophy is the subcostal view, taking help of the M mode. And if it is more than 7 millimeters, then it is suggestive of right ventricular hypertrophy. You can take help, you have to carefully assess the intraatrial septum. If it is thickened, then again it is suggestive of amyloidosis. Tissue velocity assessment you have to do to assess, because it is the early signs in the early stage of the disease, the tissue velocities and the longitudinal strain, it will be decreased. So even if the diastolic dysfunction is grade 2, then if the tissue velocities, they are less, mitral annular tissue velocities, all the velocities like S prime, E prime and A prime, if they are less than 5 centimeters per second, then again it is indicative of cardiac amyloidosis. And as already discussed, strain rate imaging is very important, which indicates the reduced global longitudinal strain with apical sparing and the relative sparing. If we take the ratio of the apical segments as compared to the average of the mid and the basal segments, if it is more than 1, again it goes in favor of amyloidosis. So these are the few things which you have to carefully assess.
How important is probably looking at the stroke volume index and the cardiac output? Should we be routinely doing in the early patients, early suspected patients?
So in patients with cardiac amyloidosis, the stroke volume and output, it may be low even if your LV ejection fraction is normal, because of the diastolic function and the stiff atria, the filling of the left ventricle is impaired, and that's why the output will also be decreased. So again, this will be one of the indicators in the early phase of the disease that your output is decreased, and you can suspect any restrictive cardiomyopathy, or in LV dysfunction, subclinical LV dysfunction can be suspected.
Questions?
Okay, Dr. Chandramukhi, thank you. Now I request Dr. Kavita to talk on CMR and PET in amyloidosis.
Good evening, respected seniors, dear friends. Thank you, Dr. Narasimhan sir, for giving me this privilege to speak in front of this august audience. And this is a small correction in the title. I noticed it only yesterday that it's been PET, but it's CMR and nuclear medicine techniques, because there's not much of PET role in cardiac amyloidosis, at least available in India right now. This cardiac amyloidosis is a condition which has been there for ages, but previously it was thought to be rare, untreatable, fatal disease, and now with new chemotherapy and pharmacotherapy drugs, it's recognized to be treatable and underdiagnosed. And we have some important investigations which have come up in the diagnosis of the early diagnosis of cardiac amyloidosis and also in treatment monitoring too. So as you all know, cardiac amyloidosis is part of systemic amyloidosis, and here that we are targeting at the proteins, insoluble amyloid proteins. So this is a part of nuclear medicine image where we target the biomolecules. And cardiac amyloidosis, yes, we need to type it properly, whether AL type or ATTR type, because both have totally different treatment strategies. So I think you don't need these details about these two types. Only thing is, if untreated, the survival is very less. That's why accurate diagnosis. So the accurate diagnosis and typing of the disease are essential for management. Of course, biopsy is the gold standard for the diagnosis and also the typing, but it's not that easy because endomyocardial biopsy is already, you all know that it is very cumbersome. And fat pad biopsy, and also it's not that easy to diagnose on biopsy. You need a lot of expertise of pathologists for the interpretation and then typing of this cardiac amyloidosis. And cardiac MRI is more specific for light chain amyloidosis, and 99M technetium pyrophosphate or DPT or HMDP scintigraphy is for ATTR. It's almost definitively diagnostic. So endomyocardial biopsy for ATTR is now just reserved for equivocal imaging features or in patients with discordant clinical and imaging findings. So we have come up so long, and this is a small cartoon showing you the different types of how this extracellular volume is expanded with the fibrils, amyloid fibrils, which we are targeting at the images. And whereas with echocardiography, we'll be just seeing at this level down. I mean, where you will have just LV hypertrophy, it will be seen like this. We can't see the extracellular compartment. Whereas when the amyloid deposition is there in extracellular department, that's where we are going to image. And increased on cardiac MRI, we can just simple cardiac MRI with no special sequences. We can just see increased left ventricular wall thickness, and the same thing with echo also, but with special techniques and special sequences of cardiac MRI, we can see the expanded extracellular volume, which are diagnostic of cardiac amyloidosis, and this feature is helpful in treatment monitoring too. So coming to the diagnosis with non-invasive imaging, as the previous speaker outlined, echo is the first investigation of choice, especially when the patient presents with new onset heart failure and we don't have any clue what it is. So echo is the investigation of choice, followed by MRI, especially cardiac MRI with special protocols like inversion recovery imaging, either with and also late gadolinium enhancement. This is for early diagnosis and prognostication too, not only for early diagnosis, but also for the prognostication. However, if clinical suspicion of ATTR cardiac amyloidosis is high, or if cardiac MR or gadolinium are contraindicated due to devices or renal dysfunction, then you are left with only radionuclide imaging with SPECT. That is technetium-99m pyrophosphate, which is the most commonly used tracer in India, whereas in Europe it is DPT, another diphosphonate, and HMDP. These are reserved for Western countries. Because of the cost, we use only technetium pyrophosphate, which has equal sensitivity. And also some PET tracers, they are not yet approved by FDA, so they are not being used routinely, but under experimental stages only. I'll outline them in the due course. So cardiac MRI, yes, excellent anatomy. You can see in this picture. Don't have pointer. You see this thickened interatrial septum, the 4-chamber view, dilatation of the enlarged the atria, the septum thickening, you see the minimum pericardium, even the pleural effusion, everything is such an excellent image resolution you get from MRI. And you need, these are the basic techniques which we need for late gadolinium enhancement. And then T1 mapping is the recent technique, which is in assessment of treatment response and tracking the disease progression. It's been reported, but still require much more validation. Combination of cardiac MRI and pyrophosphate scintigraphy approaches 100% sensitivity in selected patients and may be sufficient to avoid endomyocardial biopsy altogether. However, the diagnostic performance of cardiac MR compared with nuclear scintigraphy, particularly in the detection of early diagnosis of cardiac disease and typing, still not yet been established, because there are no studies which are showing comparison of these two modalities. So coming to radionuclide imaging, we have conventional imaging that is done in any basic nuclear medicine facility across the country, which doesn't require any big equipment, just basic conventional nuclear medicine gamma camera. And then these compounds, bone avid compounds, technetium-99m pyrophosphate. This is also very easily and very cheap radio tracer, which radio labeled tracer, which is available. This is the other tracer, I-123, which is not available in India again. It is I-123 labeled serum amyloid P component. This is another tracer which is used in radionuclide imaging, especially in the in Europe, where they have on-site cyclotrons producing this I-123. This is also done under simple gamma camera, and you need planar images like 2-dimensional images and also cross-sectional functional imaging with SPECT. All that you need to increase the sensitivity is SPECT images, and nowadays we have SPECT CT, both which will increase your accuracy rates. Of course, advanced imaging is with PET, positron emission tomography imaging, tagged with amyloid tracers, which are currently used for Alzheimer's, which is approved indication for the use of these amyloid tracers, which is again labeled with carbon 11. You need to have an on-site cyclotron because carbon 11 half-life is just 20 minutes. And this is carbon 11 Pittsburgh compound. And fluoride label, fluor beta pair and flutamidamol. These are the two newer amyloid imaging tracers available in the market, but it's not been marketed in our country. They are used in research purpose in the West. You may be wondering why I'm not talking about FDG, which is the workhorse in many of the positron emission tomography departments, because FDG, all know, is ubiquitous tracer, goes everywhere. So even a cardiomyocyte picks up FDG. Normal cardiomyocyte also picks up FDG. So it's very difficult for us to differentiate between normal physiological uptake and pathological uptake. That's one disadvantage. Of course, even if we have used that high protein diet and all, it's not very specific for amyloid imaging. And also, with the high clinical suspicion of amyloidosis, if you want to do FDG PET also, it is only the uptake is more in favor of AL type of amyloidosis than ATTR. So FDG is of no use. Never ask for FDG PET for cardiac amyloid diagnosis. Or so this technetium pyrophosphate is an old tracer which was used for bone scan earlier on when MDP was not invented. That's in early 70s, between 70s and 80s, MDP is invented. So before that, they used to use pyrophosphate for the whole body skeletal survey. So it's a very old tracer for new indication now. You see the tracer apart from the bones, you can see the tracer in the myocardium. So this has been there. They used to suspect amyloidosis in this one of the article dated in 74 I found, and there they have shown this image. So there, but it's not been given much relevance, this indication, because further what? So how do we confirm the diagnosis and how do we treat the patient? So it's been left there, but over time it evolved, and then many research papers came and many researchers happened in Europe and America, and they found that the types of ATTR and AL amyloidosis and pyrophosphate being specific for ATTR. So that's all came up in early 2000. So since then, this is being practiced for the diagnosis of ATTR amyloidosis. It's very simple, safe and sensitive. You need not have to worry about serum creatinine, or you need not have to worry about fasting or high fat diet or anything. No preparation required, and very simple, just an intravenous injection and good images. That's all. No special equipment, as I mentioned, and it's all available all over. So that's how we do. We give 10 to 20 millicurie of pyrophosphate. Wait for 2 to 3 minutes for the tracer to clear from the blood pool of the soft tissues, and now you have just a planar image, two-dimensional image. You see the heart over there, and then coming to, this is a SPECT where you see the myocardium, and this is SPECT CT. You can see the ribs, and then you can see the myocardium here. So this is how we get the images in the positive scan. And then interpretation, this is a normal, there's no visualization of myocardium, and here you are seeing faint visualization and little better and much better. So depending upon this is the visual scoring, and this coming based on the visual scoring, we have semi-quantitative evaluation. So we draw ROIs on the contralateral thorax, just like we draw an ROI in the heart and contralateral lung. So here we draw ROI around the heart, and then contralateral lung we draw ROI, and then just calculate the ratio of the counts. So 1 is normal. If it is 1.2, it's equivocal, and 1.7 is definite ATTR. So this is a semi-quantitative analysis. But coming to this is the sensitivity is, the reported sensitivity is almost about, if it is more than 1.5 at 1 hour, it is ATTR with a 97% sensitivity and 100% sensitivity. This is reported in the literature. And then interpretation with the SPECT will be definitely of additional value. This is grade 0, no visualization of myocardium, faint visualization, that is less than ribs. This is grade 1, just equal to ribs, this is grade 2, and more than ribs is grade 3. See, this is 2 and 3, grade 2 and 3 are diagnostic of ATTR. So this is initial studies demonstrated high sensitivity and specificity for DPT to diagnose ATTR, but the same sensitivity and specificity is been reported with PYP also. And this is one multi-center study involving 8 centers across the globe with 1,500 patients. So this is very important study where they say if we exclude AL amyloidosis with all these investigations, if the grade 2 or 3 pyrophosphate scan is reported, then it is 100% specific for ATTR. So this is the result of the this multi-stenting data, and this has a very good reference for carrying on the indication of pyrophosphate scintigraphy in the typing of cardiac amyloidosis. So PET tracers, again I said amyloid specific. So this is a pyrophosphate image, and there is no visualization of heart here. Whereas this is floor beta pair PET CT. You see the myocardial uptake there, and this is the cross section of the same. So axial image, you see the intense uptake in the myocardium. So this is, the diagnosis would be AL type. Fine. So because this is negative and positive. So these are the PET tracers. Hopefully in the coming future we might get them. If not for this, at least for the Alzheimer's dementia, which is very specific. Just a small, just 2 slides, I'll be finishing. This is just a retrospective analysis done in our department. We had 19 patients referred for the scan, and the positivity is 8 and negativity is 5. So we had a follow-up of 6 patients.
Madam,
and
can you please sum up the slides, ma'am?
Yeah,
Just in the interest of time.
Yes, fine. So we had follow-up of 6 patients, and some patients, because the patient's main problem would be affordability for the treatment. So especially in this ATTR positive patients. So in nutshell, early diagnosis and typing of cardiac amyloidosis is critical for optimum management of this more prevalence than expected disease. And then because we have many disease modifying drugs available right now, and imaging plays a central role in identifying the cardiac amyloidosis and quantifying the disease burden, guiding the management. And also, as I already, the caveats with the scintigraphy are SPECT and SPECT-CT are essential. Visual grading may not be helpful for prognostication or response evaluation. One more thing is positive scan does not exclude AL cardiac amyloidosis, because but even that multi-center trial also told, unless you rule out AL type of cardiac amyloidosis, you can't tell that it is 100% specific. So for the reasons not known, so 15% of patients AL also can be positive on pyrophosphate imaging. So it's all, there's no competition between the investigations available, it's only correlation, and then coming to a consensus. So in getting the diagnosis and typing. Thank you.
Thank you very much for a very exhaustive description about CMR and also and also other modalities of diagnostic tools that you mentioned, madam. I just want to add one point that probably you must have probably skipped that in the CMR, but one of the important or very obvious thing that we see in CMR is what is called a dark blood background.
Yes.
That normally when we
Yes.
see late golden enhancement, we see very dark background of the LV cavity, which is very typical of again amyloidosis that described. So this is what I just wanted to bring it to everybody. So
I'm not a practicing, though I'm a certified radiologist, I'm not a practicing cardiac MR specialist, so I didn't enumerate all those findings of cardiac MRI.
So, with the interest of time, I think we should be going to the next session. Our next speaker, Dr. Muthai, is going to speak us about Tafamidis real-world experience. As we all know that so far there was no treatment, definitive treatment for transthyretin cardiac amyloidosis so far. Although a number of things have come into existence now, but of late we have got excellent vertical data from the Tafamidis, the treatment modality, which actually reduce not only hospitalization and heart failure, but at the same time, it also reduces the mortality by almost 30%. So we welcome Dr. Muthai to go ahead and deliver this lecture on this.
All right, thank you, sir. So I'll take around 10 minutes just to show a little bit of experience with this drug and our diagnosis of these patients. So 39-year-old male, progressive shortness of breath over 18 months, blood pressure 98/60, and in CHF. So there's a few clinical prejudices we have when we try to diagnose amyloid, and that's where a diagnosis of TTR is usually slightly different than a light chain amyloid. So one thing that we have found is most of our patients are not the elderly subsets where they're 60 or 70 years, where you're typically suspecting a light chain disease. So TTR can happen in patients at a younger age, and this is one kind of example of that. This is electrocardiogram. You're seeing an atrial arrhythmia, left atrial flutter that is running with a controlled ventricular rate. And this is also another, the sensitivity of having a low QRS voltage is slightly more in light chain amyloid, and it doesn't always hold true in patients with a TTR amyloid. This may be because of the toxicity of the light chain fibrils, but most of our patients have a normal QRS voltage, at least these few patients that we've diagnosed a TTR amyloid. So this is also a small prejudice that we have. The echo of these patients is very similar to what Chandramukhi madam showed, and I'll try to play some of these loops. So you do have this concentric LVH pattern. You do have that intraatrial septal thickening that is typical of a light chain amyloid. You do have very low tissue velocities that madam showed, and this is one of the easy ways that we are able to differentiate a hypertrophic or a hypertensive heart disease from an amyloid are these low tissue velocities. And with the advent of more using of global longitudinal strain, we're able to pick out even better these patients with a apical sparing. So gross diastolic dysfunction, a relatively preserved systolic function, and with this kind of strain pattern, usually we start suspecting amyloid. The MRI here, and I think the last speaker, it's very hard to differentiate TTR and light chain based on MRI alone. You do have the nulling sequences that tell you about the washout, but that only gives you a diagnosis of infiltrative heart disease. It doesn't really tell you that it's light chain or TTR. So, and I don't think there's a lot of information regarding MRI in making a diagnosis of TTR amyloid. So you do see the intraatrial septal thickening, you do see subendocardial LGE, but in evidence you still have an infiltrative disease, and even your parametric imaging, your T1 imaging doesn't really help in this kind of differential diagnosis. Normal workup that we have for an amyloid is usually starts with we don't do this exactly in this order, and I'll show you. Usually our first investigation is a serum free kappa and lambda light chain. We're most interested to rule out monoclonal antibody production. So if that is negative and we still have a clinical suspicion, that is when we work up these patients for TTR amyloid. Urine serum immunofixation are slightly more expensive, so we try to hold on to that investigation. Troponin NT-BNP can help you sort of grade the severity, but it's not going to help you make a diagnosis. So in this patient, clinically it looked like amyloid. ECG had normal voltages. Echo was very much suggestive of amyloid. MRI didn't add much diagnosis, but your kappa and lambda light chains are negative. So this is a typical condition where we would think of a TTR amyloid. And now I think, like madam said, the advent of the pyrophosphate scan has sort of made it easier, but also a little bit more confusing to diagnose this disease. I'm not going to get into I think Madam has spoken a lot about the diagnosis. So one thing is you get two values on your pyrophosphate scan. One is a quantitative value of this heart to contralateral lung ratio, and the other is the grade. Most of these grades 1, 2, and 3, you do see false positives in grade 1 and grade 2, but this ratio is important, and the ratio, the time interval is also important. So you don't want, sometimes you do get false positives when you read the ratios at 1 hour or 1.5 hours. So you need to make sure that it's read at 3 hours. And so this patient had a grade 3 or highly positive technetium pyrophosphate scan. So what do we do? Is this enough evidence? So if you have a positive nuclear imaging and you have an absence of light chain disease, then that is usually enough to make a diagnosis of TTR amyloid. And this is what we did here. And genetic testing is just a sort of additional feature. And the reason why you do genetic testing is to rule out a wild type or a hereditary variant. It doesn't make any difference to the subsequent treatment of the patient. And what we need to understand is our South Asian or Indian data is very limited. So what we are calling as wild type right now may end up to be a different variant in the future. So typically these patients present with a sort of refractory heart failure. They'll have a low BP, they'll have a little bit of diuretic resistance with frequent volume overload. So this man, we did have a CAPD, a dialysis to sort of take him out of the heart failure. And we started him on tafamidis 61 milligrams daily. And usually our approach to amyloid is immediately we do a light chain. If we have a suspicion of amyloid, if light chain is positive, we start working them up for a light chain disease. If the light chain is negative, we directly do a pyrophosphate scan. So you need to, the MRI sometimes is additive, just additive. Even if cost is an issue, we sometimes even just go directly from echo to a light chain and a TTR and a pyrophosphate scan. That seems to be the most cost effective way to reach a diagnosis. Now regarding treatment, so light chain is a sort of it's a chemotherapy that you're going to be providing the patients. On the other hand, transthyretin that you're seeing here, there are multiple molecules. Now tafamidis, what happens is you have it's a stabilizing agent, and what happens is it sort of prevents these tetramers from binding to each other, and this prevents fibril production. So it doesn't actually do anything to the amyloid that is already formed in the body. You are just sort of preventing the amyloid that is formed into depositing and to forming fibril. So it's a stabilizing drug. So after 3 months after starting amyloidosis, so there was the functional capacity was roughly the same for this man. He did have a CAPD catheter that was inserted. There was no further heart failure hospitalizations, but you can see that there is small changes in the strain pattern that was started after tafamidis. So maybe there is a small reduction in the disease, and this is what we saw. This is all a short follow-up that we have for these patients. Now, this is the large trial that was published in 2018, and there's few things to keep in mind, that there are limitations to this medication as well. So it has shown a mortality benefit and a morbidity benefit in these patients. There was roughly 300 to 400 patients that were enrolled in this trial, and it was a placebo. It was a tafamidis versus placebo trial. So these are the good parts of the trial. The parts that we don't know about the medicine is, one thing is we don't know how long the medicine needs to be given. So that is sometimes can be a limitation, especially when we're counseling patients for this kind of medication that is expensive. And the few things I'd like to tell you about the medication is, it was initially available on a compassionate basis. The main thing that we hear about with the medication is the cost, and it is a costly medicine. Pfizer is doing some work with the government of India to try to make it more easily available and for more of our patients. So, but there is therapy for TTR amyloid as it stands. These are the other 3 patients that we have had, that we have diagnosed. And so these are the kind of things that we look at. You can see the ages are not a typical light chain subset. So you have 51, 41 ages. There was a 75-year-old male. And like Madam showed in the first presentation, this 75-year-old male had a low flow, low gradient aortic stenosis. So this is a typical circumstance where you need to think of a DD of amyloid, and that paper from All India which showed that roughly 18% of their aortic valve replacements. When they took a biopsy from the aortic valve, they found amyloid deposits on 18% of their patients. So it's few things to keep in mind when you do see some red flags. And this is the picture that I showed you. This is another patient, but to show these raccoon eyes, especially in light-skinned people, we're able to make this out as a sort of a spot diagnosis in some of the patients of periorbital purpura. Important situations to suspect a TTR amyloid. One is a low flow, low gradient aortic stenosis, sudden onset carpal tunnel syndrome that's idiopathic, or unexplained neuropathy. Last two slides. So I think previous speaker mentioned this, or our experience with this pyrophosphate scan, one, it's more easily available. But the problem here with the technetium scan is you need to understand that there are false positives, and it's very important how these are reported. So if you see a grade 1 or grade 2 scan, the problem here is you do get a lot of false positive, especially with your light chain disease. Even in a grade 3 scan, we have found 2 patients, one with hypertrophic cardiomyopathy and one with sarcoidosis, which ended up being a false positive. So the pyrophosphate scan also has to be used in a clinical context for most of these patients. So you have to add the clinical information and then see if whether a grade 3 scan helps you clinch the diagnosis. So unexplained left ventricular hypertrophy with reduced tissue velocities, weight loss, constitutional symptoms, intolerance to heart failure medications, and carpal tunnel or low flow, low gradient aortic stenosis. So I'll stop here and we can just discuss. Thank you.
Thank you very much for a very crisp presentation, Dr. Mutaya. I know this drug is very expensive, but the thing is there are also other modalities of treatment which are on the anvil, especially patisiran and then inosterol, which are gene silencers. Recently, you must come across with one other very good study, 6 patients who had a almost near cure for this particular disease with CRISPR trial, CRISPR-Cas9 in his gene therapy they are given, and totally reversed the gene in the hepatocytes to reduce the production of this tetramer. Also, we have doxycycline and also more monoclonal antibodies which actually scavenge these deposits in the myocardium and other tissues, but their role is still not yet known. But one thing is, just like a stabilizer of tafamidis, we also have a diflumisal, a anti-inflammatory drug, which is supposed to be also stabilizing this particular tetramer when it destabilizes. There's also some role, but of course it doesn't have any backing up any large study. Is some kind of anecdotal experiences are there where these people who got this TTR type of amyloidosis, who couldn't afford this tafamidis, they were treated with this to some kind of a success. This needs to be further probed because this is a very inexpensive drug.
Thank you, sir.
Any questions and comments? One question from this audience. If there's no more questions, I think this session can be closed. Thank you very much.
Thank you.
Thank you all. We'll have our next session in Westin, followed by dinner tonight, 8 p.m. So, wish to see you there, please.